शादी करो भी। Very good morning. We start with our first session of the day, trauma. We have our chairpersons, Dr. Manju Meena and Dr. Raguraj Hegde. Good morning. And I invite our first speaker, Dr. Namita, for her presentation.
Good morning, everyone. I invite our chairpersons for this trauma session, Dr. Manju Meena, Dr. Raguraj Hegde, Dr. Tarjani Dave, Dr. Samir Mohapatra, Dr. Amit Maitre, and Dr. Ritwija Thomas. To moderate the session, I request Dr. Sukhdeep to chair.
So, good morning, everyone. Thank you, OPAI and UKSOS and Dr. Vishal for inviting me here and giving me the chance to present this case. Sorry for my bad throat. So, I'm presenting a interesting case. So, the 19-year-old male presented to our secondary center OPD with the pain, warting, and diminution of vision for the right eye for 3 days, following injury with a iron wire at workplace. There's no history of prior consultation anywhere. So MLC in such cases is very important if it's not done earlier. There's no history of diabetes mellitus, hypertension. And at presentation, you can see that on the ocular examination, he just had PL positive and PR inaccurate. Pupil is non-reacting with posterior synechia. There's a circumcorneal congestion. The inti wound is the sealed, is the paracenter sealed corneal tear, and CTL test is the negative. He also developed cataract by the time he reached to us. There's a hypopyon of 3 mm. You can see this here. And also the anterior chambers has +3 cells, posterior synechia, and fundus as a novulum. So the B scan was done, and B scan suggestive of that endophthalmitis. Along with this, there's a intraocular foreign body, a small part of the intraocular foreign body is visible. As there's a history of the injury with the projectile foreign body, patient have been asked for a X-ray orbit, and the patient presented after 2 days. And that you can see that there's in the inferior orbit, there's a one linear foreign body is there. So patient referred to the main center daily for the management, and at the patient came very next day. But that time the PL was negative. There was a 0 response out of 10. And the CT scan was advised, and CT scan shows that there's in the inferomedial position of the foreign body. So diagnosis of zone 3 perforating injury, traumatic endophthalmitis with intraocular and orbital foreign body with retinal detachment and self-sealed corneal tear was made. So the dilemma at that point, because the patient has PL negative, the subtenon fluid was also there, and there's a large foreign body along with the posterior scleral tear. But we have this dilemma that should we go for the evisceration, or should we go for the globe repair with the foreign body repair? So patient was young and we took the chance, and what we did is like we did operated this case with our retina colleague. We did conjunctival peritomy. We hooked the inferior rectus muscle and oblique and first localized the foreign body, and then went ahead with the vitrectomy. And the after clearing the vitrectomy, you can see that there's a pale red disc is visible. And after that, once we have done this, we removed with very gentle maneuver, we removed this foreign body externally, and we pulled it downwards first, and then we take it out. It's around 22 millimeter iron nail that came out. And then we sutured the scleral wound with the 560 vicarious suture. And then what we did is like we did the endo laser, and after that we closed the wound at the break. We did the laser, and then we closed the conjunctival, and then the antibiotic is given. So this is the antibiotic injection that given in the last. So immediate post-op, patient was able to respond at like out of 10. He was saying that, but PL is enlarged inconsistent. And then for our surprise, after 2 weeks, the right eye vision improved to 4/60 with aphakic correction of +8. And this is kind of miracle for us. And you can see that there's a still retinal detachment is there, what for which patient is planned for retinal detachment surgery. But at least patient regained the vision, and we are able to save the globe salvage. So twist and turn in this case is that it's a PL negative eye with endophthalmitis with the large perforating post-equatorial scleral exit wound with the large foreign body. And we applied the multidisciplinary approach. And in this case, the turn is that the patient from PL negative turn to the 4/60. So the message is from this case, what I learned, we should not never you should lose your hope, because the miracle can happen anywhere. And this what reminds me that the tunnel rescue thing that happened 1.5 years back, when I think that every high technology, everything failed, and the help come from the very unexpected, the rat miners, and they rescue. So I think sometimes we, as a oculoplasty surgeon, B has a very low threshold for the evisceration. So from this case, what I learned that, at least for me, it's like we should aim more for the globe salvage, and we should have a high threshold for evisceration. And early management is crucial for the good visual outcome in such cases. Thank you.
Thank you, Dr. Namita. Yeah, your point was is very valid, because every time if there is an injury, our purpose is to salvage the globe.
Yeah.
And if there is a chance that the patient has blind eye or something later in future, the patient can be counseled for eye removal, but not in the primary setting. So
Yes.
multidisciplinary approach is the ideal way to handle such cases.
Yeah, the main thing was, the dilemma was this, Manju ma'am, the time till the time of operation, it was like almost going into the pan-off. We could not see the T sign, but subtenon's fluid was there. There was a chemosis that started, and so on the table we took also the consent for the evisceration. That we and we never, because the retina was pale, so we never expect that it like, so something that is something that yeah.
Namita nicely presented and a very well managed case. But what made you do the vitrectomy and see such a case? I mean, looking back, I would have just thought that just take it out and.
No, it was
So
such
what is the
yeah, so it was
reason
that
why you
yeah. So actually it was PL negative. We just wanted initial
no,
motive
probe
was
salvage would have done.
yeah.
But
So
what
but
made you do the
yeah, so
vitrectomy?
that is so it was on a Sunday OT day, and we were like, nay, it's a young guy. We should give the chance. The other retina colleague was also interested in taking the case. He said, okay, ma'am, I will do the cold vitrectomy. And because this wound is quite posterior, will you be able to suture? I said, I will manage with the minimal this maneuver. So I think that time we like thought that why not give a chance? Because I heard that from the people that sometimes the PL negative I can be PL positive, and he's a young guy. So we just wanted to give a best possible management in like in this scenario.
Very well managed.
Yeah.
Anybody else has any questions? We can go on to the next speaker.
Thank you. The next speaker is online, Dr. Pujita. Dr. Pujita, are you here? Dr. Pujita, can you please
Hello,
unmute
can you hear
yourself?
me? Hello,
Are you audible?
can you hear me?
Yeah, you are audible.
Okay, can you see my screen?
Yes.
Okay. Good morning, everyone. My name is Dr. Pujita Ralapalli. I'm a third year postgraduate from Osmania Medical College, Hyderabad. And today I'm here to present a case of globe luxation. The title of my presentation is Lost and Found, the Case of a Missing Eyeball. I'm presenting this case under the guidance of my superintendent, Dr. P. Modini ma'am. Just give me a moment. I'm not able to.
Doctor, just click on the screen. Just click on the screen. You should be able to move the slides. Just click on the presentation screen and roll the slides.
Yeah, I'm trying. Yeah.
Yeah, just move it.
Okay. So globe luxation is a rare condition that can present spontaneously or more commonly following trauma, where there's a complete or partial prolapse of the globe from the orbit. Based on the etiology, globe luxation can be classified as spontaneous, voluntary, and post-traumatic. Traumatic luxation occurs following high-velocity direct or indirect trauma, especially to the head and neck region. It is a rare condition with only 109 cases reported till 2021. Road traffic accidents appear to be the most common cause. Traumatic luxations into the paranasal sinuses is even more rare, of which maxillary sinus is most commonly involved. On the other hand, facial disfigurement due to any cause presents a serious psychological and social challenge to the individual who has to cope with an appearance that is obviously different, hard to conceal, and subject to social stigma. Research suggests that those living with appearance-altering conditions are at a risk of anxiety, depression, stigma, discrimination, social isolation, and suicide. Visible differences to the face may impose particularly complex psychosocial challenges, and disfiguration to key areas such as eyes, nose, and mouth may increase susceptibility to distress. Furthermore, subjective satisfaction significantly influences psychosocial outcomes. With this introduction, I would like to start my case presentation. A 45-year-old male came to the oculoplasty OPD of Sarojini Devi Eye Hospital with a history of being hit by a motorcycle from behind while crossing the road, sustaining injury to the left eye 10 days ago. He was not under the influence of alcohol. Patient experienced a sudden flash of light in left eye followed by complete loss of vision in that eye. There was no history of any loss of consciousness, ENT bleed, seizures, and vomitings. Patient was immediately taken to a general hospital where he was operated for a left eye femur fracture. On ophthalmic evaluation, right eye was found to be completely normal. Left eye showed upper lid laceration involving the lid margin. On parting the lids, the contents of left orbit could not be seen. So here we can see that the patient presented with an apparently empty socket and left eye upper lid laceration. On initial examination, deep space was seen, but no signs of the globe were seen. We immediately took the patient for a B scan. B scan was done, which showed that which confirmed an empty socket with orbital soft tissue edema. CT was done, which showed a left orbital floor fracture with prolapse of the intact globe into the left maxillary sinus. Here we can see that the globe is prolapsing into the left maxillary sinus. Management, the patient was taken up for exploration under GA. On placing the speculum, the globe was seen displaced inferiorly. Attempts to disimpact the globe with muzzle hooks were unsuccessful. Hence, it was carefully twisted out of the floor using an enucleation spoon. Careful inspection revealed that extraocular muscles and optic nerves were still intact. However, the conjunctiva was inserted at 360 degrees of the limbus. A transconjunctival approach was taken to repair the orbital floor fracture using a silicone sheet of appropriate size. A bulged conjunctiva was replaced by AMG and sutured at the fornices. The upper eyelid laceration was sutured in layers using 6-0 Vicryl. On table, this was what we noticed. On parting the lids, we saw that the globe was luxated completely inferiorly. Initially, we tried to hook the muscles and pull the globe out, but this attempt was unsuccessful. So on table, we decided to use a enucleation spoon to just bring the globe out of the maxillary sinus. Globe was placed in the orbit. Here we can see a transconjunctival approach being used to reach the orbital floor. That is, in the second picture, a silicone sheet was used to repair the floor fracture. AMG was being placed for conjunctival loss. Finally, the upper lid laceration was sutured in layers. On post-op day 1, vision was noted to, in left eye was still PL negative. Patient had left eye ptosis. AMG graft was still in place. Cornea was clear. Pupil was mid-dilated and fixed. Extraocular movements, we could see slight movements in all gazes. Patient was placed on these medications post-operatively. After 1 month follow-up, the patient was doing well. AMG was completely taken up. Fornices were well formed. Patient is being followed up for ptosis correction in left eye. However, the vision was still PL negative. I won't. My media is not playing. I'm sorry for that. Extraocular movements were observed about 10 degrees in all the directions. My conclusion is that even though the vision did not improve, the patient was very satisfied and the overall morale of the patient is improved just because the globe was repositioned and the patient was saved from significant aesthetic disability. These are my references. Thank you.
Hello.
Hello.
Yeah. So you used the silicone only for the floor, right?
Yes, only for the floor.
But even the strut also seems to have got damaged. Usually, if the strut is damaged, that is sometimes not enough. So you have to reconstruct the strut also. The inferior strut has to be reconstructed. So in those cases, a titanium floor medial wall plant would be a better. But otherwise, well managed case.
Just wanted to ask one question. When you were depositing the globe in the orbit, did you enlarge the fracture site? Because there must be some sharp pieces of bone around the globe. And
actually, we noticed that the globe was not completely into the maxillary sinus. A part of it was on top of the maxillary sinus. So we tried to remove that, holding that part. We didn't really go into the fracture part of the floor.
Almost in the upper 1/3 of the maxillary sinus.
Regarding the titanium mesh, at that we didn't have availability for it, and this was done on an emergency basis. That is why we had to go for a silicone sheet, because that was what was available at our hospital at that time.
Okay, thank you.
Thank you.
Now we can move on to the next speaker.
Next speaker is Dr. Harika. She's a private practitioner in Vijayawada.
Very good morning. At the outset, I would like to thank the OPAI and the LOC for this wonderful organization and having me here. So now I'll be taking you all through a small story of a facial shearing injury. So this was the female, 24-year-old female who presented to the casualty with a road traffic accident. So while I was planning to how to go about this case, her father ended up in the same casualty with a shooted blood pressure. And their relatives come to me saying that, ma'am, she is the bride to be in the next 20 days. So please do something about it. So then my BP started shooting up. So what best I can give her in the next 20 days. So with all positive hope, this was the primary repair done after a good thorough wound wash and all. So after 2 days of this primary repair, she ended up with this necrotizing fasciitis. So we had sent the pus for culture. We anyway started the patient on IV cefixime and gentamicin to broadly cover it. So serial wound debridements were done. The wound was cleaned on a daily basis. So after a daily wound debridement and all the cleaning and all, so this was the scenario after approximately 10 days of the injury. So somehow we managed to, she was not ready to postpone her wedding. So somehow we managed to make her ready. So all our team was there. We just used to touch up before she enters onto the stage and again get back and do the dressing after that. So this is on her wedding day. So after that, we had to do a skin graft as planned, and the donor site was the retroauricular area. So initially the graft did take up well. This was the suture tasserophy intact, but unfortunately, the twist was this, she developed a very bad granuloma and the scarring, and the lid again started pulling up, and she's having lag of thalamus. So after that, for this, I had to do a repeat skin graft, and fortunately it did took well this time. And the patient, the lag of thalamus improved quite a bit. And then the scar modulation was carried with 5-fluorouracil and triamcinolone acetic acid with the injections. Approximately 5 cycles of injections were given, and the scar did remodel well. And now the patient is doing well without a lag of thalamus. So this was the presentation at the pre, and this was the twist we had. The granuloma was not expected, and this was post all the treatment we have done. So this was a happy patient after 1.5 years. So facial shearing injuries are these type of injuries happen when the skin is adhered to the surface and the force moves in the opposite direction. And the initial management of these injuries would be a thorough wound cleaning with a good irrigation and proper hemostasis and debridement of the non-viable tissue is very, very important. And definitive management depends on the region of the face involved, and we need to consider the crucial structures over there. So my learning points from this case is higher empirical antibiotics. Usually from our aspect, we really don't go to start with higher end of antibiotics at the first go. So it's only after she developed that necrotizing fasciitis, I have started her on linezolid, and the pus culture was also sensitive to it. So my thought process was, if I would have started on that higher end antibiotic initially, I thought maybe that would have been little less severe. That is one learning point from me. And second is, I'm not so sure I would learn from you all whether the irrigation with dilute hypochloric acid at the presentation itself, because we have given a thorough wash only with the povidone iodine and the saline. So would that irrigation with hypochloric acid, would it have been helped a little better? And of course, a close follow-up and early intervention and scar modulation are a process of the treatment. So I would ask the panel if these points, what would have been done better in this case, what steps would have been done more? So in all this story, he's the hero. So he's there right from the casualty to the end. And now there's a happy family with a baby of 3 months. Thank you so much.
Very nicely managed. One comment I would make is that when you did the, how did you conclude that it was a necrotizing fasciitis? Did you?
So actually, once we have opened the patch, we have noticed that the debris was there, sir.
And
so
what day was it after the primary repair?
It was just after 1.5 days. She did not turn up immediately for the patch removal also. It was immediately after 1.5 days. Once we opened the patch, I could see the debris, and we started debridement, but it has got worse for the next 2 days. And after 3 days, it started getting better.
I'm not convinced it is necrotizing fasciitis. I think it's probably it's a wound infection.
So, but all the fascia we have debrided, so it is deep enough for the fascia also.
Even infection also can, fasciitis would have a clear plane where it will go in along the plane, subcutaneous plane. And then you would start seeing the necrotizing on as it's going. I'm not convinced that it is. It could still be, but I'm not convinced it is necrotizing fasciitis. And one more comment is that when you do the free skin graft, it should be as thin as possible because it needs to get the nutrients from the base of the.
Yes. So we made sure that that is very thin.
Another thing is you should probably put quilting sutures so that there is more fixity to the base of the.
Yes. So 2 quilting sutures were put. So it did take up, but that granuloma site was not properly taken.
Other than that, I think other than that, it will be well managed. And of course, the scar modulation you can't start at the same time because you want it to heal also.
Yes, sir.
So you need at least about 3 weeks to 4 weeks for it to have a little bit of the granulation tissue to form. Otherwise, the granulation tissue will not form and you will have a non-healing. The graft may not take up.
Yes.
So anything else? Otherwise, everything very well managed.
Thank you. Sorry. No, that was in the center. It was not really on the margin of the graft. That was a little in the center part of the graft, the granuloma which has happened. It was very localized, yes.
So what was the reason behind granuloma? Because I've seen you use proline sutures.
Yes,
Generally doesn't cause.
Doesn't cause, but even I was not sure. And there also the patient was not on a close follow-up. She came to me after, I think 10 days after that. Okay. So maybe that period, maybe if would have intervened earlier, it would have been better. I'm not sure.
Generally, these cases, what I feel that initially when they present to you, then only you have to start with broad spectrum IV antibiotic because oral, if you start, that's not going to cover the whole spectrum. Yeah. And you expect infection in a traumatic cases.
We did started IV only, ma'am, but somehow I thought maybe higher end antibiotics, if would have started, it should be better. Yeah.
And regarding the use of hypochlorous acid, I don't think it's a good choice to start at the acute phase as a preventive measure. Its role is only for the curative purpose. That's why.
Anybody has any other comments?
I think in such cases of skin infection, IV clindamycin works very well. So you should try using IV clindamycin.
Yes, ma'am. Actually, the pus it was resistant to clindamycin, so that is the reason we have given linezolid for her. The pus culture which we have sent, so that was resistant to clinda. So then we have started this linezolid. Yeah. Yes, sir. Thank you so much.
Invite upon the next speaker, Dr. Soma Sarkar.
Good morning, everyone. Thank you for the opportunity to present today. Today, I'll be discussing the retained foreign body after eyelid repair 2 cases. So let me begin with the case 1. A 46-year-old male who presented with difficulty in closing right eye after injury. Patient had a history of fall and had broken his spectacles 1 month ago, and primary repair was done elsewhere. On examination, base-corrected visual acuity was 6/9 on both eyes. Ocular posture appears normal. Both eyes on eyelid and adnexa, there was a cicatricial ectropyon with scar and firm fill on palpation, and 4 millimeter scleral inferior scleral show was noted, and left eye appears normal. Extraocular movement full and free all the cases. Conjunctiva, anterior segment and posterior segment appears normal. So we plan for wound exploration with ectropyon correction and advancement flap and suture tarsography. And a 15 millimeter broken slate lens material was retrieved during surgery. Post-operatively, vision remained stable. Flaps in place. Interlation of 5-fluid uracil injection given after 2 months for hypertrophic scar, and after 3 months, the suture tarsography was released. This image was taken at 6 months of follow-up, and this was taken at 1 year. So come to the next case 2, a 37 years old male, steel factory worker, history of a trauma by metal object for 4 days ago, and primary management was done elsewhere, and patient came for a second opinion. On examination, the base corrected visual acuity 6/9 on both eyes, ocular posture on left eye there was a hyperglobus, and inferior scleral show was noted. On eyelid and adnexa, on left eye, there was a lower lid swelling at the suture line and intact sutures and heart fill on palpation. Extraocular movement was full and free. There was no diplopia on left eye. And conjunctiva, there was a chemosis was there, and anterior segment was normal, and posterior segment there was a Berlin's edema with vitreous hemorrhage, and retinal hemorrhage was there. On X-ray image shows there is a radiodense structures in epi and lateral view. So we planned for urgent wound exploration and foreign body removal. During surgery, we retrieved a 15 millimeter metal fragment was removed, and postoperatively vision has remained stable, and resolving vitreous hemorrhage with inferior retinal edema. So postoperative fundus diagnosed as a chorioretinitis clopidography, because there is some pigmentation and chorioretinal scar was there. So the key points are a suspicion for foreign body should be kept in mind in patient with periocular injuries. Appropriate investigation and thorough wound exploration should be done in such cases during primary repair to prevent retained foreign bodies. Thank you, everyone.
Hello. In the first case, the lower lid there was a antilamellar deficit. So,
Yes, sir.
so how was it managed? Was that flap?
Yes, YV flap.
It looked like a monopedicle flap and an advanced flap from the medial side. Was it?
No.
From the upper lid?
No, ma'am. We did YV flap because there is a Y-shaped scar.
Upper lid also was edematous at the end of the intra case.
No, sir. No, sir, because the suture is not properly placed. So we.
The upper lid also was edematous in the intra photo that you showed.
Can.
It shows.
Okay.
And the second case was a barrage laser done for the.
Barrage laser, no, sir. We just observe the patient.
Because there's a chorioretinal atrophy.
Chorioretinal atrophy. No laser done, sir.
No, but was it not? Was it advised? Was it indicated by the medical service?
In that area.
For preventive
but
measure, because
there
it is not
is-
involved in the macula.
Because there is no tear, no retinal tear was there.
But these cases, they don't develop acute tears.
Yes,
Over a
ma'am.
period of time, they might.
Yes, ma'am.
So that border of the injury, that is the chorioretinal atrophy, that can actually flake and that actually can cause the RDA.
We explain the patient.
The young patient should be, I think, at least there is a prophylactic measure. Barrage laser would be a better.
On the right, can you shift the slide? Next slide, maybe the post-op.
This intra.
This is intra-op, this one, and this is the post-operative picture.
So how did you manage to lift this eyelid up? So because
we did VY plus T. We released the suture. We released the wound from here.
Okay.
And make a flap. Yes, we did tarsography to make the flap within in place.
Because in the upper eyelid, there is
mild
like
swelling.
there was something done.
Edematous also.
Yeah, edematous and obviously
Because it is
closed
a
eyelid.
post of day 1. Tarsorrhaphy and post-op day one, ma'am. That's why I think. No, ma'am. No CT or no radiological examination was done because we did not suspect there could be a foreign body. That's why we planned for own exploration to evaluate the area.
What was the mode of injury in this case?
Broke the spectacle injury.
And that's quite obvious. There might be chance of a glass foreign body there.
Yes.
History is very important in these cases. Because mode
No,
of injury, duration of injury, history, how it happened, all that is very important. And that gives us clues regarding the nature of foreign body.
Yes, ma'am.
Thank you. We have the next speaker.
Dr. Neeraj is not here. So may I invite upon the next speaker, Dr. Preeti. Preeti ma'am is online. Preeti ma'am, can you please join? Dr. Preeti, you there? Ma'am, are you here?
Yeah, hi.
Hi,
Sorry,
good morning, ma'am.
sharing my screen. Hi, good morning. And I think at the outset, I must congratulate Vishal for, making these last minute changes and accommodating us virtually. It's been a wonderful meeting. I can see that. I'll be speaking on orbital adherence syndrome, which is a very rare complication. And here we are talking about very complex fractures which require secondary reconstruction, especially in patients who have undergone surgeries previously. So in these kind of patients, we use titanium implants because of their preferable properties, but we know that titanium can cause inflammation and fibrosis. And this fibrogenic potential depends on the pore size as well as the density of the pores. So pore sizes less than 250 microns and density of less than 46% has shown to be less fibrogenic. And therefore, the designs of the implants have undergone a tremendous evolution. You can see the old implants compared to the newer ones, which have lesser pore size and a lesser proportion of the pores. Also, other factors take into consideration for the fibrogenic potential. Now, these are important papers that we have seen, which have shown that more the surface irregularities and roughness, more is the fibrogenic potential. And also an important point that I have seen is that whenever you use a plate in the inferior orbital rim, when you reconstruct zygoma, chances of you getting a lid retraction is higher. So whenever you have this kind of orbital adherence syndrome, you have restricted diplopia as well as a lid retraction. Now, solution is adhesiolysis and interposing with smooth surface implant, strabismus surgery, and use of mitomycin, PRF, and 5-FU. Now, here is a very young patient. He had had a zygoma fracture elsewhere. He came to me for enophthalmus. I have done a standardized pre-contoured implant here, but you can see the eyeball has gone up. So I took him up again, and when we explored, you can see the dense fibrosis, the dense adhesions which we see starting from the conjunctiva, tenons, the muscle sheet. Also, these adhesions adhere the inferior lid to the titanium mesh. So you can see now the FDT is still positive. We are releasing some more adhesions, and these adhesions go right up to this mesh. Once we release this, we put a mitomycin C as well as we have done a superior rectus recession. The implant is in position postoperatively, and he did very well. So the causative factor here would be the young age of the patient and presence of a rim implant previously. Now, another patient who had a repair by Fasciomax surgeon, you can see the older design of the implant. And here the implant is inside the inferior rectus. So we have used the new pre-contoured implant here and redid the zygoma. Post-operatively, he did have a lid retraction and we corrected it with a hard palate graft. So here the causative agent must be again the rim implant, the young age of the patient, and we did a mesh exchange. Now another patient, very severe enophthalmos, we have designed a PSI because available implants won't be enough for him. These were the PSIs available from the Indian companies. All of them claim to use medical grade titanium, but post-operatively his CT scan does very nicely symmetry in the bony orbit, but you see the eyeball has gone up. There is severe restrictive diplopia in these patients, and the MRI shows that the muscles are all intact. So these are the fibrosis which is triggered by the surface polishing of these locally available PSI. We had to do these whole range of soft tissue corrections for us to get him to this level. So now preventive measure is that whenever we are doing a secondary reconstruction like this, like he has a malunited zygoma, his anterior projection of the midface is affected. And so here we have designed a peak implant, that is polyether ether ketone implant for the rim. And for the floor and medial wall, I use a coated implant now. So this is a MedPore coated titanium mesh. You can see the pre-placed sutures. I do a midface lift and a hard palate graft simultaneously. His midface has improved tremendously. He had had 4 surgeries previously before coming to us. He already had ptosis correction twice. So we didn't touch the eyelids, and that is planned in a second stage. His midface has improved. We did not get orbital adherence syndrome. So the preventive is use coated implants whenever you have a mesh exchange or you're doing a secondary reconstruction. And whenever we do zygoma, like in this patient, I try to avoid the inferior orbital rim plate. Just try with a two-point fixation and see if the fragment is stable. Another thing is this kind of a patient like this, again, severe enophthalmos. Again, I've used a coated implant. You can see this is a MedPore coated titanium with a peak for the rim, and he does not get adherence. Now, this is an interesting case, the next one, who had a zygoma which was malunited. Now, somebody has used a rib graft here, so the horizontal width of the face has increased. Now, we have to move the zygoma, but I don't want to exchange this mesh because mesh was in place. And so what I did is I cut only the anterior end of the mesh so that it gives me space to move the zygoma. We have used virtual planning and cutting guides as well as drill guides to move the zygoma. And post-operatively, his midface has improved. You can see the midface, which was down and the anterior projection was lost, that has improved. And we did not touch the eyelid. He needs a secondary eyelid correction, but we did not land up with orbital adherence. So whenever possible, avoid a mesh exchange. Now, this was a young girl who had implant 4 times in the past before she came to us. Her enophthalmos was not getting corrected because the size of the available implants is not adequate for her. She needs a PSI. She is young, so I did not want an orbital adherence. I organized for a PSI from a very standardized company. The implant itself costed us 4 lakhs in Indian rupees, but I think the surface and the surface polishing is much better. So inside the orbit, don't use locally available PSIs. And post-operatively, she did well. This was the 5th surgery that she underwent. So these are the few take-home messages that I would like to reiterate today. Use coated meshes whenever you need a mesh exchange or when the reconstruction is a secondary reconstruction in patients who have undergone previous surgeries, and use very standardized PSIs and avoid a rim plate. Thank you very much for this wonderful opportunity, and congratulations, Vishal, for working against all odds and making this meeting a super success. Thank you.
Hello, Dr. Preeti. Yeah, nice cases as always. Everything so very well managed. You are having trouble with the locally made PSIs? With the...
I use the locally made PSIs only for plates like the buttress or the rim plates, but I don't use the locally available for the floor and the medial wall now, because I think the mesh size, the porosity, all that is not taken care of in the local ones. The thickness also, now we have been able to make it sub 1 mm. Now this case was about 2.5 years back. That time they used to make it more than 1 mm thickness. So we had a lot of shortcomings with the locally available meshes, but the plates are all right, I think. And still I don't use the inferior rim plate very often unless I really need it.
So the titanium ones you're using is from KLM Martin or?
Yeah, this last one was KLM Martin, but it's so expensive because it was 4 lakhs for the
I think Synthesis,
yeah,
it doesn't have a titanium, only the peak implant only.
Yeah,
And
that's
Medpore has only the Medpore.
I would
Synthesis
try to have a locally available PSI, but which is coated. Then that would be solving our problem. It would be cheaper also, but still they don't have the
They
PSI.
come with a matte finish. Some of them come with a matte finish. Have you?
Yeah, we've tried all kind of local companies. I think this claim it to be medically grade, but the surface polishing is what is important because I discussed with few surgeons in US, and they say that the finishing they take a few days to do that, and that is the most important point.
Thank you. Thank you.
Hi, good morning. Can I add on to that?
Sure.
Preeti, fantastic cases. Yeah, we face a lot of this because we see a lot of secondary, I mean, we do a lot of secondary reconstructions. So inevitably, we have a lot of scarring, a lot of adherence that we see. One thing that I've started doing for patients who cannot really afford is, I mean, I've done only 3 cases, but I have used X-ray plates. So what happens is once you're lining it with an X-ray plate after doing the PSI, there is no ingrowth that you can look at because there's a barrier that you're forming. I use a cyanoacrylate glue in the just anterior thing, and then I try to place it there. Follow-up is only like 6 months as of now. Okay, the highest follow-up. So I think that is also something which I found useful to do in patients who cannot afford a very good PSI, and we want a nice smooth surface. So that is something that can be tried.
Yeah, exactly. Actually, we also tried to coat the implant with a lot of things, and we landed up 2 patients had very severe infection, and it was MRSA, and we had to remove the peak also, and the cost of the whole thing, the patients are very, very upset. So I don't know, I'm maybe because of my experience with those 2, we tried to line it with various materials. And what happens is there are 2 different materials, one on top of each other, and glue usually doesn't stay for too long, and you have a chance of it moving, migrating somewhere, and I don't know why it triggers an inflammatory reaction, which in turn leads to some kind of infection. So our experience with coating these implants haven't been very good, and I feel even the curvature for which we are really dying, and we are getting customized implants because we want that convexity posteriorly, which goes off if you're lining it with a X-ray film. So I don't know, maybe let's see how your results are. It will be a good chance.
I couldn't do it for the medial wall. It was only for the floor because we cannot give that contour.
You can't curve it like that.
Yeah,
And
we
that's
can't
what
curve
we are
it.
paying for, actually. So that's what I don't know.
Can I make a comment?
Sure, ma'am.
Preeti, obviously, as always, you have got real complex cases. I just have one suggestion. See, when I worked a lot with the neurosurgeons, so there is something which is called a synthetic dura. Right?
Yes, the Duragen. Yeah.
It's made by a company called Surgiwear, and that synthetic dura, maybe you could try and line your implant with that synthetic dura, because that is it's an acceptable intracranial sort of material. So if it's acceptable intracranially by the body, I'm sure intraorbital it will be accepted. That was one point. Second thing, Sonam, regarding your using the X-ray in an orbit, I mean, is it just your own thing or you've done an ethical clearance? Because I really don't know. Because if you work as in a silo, that's all right. But if you're in an institution, you will never be permitted to do this sort of a thing without an ethical clearance.
These are published reports. We have been using it for trapdoor fractures.
No. See, trapdoor fracture is something different.
Yes.
Right?
So same concept we have utilized here. We ETO it and then we have utilized.
All that I understand. My only thing is there a formal ethical clearance that you have taken?
No, it's just the consent forms that we have done. And
consent to patient dega, na?
Yeah. No official ethical clearance has been taken.
I think to be on the safer side, you should get an ethical clearance for this from some
That's a good point.
institution. Any institution where you can approach, I think it would be worth it. It'll put you in a safer bracket.
Absolutely, that's right. Yeah, I think that's a good point. We'll do that. This was just a thing because we were tired. That guy already had 3 surgeries and implant removal. So this was just like on top of it, it was just placed like how we do a double implant sometimes. Something like that we did. But it's a good point. I think we'll take that.
Hi, Sonam, Modini here.
Hi, ma'am.
A very, very innovative idea. And why not silicon sheet instead of X-ray? Because that may be releasing some of the harmful things into the orbit also long term. Why not silicon sheet, a
C
thinner
is
one?
very thin, so that
Thinner
is
one,
better.
thinner one. Maybe we can get customized thinner one silicon sheets if you explore,
Okay.
because they may be using it. Just a thought.
One point I'd like to make here is that what happens is intra-orbital structures are very mobile, right? We need all the eye movements. And when you have 2 implants, one on top of each other, and they don't have the curvatures which are matching, it is less likely for them to stay in place in long term. Secondly, regarding the synthetic dura, yes, what happens is whenever they are setting that material, it is a thermogenic reaction that we wait for. So we have to set it up outside with a 3D model. We also tried that because I work a lot with the neurosurgeons. The weight of the implant increases then. Many a times we don't have enough anchorage here and we are relying on one fixation, one screw fixation, because we know that orbit is not a weight bearing or a load bearing area. So sometimes when this weight increases, we are not able to stabilize the implant very well. So we tried these maneuvers, but of course, I think we need to think over much more and try to come up with a solution for this. But at present, I think layering 2 implants, one on top of each other, especially when the curvatures are not matching, I think the long-term results are a little bit unpredictable.
Yeah, we need to wait. Yeah, I agree. Yeah.
Yeah, there's a lot more to be done in that field. And nothing can mimic nature, I'm sure. Whatever the best possible also will have some differences from nature. But still, I guess, yeah.
So moving on to the next case. Thank you, Dr. Preeti, for the wonderful case and discussion upon it. Dr. Maya Hadda from SMS Middle College, Jaipur.
Thank you, Dr. Vishal, and thank you for organizing the wonderful conference. So I'm going to talk about few masquerades of intraorbital wooden foreign bodies. Decoding traumatic misalignment means they presented to me with the traumatic squint. No financial disclosure. This was a 26-year-old male who presented with diplopia for last 1 year. And you can see that there is a face turn to the left side. It was also associated with the left periorbital pain. On the ocular movements, you can see that the adduction in the left eye is grossly restricted. And in the primary gaze, the left eye is having an exotropia. The MRI orbits were done earlier by the treating ophthalmologist, and you can see the lateral rectus muscle is bulky and hyperintense, and there was some central hypointensity. So he was being treated with steroids for suspected myositis or myocystic sarcosis, but there was no significant improvement in diplopia and motility restriction. And on detailed history, revealed that there was a history of trauma with a wooden stick 1 year back. And I got a CT orbits done for suspected retained foreign body. And you can see that there are multiple hypodensities within the substance of the lateral rectus muscle, which are indicating that there can be pieces of wood inside the orbit or inside the lateral rectus muscle. So I took the patient to the OT and tried the exploration of the orbit on the lateral side. And here you can see that some discharge is also there on the lateral canthus. And I did the canthotomy and tried exploring, but because of the long-standing inflammation, there is this orbital adherence, which we were discussing, developed in this case. And they were very difficult to dissect out tissues over there. And this is the lateral rectus muscle, which I am riddling, and then I disinserted the muscle. And this gave me a better view. And then I tried going more posterior to find out if I can see any pieces. And as expected, you can see some pieces of very disintegrated soft wooden pieces started coming out. And as I went more posteriorly,
there were this necrotic material, some organic thing, might be the covering of the wood or something which has disintegrated over a period of 1 year was coming out. So in the wood, you're never sure that how much is remaining, how much you have taken out. So I kept on exploring, and then I could see a larger piece. And this was a thicker one. And this was the longest piece. And I was sure that maybe I have taken the whole thing out. And I reinserted the lateral rectus muscle again and closed the wound. So these were the pieces that were taken out from the lateral rectus muscle in the surgery. This was the post-op day 3. You can see that the exotropia has improved in primary gaze, and the adduction of the left thigh has also been improved. These are the pre and post-op pictures of the same patient. So this case highlights that wooden foreign bodies in the vicinity of extraocular muscle, it can mimic as myositis sometimes, and they can have a subacute presentation like restrictive strabismus. And because there are inconspicuous imaging features, we have to have a high index of suspicion for diagnosis of such cases. This was my second case, a 22-year-old female. She was referred to me in oculoplasty clinic with this ESO deviation and restricted ocular motility associated with ptosis. To my surprise, her treatment records showed that she had underwent a biopsy from the conjunctiva for suspected conjunctival mass infiltrating the medial rectus muscle. And then the patient was referred to a higher center in absence of any imaging modality over there to get an MRI orbit, because despite doing the biopsy, they could not find anything and there was persistent ESO deviation. So this patient came to my department in the emergency services, and the attending ophthalmologist on call, he saw there was a self-sealed corneal tear and it was Siddle's positive. So he took the patient to the OR and corneal suturing was done. And as a protocol, they got a CT orbits done in all trauma cases. And on the CT orbits, they found there was a medial wall fracture and there was this hypodensity going into the ethmoid and opacification of ethmoid. So then the patient was referred to me for opinion regarding medial wall fracture. And this was the patient. You can see the grossly restriction of ocular movements in this eye. Eye is fixed in ESO. I got an MRI orbit and there was a large signal void foreign body going into the ethmoid from the medial orbit. So I took the patient again for surgery. The case has been operated on corneal tear repair. So you can see the air bubble and corneal sutures just 2 days back. And here, this was the site of previous biopsy, which was taken elsewhere, suspected conjunctival granuloma or mass. So I explored this site, and as I expected, this was the large piece of wood which was lying there. And because it was impacted into the medial wall and there was an open globe injury, I need to be very careful to manage the globe in this kind of large foreign body. And this was the piece which came out from the medial side in toto. And the patient did well. Post-operatively, this was the picture. Improvement in ocular motility was noted. So again, a retained foreign body can present as ocular misalignment with conjunctival granuloma, which can mimic a mass lesion. But in cases of any globe injury, restricted motility, we should suspect retained orbital wooden foreign bodies. Thank you very much.
Actually, whenever there is a globe rupture or a globe tear, along with any other abnormality, either a subperiosteal hematoma that you suspect, in other words, I would say with a dystopia with a corneal perforation or a globe perforation outside of the cornea, a CT scan is mandatory.
Yes.
So whoever repaired the cornea in the first place without doing a scan, probably that was a laxity or what sort, a negligence, I would say. Because a dictum should be that whenever there is a corneal rupture with a dystopia, whether proptosis, ESO, exo, hypo, hyper, whatever, any restriction, any malalignment, please go and do a CT scan. Because trauma can What will go in from where? You'll have absolutely no clue. And many a times, because our fornices are very deep, the foreign body enters the orbit through the superior fornix or the superior medial fornix. Probably this is what happened in this case. It entered from the superior medial fornix, went and got abutted in the ethmoid. Another thing which one needs to keep in mind is that very often there is a base of skull fracture which is associated with this. So please be mindful of the fact that when you disengage, when this bone, this tissue has gone, this foreign body has gone inside, it has done some vectors over there. And you never know when there is a crack in the base of skull. Please be prepared with to face a dural leak, CSF leak from there. And it's not difficult to manage. All you need to do, just in case you get one, just take some muscle tissue from the vicinity, even if it is from the cheek. Tease that muscle tissue, identify where the leak is happening, and for a few seconds, just plug that area with the teased muscle tissue. You will be able to seal a fresh CSF leak.
Yeah. Fat can also be used.
Fat can be used, but muscle adheres very well.
Yes.
Fat does not adhere very well.
Excellently done. But one point I want to say, in such cases, weak cases, my technique is really extend the only thing. Extend the and extend the exposure should be very good.
Yeah.
So the detector, instead of pulling, I generally try to expose as much as possible. Present we are really good nowadays. We can do it. Then it can reduce it because it is putting for a body. We transfer there is some remnant may be there. That's why the exposure in more. Technique is done and doing using endoscopy. It is available. Yeah. And just introduce the endoscope also to see the up to the effects of the.
But yeah, it was a large wooden piece, and when you remove it, you can be sure that you have left it or not. But yes, nasal endoscopy in post-op period can be done to see if any shell or anything is left. Yes.
I have a question for the
Just one remark. Just, in these cases, once you are done with everything, maybe a follow-up CT or an MRI is important, just to make sure that everything is on.
I have a question for everyone. Just in case if such body is explored during you repair the large fractures, so is it wise to go ahead with the implanting the thing at the same time? Or
No.
Wait? How long should
We should not
wait?
put an implant.
So how long should we? No, if there is a large.
See, as long as your periorbita is such that it can't be intact. Your periorbita is obviously ruptured if your fat is coming out and the muscle is impacted. But the periorbita itself will seal that area. So when you remove the foreign body, just check that between the periorbita and the fractured side, you don't leave much. So here comes in the importance of doing a good hemostasis in that area. So you should not leave a hematoma there. That is the only thing which will be a nidus probably for an infection because your sinus is now open. So a sinus clubbing, an open sinus clubbing with retained blood is a culture material. So ensure a good hemostasis, this area will seal by itself. And if you can approximate the periorbita, close it there. Then again, your globe and orbita are a sealed cavity by itself. Then it doesn't matter.
But for the larger fractures, like how long should we wait to re-go 6 weeks?
And during this period, cover the patient up with a fluid antifungus.
Second one is that if, as mentioned, that if you are not sure about that mathematics, maybe again there is a collection. You can put a drainage for 36 to 48 hours. Drainage to this, if there's a less bleeding also, there's a no, you can put a drainage.
Thank you. Our next speaker is Dr. R.V. Moria sir from BHU, Banaras.
Good morning. First of all, I thanks to Dr. Vishal and Dr. Sukhdev for inviting me in this beautiful hilly station and in beautiful scientific program. I shall be talking on the challenging cases of oculofacial trauma. I have no financial disclosure. Written informed consents for use of the photographs and investigation reports were taken from all patients. Ophthalmic trauma is the most neglected, under-recognized, and under-reported ocular disorder causing visual impairment and blindness. Eyes and face are the third most common organ affected by trauma after the hand and feet. Oculofacial injuries are the most common type of polytrauma and major injury. Major trauma, that is injury which can lead to serious consequences. Oculofacial trauma comprises about 30% of all bodily trauma, and about 4% of the oculofacial trauma associated with the globe injury. The periocular lacerations may be simple if it is superficial or is smaller in size. It may be complicated if the laceration size is more than 10 centimeter or extensive avulsion, loss of tissue are associated with the comorbidities. And it may be complex if there is an underlying bony fracture and fracture of the craniofacial bones. The most of the eyelid and periocular lacerations are complex and difficult in managing. Difficulty in the diagnosis. You can know undetected or missed globe injury are not uncommon in many severe polytrauma cases because of the difficulty in examination due to periocular swelling. Visual acuity sometimes you cannot assess, and accurate assessment of the extent of injury also very difficult. Then the treatment difficulties, if there is a lack of trained multidisciplinary trauma team at your center, or if the patient is a poor general condition, or there is extensive loss of tissue, there is difficulty in management. There are some conditions where you will get difficult management, like periodic ophthalmic trauma, or severe grade of the ophthalmic trauma, or concomitant globe as well as adnexal orbital fracture. The challenging cases you can get in any circumstances, like recreational activities, road traffic accident, animal attack injury, fall from height, and assault related injuries. As you know, the recreational games are different types. The low risk or no risk games, moderate or high risk games, and very high risk games like boxing, etc. What about the mobile game? Anyone in audience? Is it low risk or no risk? Yes, here is a case of polytrauma. A child was watching mobile video and while charging the mobile and got a polytrauma with the amputation of the fingers, as well as oculofacial trauma with laceration of the lid, rupture of the globe, and many foreign bodies in the face. This was in CT scan. There is intravitreal hemorrhage and lid laceration, and globe was ruptured, which was managed. So the inference is never use the mobile while charging, avoid overcharging, and keep regular checkup of your batteries. What about the kite flying? Patang. In our northern India, this is common recreational activities. Here is a child who was flying kite on a roof and fall on the asbestos roof. And during COVID, he got retained sustained intra-orbital cranio-orbital foreign body, that is asbestos seized. And during COVID, our OT was closed. So this patient was operated by Professor Abhijit Korman, and there was no visual outcome, but I put the prosthesis. Another patient who was fallen from the roof while catching the kite. And again, you can see there was a large lacerated wound, and private practitioner repaired that wound without doing any CT scan. Patient came to us for periocular swelling. And when we advised the CT scan with 3D, we saw there is a retained intracranial orbital foreign body. This was removed with multidisciplinary approach in 2 pieces, and titanium mini plate and mesh was implanted to restore the orbital volume. And you can see the good cosmetic as well as functional outcome. Then other recreational activity we will see during the Holi and Diwali festival related. Here another boy who was burning the Sutli bomb. And before burning, he put a aluminum glass, drinking water glass. And there was a blast and foreign body goes to the orbit and neozoethmoidal complex and cranial cavity, which was managed with the neurosurgeon. Then travel related injuries can lead to the severe oculofacial injury. There is, you can see the multiple displaced fracture. This was a very interesting case. The person diabetic, severely uncontrolled diabetic, and traveling on the day of Holi, he was sitting in front of the window and got some projectile object clay. And you can see there is a foreign body in the lacrimal sac. And also there was a traumatic mydriasis, which was managed, secondary repair. And another case of road traffic accident, there's a crust injury. You can't identify any tissue. And also there is a loss of globe. So we repair it, thorough on debridement, identification of tissue. Anyhow, we are able to restore the anatomy, but there was a contracted socket. This was a 3-year girl running along with the tractor in front of his door, and he slipped in front of the tire of the first tractor. And you can see there is a avulsion of the craniofacial soft tissue along with the degloving, and there is also fracture of the zygomatic complex, which was repaired with titanium mini plate, and soft tissue repair was done, but there was a mechanical ptosis. The assault-related ocular trauma can also lead to challenging oculofacial trauma. This was, again, a patient having blunt injury with the lathi, and you can see there is a pan-orbital wall fracture, which was repaired with the multiple titanium mini plate, and after 6 months, he has a good cosmetic as well as functional outcome. Then complex oculofacial injury can occur in animal-related injuries like dog, which is very common, and also bear attack. This 3-hour-old infant mother was sleeping in the primary health center, and window was open. Cat came and lead to an oculofacial cat claw injury, which we repaired, but patient is having deformity. Then dog bite injury is very dangerous because of not only due to the injury, because of the dog harbors many microorganisms in the mouth, which can lead to infection. Okay. The management of dog bite, we use the aggressive wound irrigation and selective debridement, anti-rabies and immunoglobulins, and wound repair can be done primarily. And you can see these are the patients which were managed after the primary repair of the dog bite. There was a avulsion of the eyebrows, which I repaired it, and by 5-year fused scar modulation, you can see the good results. This was a very challenging case. This one, there is a loss of total avulsion of the lower eyelid and even half of the upper eyelid. I primarily repaired with the skin graft and advancement flat. And recently I did the double jet plasty to get the opening of the eyeball. These are the beer maul injury, which are very dangerous. And we all manage these cases with the multidisciplinary approach with the craniomaxillofacial surgeons. These are beer maul injuries. Nilgai injury in our country, this is the largest antelope, which can cause there is autoavulsion along with the maxillofacial trauma, and we repair this patient without any regaining of the vision. So finally, I conclude that the commonest etiology of complex oculofacial injuries are road traffic accident, animal attack, recreational activity, and domestic and industrial injuries and assault. Reconstruction of the complex oculofacial defect is challenging, often need to multidisciplinary team approach. Critical assessment of the nature and magnitude of the wound is necessary by doing the CECT, and early intervention with the protocol-based approach of the meticulous surgical repair is mandatory. Public awareness and knowledge about the preventive measure and safety during the travel and sports is mandatory. Thank you for listening.
Any comments? All us well bonded with the presentation that. Thank you, Dr. Moria. Now, our next speaker is Dr. Jayanta Das.
Good morning, everyone. And I just congratulate Dr. Bishal and the entire team. In spite of all those issues in our country, he managed very well and all the delegates to participate. So, as my previous author already mentioned, all those things, this very huge injuries. There is in few months back, there is in our WhatsApp group, there is issues. So that oculoplastic surgeons or ophthalmologists was not in a properly treated, or in multi-specialty hospital, they are generally not giving that due respect in some areas. That why, and I will just explain this. That's why I just discuss with Bishal and just fix it. Okay. Most of the time we are doing very hi-fi work, but at that in other hospitals, this is a reality. I was also ill 20 years in one tertiary care hospital, so did that thing. But moment there is a injury, multi, just a cranial, nose, etc., what to do? Most of the regions, it was hospitals, it was treated by faciomexillary surgeon. The term is faciomexillary surgeon. Everyone attended thought is a faciomexillary surgeon. But if you look at that in a ground reality, they are basically a dental surgeon with a master degree. So that's a big issue. They're dealing not in a proper way. That's why we land up with so many issues in the flexor, etc., malalign, etc. So that's a part. Most of that, there is no such time to think in even big hospitals. I'm working in Apollo. The neurosurgeons, they are very busy their own work, and plastic surgeons. Maximum work is done by the faciomexillary, means dental surgeon. So, and sometimes they are calling me if there is some are busy and that one. So if there is a nose injuries, eye injuries, those are the appointment what to do. And they just repair. That's why we are faced lots of things. In multi-speciality, there is a first is the critical care team. That are term we should that follow all those guidelines of them. Then I think we are the best. I will explain in my next. Otolaryngology, neurosurgeon, plastic surgeon, yes, good. But that our big problem is a faciomexillary, basically dental surgeon. As per the critical care team, we should observe always and we should follow airway breathing and circulation as observation called already. So those we are in the center, oculoplasty. But that the red one, the faciomexillary treated our all maximum our cases. It is not happening in the institute like in Maria Objet. There is a big institute. But in other hospitals, even those good hospitals also, they are basically treated by faciomexillary. So the ideal approach, there's a no nose. If they treat it, so there may be issues in future. So it should be step by step. We can lead oculoplastic surgeon, as we know all, we can repair it, and I will help with the ENT surgeons how we can. There's an eye injury I repaired, that one plating done, and the nose, it was with the even the rubber catheter that ENT surgeons, that one or others, the rice tube. The big size rice tube, that both. Next, I will share one of my cases. It was that faciomexillary surgeon called me. The four that was a nose reconstruction. Then I told, so we will first align the bone, then we just use one rice tube introduced to the stomach for, because this patient is on central line, so for feeding. And next I use is another the tube to just pass. And I always ask if there is no ENT surgeon available on that day or that time. So you just ask, and just to encourage young surgeons to ask, take a help from the anesthesiologist, because they knows the anatomy in details. So they can pass the tube, then later on you can just layer by layer you can close. And after that, it is very nicely we can just observe. Again, regarding the foreign body, Dr. Maya nicely mentioned, it is in our hand, but not only the foreign body. If you look here, not only that, there is other debris, which is the in future it may create as a cellulitis, or there is a scarring, or there is a some problem. So that's one. You can go for a X-ray. That plating also done. From I learned from, we can, without exposing that from the oral cavity, we can explore it then done. So here I am telling, this is my technique. As I already mentioned, once I remove the wooden foreign body, so I just introduce a gauze piece soaked with adrenaline and the normal saline. So it will clean everything, and with that it will, like a fishing net, it will just all others debris also you can remove. Those are the points. As sometimes that the previous treating surgeon thought it is a large, only he is looking, the radiologist also looking only for, it is thought it is a only fracture, but actually on MRI it was fine, it is actually wooden foreign body. So in wooden, if we suspect wooden foreign body, we should go for MRI. So here, if you look, so there may be so many other small foreign bodies may be there. So we can remove it, and then we can put a drainage tube as object mem, so we can take care for the hemostasis. So this is very much important to reduce the future infection, inflammation, etc. The post-op day 10, and then all movements are very nice. All sometimes that neurosurgeons or plastic surgeons, they miss some finding, nicely repaired intracranial injury, but after 2 months there's a corkscrew blood vessels one, and patients are only complaining was Dala Ayek. So then when I examine the IOP straight, it is around 24, one looking up, if there is a more 26, 27, then I just immediately advise the ultrasound, because my clinical diagnosis was CCF. So once you can do, then you can go ahead and there is a CCF. So once it was diagnosed, for the neurosurgeon, it's now it is very easy. On the table, we can do the thing, and coiling can be done. This is the process of the coiling. So, and we can observe immediately there is a red eye to white eye, IOP reduced to 14. So it may, in the admission, it should be. So some of you are working in a multi-specialty hospital. You should not, this is a technical term I'm having for telling for the hidden. So in some hospitals, there's a protocol. So if you are working, so if they ask you to see the patient, in the admission slip, it should be mentioned like that. Otherwise, your whatever your surgical package, it will be half, because you will be as a second surgeon. That's one topic. Someone may be working with some multi-specialty hospital. Here, you please look carefully. If it is a oculoplasty related thing, it may be initially under plastic surgeon, orthopedic surgeon, whatever. But be careful in the admission. It should be then automatically on your work, then your package and your recognition will start. Otherwise, there will be nothing in the discharge sheet also. Initially, I did lots of cases, but in the name of others. So my take-home message is that ophthalmologists may be the first to encounter all, and hope this presentation will just give some solution about that what was discussed earlier in our WhatsApp group. Thank you.
Thank you, Dr. Jayantada. Yeah. So with this, we end this session, and I request Dr. Abhijit Kaur ma'am to felicitate Dr. Rajendra Moria sir, who couldn't be there yesterday. Also to Dr. Jayantada sir. Thank you, the chairpersons. Now we start with the next session. Yeah, before that we will have a group photo. All the speakers and the chairpersons, please.
Yeah, you must put the virtual ones also in the background. स्क्रीन पे लगा दीजिए हमें भी
Zoom वाला लगा देना.
Zoom वाला लगा दीजिए. Thank you. Biggest one.
I invite Dr. Shiv Yogi sir to chair the session. Dr. Praveen Mongre sir, please chair the session, sir. And we are lucky enough to have our seniors to chair the session. Dr. Shalu ma'am. So let us start with the second session of the day, orbit. And our first speaker is Dr. Lakshmi Shankar from LUPI.
So good morning, everyone. I'm Lakshmi Shankar, and on behalf of the Ophthalmic Plastic Surgical Services, LV Prasad, Hyderabad, I'll be presenting this case. I'd like to thank Dr. Tarjini Dave and Dr. Ravi Verma, interventional radiologist, who worked as a team to treat this patient. My first objective is to discuss the clinical features, imaging, and treatment of this patient, and the basics of arteriovenous malformation if I have the time. So this is a 38-year-old male from Andhra Pradesh with right upper lid swelling. So he developed the swelling 25 years ago, but the pain and intermittent headache started 1 year ago. On external examination, facial asymmetry was noted on the right side. On inspection, there was a fullness with visible pulsation seen in the lateral part of the right upper lid, preseptal region, subbrow and location extending to the temporal fossa. On palpation, a firm mass was felt, which was compressible and non-reducible in nature. The posterior extent of the mass was palpable. It had a characteristic boggy appearance, boggy feel, and was warm on touch. The underlying superior orbital rim is palpable and the lesion was not adherent to the overlying skin. So the key findings, excuse me, So I've done the inspection and the palpation findings. So on the key findings which were positive findings, are the visible pulsation, the palpable thrill, and on auscultation, a bruit was heard. There was absence of proptosis, the extraocular movements were unaffected, and then this gave us a clue that this is not an orbital, that this lesion didn't have an orbital extension. The anterior and fundus findings were unremarkable. So at this point of time, our working clinical diagnosis was a right upper eyelid arteriovenous malformation. So our next question was, what is the imaging of choice? So our imaging of choice depends on what kind of lesion it is. And why we do imaging is to look for the posterior extent, the plane of the lesion, and the flow dynamics. So just giving on vascular lesions, how we divide it. So let's divide the vascular lesion into low flow, no flow, low flow, and high flow. No flow means a lesion which is most likely a lymphatic malformation. These lesions would not have any visible pulsation, so we would go ahead with a non-contrast CT or an MRI. Whereas a low flow lesion would be a varices or a venolymphatic malformation. That is, there is flow from the systemic circulation. So here we would go ahead with a non-contrast CT or an MRI. So our case, which is a high flow lesion and which has a direct flow from the systemic circulation, we'd go ahead with an MRI with MRA or a digital subtraction angiography. So this is a non-contrast T2 weighted MRI where we can see high flow void pockets at the temporal fossa. And this is the axial cut, again, just showing the high flow void spaces and shows the location, which is preseptal. Okay, so just going through the clinical and the radiological findings. This is a middle-aged man with history of long-standing slow-growing swelling in the supraorbital region, pulsatile, palpable trill, with flow void spaces on MRI, gives us a clinical and radiological diagnosis of an arteriovenous malformation. Our plan of management was two-staged. One is an endovascular embolization by the interventional radiologist, followed by a debulking by us, the oculoplastic surgeons. So the embolization is done by a DSA guided. So before they do the this is all by Dr. Ravi Verma, of the interventional radiologist we collaborate with. So this is an MRI MIP sequence showing the feeder vessel. So when you do an MRI with where they cut off all the soft tissue, bone, and the only the blood vessels are prominent, you can see a large dilated feeding artery to the nidus. So if you look into the left side of the picture, here is the superficial temporal artery. This is an MRI MIP sequence of the right lateral projection showing the distended feeder vessel, which is the superficial temporal artery, which is a branch of the external carotid artery. So for embolization, the patient is sedated and a guiding catheter is passed from the right femoral artery to the common carotid. Iodinated contrast is passed, images are taken, and as the AVM is, in this case, the arteriovenous malformation is just below the skin, an image-guided direct puncture of the nidus was done with glue. These are the pre and post embolization DSA videos. So if you can, I'm sorry. So I just want to show you the pre and post. So in the first image, you can see that the feeder vessel is still feeding the nidus. Whereas in the second, that is a post embolization, the nidus does not get filled because of the glue injected by the interventional radiologist. Now, after this is done, that is the DSA is done and we have done the embolization, we take it up for the second stage, which is the debulking of the arteriovenous malformation. So that is surgical debulking. So here, so 2 days after the procedure, we mark the, under general anesthesia, mark the lesion, subbrow incision to prevent scarring, using radiofrequency cautery to make the incision. Subcutaneous dissection with radiofrequency cautery. Once the lesion is identified, blunt dissection is done with a tenotomy scissor. And this is a very consolidated lesion because we have injected glue, but we should always be worried that the glue doesn't completely make it avascular. So once the lesion is dissected out, we know the location of the superficial temporal arteries. So then we, while going into from the location for where the feeder vessel is, we take more precautions to prevent the bleeding. We extend the incision for better exposure. Here, when we almost finished dissecting, we find the feeder vessel, which is now collapsed. So this is the main feeding artery, which is the superficial temporal artery. We ligated with the 4-0 silk. After ligating, we dissect out the consolidated AVM. So this is the lesion with the ligated vessel. And now we are just cauterizing the feeder vessel. And while we were cauterizing this feeder vessel and we're just putting glue, it gives away, causing bleeding, which can happen in these cases. And then we again, there was immediately we suction and then we cauterize again and we put fibrin glue over it to prevent the, basically to close the vessel. Once that is done, yeah, so we close the lesion on in 2-layer suturing. So our histopathological confirmation was done. This is our pre and post-op images. The swelling in post-op day 1, the patient had ptosis and swelling. It persisted by 1 month. He was able to open his eye. This is our 5th month follow-up of the patient where the brow span height is good. That is, the swelling has not recurred. We still follow up this case to look for recurrences. And yeah, so so my second objective is to just give you a briefing on what AVMs are. AVMs are a high flow tangle of, like a nidus with a feeder vessel and a draining vein. So depending on the location of it, our treatment varies. So what are the treatment descriptions given? So most of the AVMs are seen since birth, which grows in size when there's an inciting factor like a trauma or during menarche, during pregnancy. So if the lesion is asymptomatic, best not to do anything, observe the case and follow up. Less than 10% of AVMs are asymptomatic. Sorry, less than 10% are symptomatic, but they are most commonly seen in the brain, spinal cord, or the orbit. Surgical removal by removing the nidus and ligating the feeder vessel is a technique which we have done here. Radiotherapy is done for AVMs in the brain, where which is inaccessible, so radiation is done. So finally, I would like to say that the combined embolization and surgical treatment was done by Goldberg et al. And he has done for one of his patients. And we did the same procedure over here where we have embolized first and then followed by surgical debulking. Our way forward would be intraoperative digital subtractive angiography. So because over here we have consolidated the lesion and then we did the surgery. But in cases of there are inaccessible areas where the vessel can give away, if you have an intraoperative DSA, which is there in foreign countries, it can help us to do these cases better. The second way forward would be training in ophthalmic radiology, because we take a lot of help from radiologists to do these cases. So that would be a second take-home point. Thank you. I'd also like to thank Dr. Vishal, and I've come mainly because of the location, Mussoorie, and I'm not much into presenting, but this location, and I just love Uttarakhand. I have stayed here for 8 months in Dehradun, and I've had a great time. I'm from Kerala, and I love Dehradun. So yeah, thank you.
Thank you, Dr. Lakshmi Chakravarti. Any questions? So our next speaker is online, Dr. Gurpreet Singh. Dr. Gurpreet?
Yes, good morning. Am I audible?
Yes.
Okay. So should I start?
Please start the case.
Okay. So good morning, everyone. So I would like to present a very special topic here. Tiny eyes with a big impact, navigating infant orbital cellulitis with endoscopic precision. So I'm Dr. Gurpreet Singh. I have completed my DNB from Sir Gangaram Hospital. So as we all know, pediatric orbital cellulitis is a serious infection that involves the muscle and the fat. It usually occurs at the mean age of 7 years, but its occurrence in infants is very rare, with very few cases that have been reported in the literature. Most of all, the medial subperiosteal abscesses can be treated medically or with surgical drainage. And surgical management of these kind of abscess, it includes either open drainage through an external orbital approach or an endoscopic approach. So our case was an 8-week-old male which presented with high-grade fever, which was associated with irritability and refusal to feed post his vaccination, 2 or 3 days after his vaccination. He was admitted at a hospital outside of Gangaram Hospital and was symptomatically management and was discharged of fever. He again developed fever along with swelling and erythema at the medial aspect of the eye and was again managed symptomatically in that same hospital. But there was deterioration of general condition and there were episodes of seizures, which basically tempted the parents to bring the patient to a higher center, and that was Gangaram Hospital. And then he was admitted to the NICU. In NICU, the management was done according to the protocols of the NICU. I won't be including that management in our case. We met this patient in the pediatric ward. And on examination, we saw a left eye proptosis, upper as well as lower eyelid edema along with erythema, as you can see in the picture. The pupils were normal. The motility was also normal in this child. And cornea and conjunctiva, I mean, all the other, there were no other signs or symptoms other than this. Basically, then we sent the investigation for this patient. As you can see here, that all the parameters, the TLC were increased in this case, although for a pediatric infant at this age, this is not a very high number. CSF analysis was done, which was within normal limits. CSF culture was also sterile, but then the blood culture was sent, which turned out to be positive for methicillin-resistant Staphylococcus aureus. Then we sent the patient with sedation for the MRI. Here you can see T2 protocols being done. This is an axial scan, which is showing, you can see my yellow arrow here. This is hyperintense subperiosteal collection along the left lamina papyracea was shown on the axial as well as the coronal scans. Here you can see the subperiosteal abscess in the medially. So on the basis of our radiological investigation, we we basically came down to the diagnosis of a subperiosteal abscess. Management was basically started by the pediatric team. Medical management included the vancomycin injections, which were given, and including the injection monosef, which were given before planning for the surgery. And this was the medical management. And for the surgical management, we sought help of our ENT team. And they basically performed endonasal endoscopic pan sinus as well as orbital decompression under GA for this patient. And then the pus cultures were sent for microbiological investigations, which again came out positive for the methicillin-resistant Staphylococcus aureus infection. And basically after the discharge, this is the surgical result. This is the preoperative picture of this patient. As you can see here, the proptosis as well as the lid edema. And this is 3 days post-operative. You can see no post. Basically, child is performing well here. There is no edema, there is no erythema, there is no proptosis. And on discharge, then the patient was actually discharged after 2 to 3 days on domiciliary basis with injection vancomycin, clindamycin, and all these oral medications. And the child is doing pretty well after the surgery. So what was the twist and turn in our case? Basically, surgical management in infants can be challenging due to restrictive anatomy as well as limitation of the surgical endoscopic size that are present, that are usually done for these kind of surgery in an adult case. The traditional nasal endoscopes built for children less than 5 years are only for diagnostic purposes. They are not for surgery, basically. And in our case, the ENT surgeons used micro ear endoscopes to access the sinus as well as orbital abscess in this patient. So to conclude my presentation, this endoscopic approach offers several advantages, such as unsurpassed and magnified visualization of the surgical field. And since the orbital socket is an enclosed space with crucial structures packed closely, the endoscopic approach obviates the need for external approach and also avoids facial incisions. An endoscopic technique yields similar success rates when compared with traditional open approach, and it leads to shorter hospitalization as well as less post-operative edema. Thank you. I would like to acknowledge Dr. Shalu and our ENT surgeon, Dr. Manish, and my consultants, Dr. Mrita, as well as Dr. A.K. Grover. Thank you so much.
Thank you, Dr. Gurpreet. Any questions?
I think it's one of the few orbital emergencies, and if the pus percolates intracorally, probably can lead to vision loss. So time is important here. Intervention is important. Decision making is important. Yeah.
Yes.
Can go to the next case now.
Can I say something?
Yeah.
Thank you.
Whenever there is a partial response to medical management, a subperiosteal abscess in cases of orbital cellulitis must always be kept in mind. Either a partially resolved localized pocket or a subperiosteal abscess. Invariably, you will find one of them. The initial response to antibiotic is going to be good. And then if there is a plateau, it means that there is something where your drug is probably not reaching. And these pockets are either the subperiosteal area or an encapsulated locus in the orbit where that pus has got sort of caught up in a fibrotic cavity.
Yeah, in this case, we like to present this case because being an 8-week infant,
it was a dilemma how to manage this case and drain the suborbital abscess. Even the ENT surgeons found it difficult to go through the endoscope, and they use these micro instruments. So, yeah.
Another point, in these cases of cellulitis cases in infants, we have to do a peripheral smear to look for blast cells. So sometimes they do present, the AMLs do present like this. So the peripheral smear to look for the blast cells should be included in the primary investigations.
Young patients coming with partially responding to antibiotics for 2 weeks. And when you actually scan them, you see maybe one eye has a very big cold abscess, which has not responded, and the other eye has these tiny pockets. So do you actually go in and do bilateral abscess drainage, or you drain the one which has the eye with the proptosis, and the other one which has small pockets, do you leave that eye?
So you use two words, multiple pockets and a cold abscess.
Yes.
The word cold abscess is used for tuberculosis.
Yes, ma'am.
It is not used for a partially resolved pyogenic abscess.
Yes, yes, ma'am.
So if it's a cold abscess and it's not responding to anti-tubercular treatment, yes, you need to drain it.
Okay.
That one large one. But multiple small will definitely respond if it's a proven case of tuberculosis.
Oh, thank you.
Cases, small cases. So you can bring the ultrasound machine, color Doppler is easily accessible in the OT, and ask the radiologist to find it out, and with the cannula, you can introduce it, and if there's a multiple pocket also, you can drain it out. And on that, once they can confirm if there's no pass, then you can inject, or you can inject a good profile active, who's can taken care both gram positive and negative of foci and bacilli all, and simultaneously that whatever aspirate you can send for culture and sensitivity. No need for open up. Sometimes with a ultrasound guided, we can.
Sometimes if the pocket remains, then we are taking the patient for general anesthesia. Then again we'll have to take.
In general anesthesia, you can plan accordingly. That's what I'm telling. You can just pre-plan that machine can be shifted to OT. Machine can be shifted to OT, except in IoT. We are doing a anyway. We are not doing in a SAS OT, okay, cataract OT. So whatever oculoplasty OT we are doing this year, etc., is well equipped that machine easily can be carried if it is a multi-specialty.
But when we are doing endoscopy, we are opening the abscess also, the abscess wall, so it can keep on draining.
Then
If we are doing through the, we just aspirating it, then still the collection can again come.
Then you can just into some wash out by antibiotic. That's one option, easy option. Under GA, short GA.
That is one of the options.
One of the option under short GA, but it's work very good in Ixabeki.
Thank
you. Yes.
We need to be calm and very soothing like Jayanta when we are operating these emergency cases.
But it can be done. Once you're radiologist in your opinion, you can do as fast as you. But anyway, for GA, 3 months. You can just that one, and after 15 days, and after
So next speaker is Dr. Zahir Ansari.
A warm good morning to all of you. My topic of presentation is from the uncertainty to clarity, the role of gallium-68 DOTA PET scan in diagnosing optic nerve sheath meningioma. So I'd like to acknowledge my co-authors and mentors and Department of Nuclear Medicine and Radiation Oncology of Gangaram Hospital. Optic knopsid meningioma is a rare and slow-growing tumor originating from the meningoendothelial cells of optic knopsid. It's basically affect the middle-aged females with progressive painless vision loss with proptosis. Diagnosing these optic nerve pathway lesions quickly requires biopsy, but it poses a very high risk and it is technically very challenging also. While MRI and CT has been traditionally used for diagnosis, but this gallium DOTA PET scan offers improved specificity for targeting the somatostatin receptors. So before proceeding forward, let's know how this DOTA PET scan works. Actually, this optic nerve sheath meningioma tumors express the somatostatin receptors, basically more of the type 2. And when we inject these radiotracer elements, this is going to bind with the receptors on the surface of the tumors. And when we do PET scans, that PET scan detects the radiotracer uptake. And this is basically calculated with a standardized optic volume maximum using the formula given here. In the recent study, it is found that the ranges of ACV max of 14.3 to 15.4, it is very found to be diagnostic and with 100% specificity and sensitivity for diagnosing the optic knopsid meningioma. So our case, it is 60 years females which presented with us basically with a complaint of swelling in the right lower periorbital region for last 3 years. On a further inquiry, we found that she is having a vision loss of right eye over the period of 4 months. She is having decreased vision from 612 base corrected visual acuity to 624. It was unilateral vision loss, progressive and painless, associated with forward bulging of right eye. However, there is no history of pain, redness, trauma, drooping of eyelids, double vision, and headache. No significant any systemic illness, no significant space-occupying lesion in the past, long-term steroid intake, any radiation exposure to head and neck, and no significant family history. On examination, her visual acuity in right eye was 624, not improved with pinhole. In left eye, it was 612, 69. On periorbital examination, there was a back fat noted, which is around 28 mm into 10 mm. And she is on doing Holter's exophthalmometry. Her proptosis in right eye was noted with restricted extraocular movement in superior and lateral gazes. With grade 1 RPD and having cataract, which is not significantly affecting vision in the both eye, with a choroidal fold present in the right eye and impaired color and color vision test and contrast sensitivity in the right eye. On visual field analysis, he is having superior and inferior original defect with superior and inferior RNFL thinning along with ganglion cell layer thinning with foveal sparing, suggestive of compressive optic neuropathy. However, the lab parameters were within normal limit, except the ESR was raised and CRP was positive, and MON2 test and HRCT test was not significant. On doing MRI orbit, the T1 weighted MR images as shown in this picture, we can see it is showing a ill-defined marginated soft tissue lesion in the intercoronal compartment of the right orbit, and on the contrast, it show classical tram track sign. On the basis of this, our radiologist makes the following 4 differential diagnoses, and they suggested us doing a biopsy. And then we faced a challenge, whether to go under biopsy with the risk of vision loss or choose a safer pathway like DOTA PET scan. The patient also agree for the DOTA PET scan, and we do a routine FDG PET CT showing no significant uptake, but the turning point come with the DOTA PET scan is so a very significant uptake with ACV max 8.4, strongly pointing to the optic knopsid meningioma. So with this non-invasive diagnosis, we planned for the radiotherapy. The patient went on the radiotherapy with the dose of 25 Gr, and she completed her therapy and tolerated well. And after 6-month follow-up, we can see she is having a decrease in the proptosis and no further deterioration of vision. So this MRI and CT aid in diagnosis, but they lack specificity in differentiating optic knopsid meningioma condition like pseudotumors and lymphoma. Other tumors do express the high somatostatin receptors, such as pituitary adenoma and neuroendocrine tumors, but they are not located in the optic nerve pathway lesions or orbital locations. So in our case, the absence of significant FDG PET uptake highlighted the diagnostic superiority of this somatostatin receptor imaging. So few cases have been reported. The largest series of the Horowitz et al. And followed by Klingenstein. However, these cases also have the two negative cases as shown in this table. In the cases study done by the Graffi et al., in which a case that was histologically proven optic knopfed meningioma, the SUV max was found to be negative. It was 1.7. But in this study, the ranges of SUV max was 2.6 to 7.8. So it was missed. So for this, they should have used ratio of optic knopfed pituitary adenoma by the optic knopfed ratio by the pituitary adenoma ratio that has to be used in this study. So talking about the limitation and the recommendation, all the studies done till date are monocentric with no histological confirmation. Large case studies with multi-centric reporting should be obtained for the validation. Other limitation is that there's a lack of clear gold standard method for the optic knopfed diagnosis. So new tools are required, basically for those cases which are this gallium DOTA PET scan negative cases. So the key learning is that this DOTA PET scan is a non-invasive, powerful, and still underused tools in diagnostic workup of intraorbital tumors, especially the optic knopfed meningioma. This case report highlighted the utility of the gallium DOTA PET scan in achieving the precise and non-invasive diagnosis of optic knopfed meningioma. So future research should be focused on the role of this DOTA PET scan in diagnosing as well as monitoring the treatment response. So these are my references. Thank you.
So I have a question. What was your indication for thinking for tuberculosis?
Actually, ma'am, we in the past when we look back our documents, she's having history of significant history of fever also, ma'am. And later it was diagnosed. Later they have done also a scan. They are found that this is having sinusitis also.
No, but sinusitis, fever does not indicate that this perineural mass is tuberculosis.
No,
tuberculosis does not manifest in the orbit with perineural masses. It would come first into the choroid for a tuberculoma to form around the perineurium. I have not read about it.
No,
the second thing which came to my mind was that it would have been much better if rather than focusing on the field of that particular eye, you already know that there is a mass, you do suspect a field. There is going to be a field effect, whether compressive or otherwise. Lot of focus should have been put on the field of the other eye. That itself would give you an idea whether the lesion has gone into the canal or not. See, clinically, not everybody has access to this. It is nice that you pointed out a new modality of investigation. But as far as the clinical workup is concerned, I think it is important to also pay attention to the other eye. Then what was the fundus picture? Did you get any shunt vessels or any such thing on the fundus?
Pardon, ma'am?
Shunt vessels on the fundus?
No, ma'am, there was no any shunting.
There were no shunting vessels. So these are small issues that came to my mind. Any other comments?
Seeing the false negativity of this modality, can you strengthen your case by doing tissue biopsy somehow?
In the cases of false negative cases,
Sorry, in this case which you are talking about.
Yes.
You have one case, no?
Yeah, just one case.
So since false negative reports are there with this, so can you strengthen your diagnosis with the tissue biopsy? Can you take a tissue biopsy somehow?
We counsel the patient for the biopsy, but we also explain the risk of the vision loss, but they don't get agreed for going for biopsy, ma'am. So we
see, radiation also is going to give rise to visual loss. It is not that you are going to irradiate the orbit and the vision will not get affected. The patient will develop radiation neuritis.
But when you approach surgically for the biopsy, that I think poses more risk of vision loss than the radiation.
You don't go in for an open biopsy. You go in for a CT guided biopsy. Under direct vision, you put in a needle. You go in for a CT guided biopsy.
Okay.
Not an open biopsy for such patients. It's never indicated. You definitely land up with loss of vision.
Yes.
You could have done a CT guided biopsy.
Okay, thank you, ma'am.
Very well presented. Good you brought out these points.
Yes, thank you, ma'am.
Thank you, Dr. Zahir. Next speaker is Dr. Tanvi Joshi.
Good morning to all. So I'll be presenting two interesting cases on unsuspected pleomorphic adenoma. So a young male presented in our OPD with diffuse swelling of left eye upper lid since 5 months, which was gradual, progressive, and non-tender. On examination, he had left eye S-shaped ptosis with all anterior and posterior segment findings within normal limit. On extraocular motility, left eye levoversion was restricted. On palpation, the mass was well defined, firm, freely mobile, and non-tender. On CT orbit, the mass was hyperdense, extraconal, with fuzzy border. So we narrowed down our differential to dacroadenitis with a distant possibility of neoplasia. Management, we started the patient on combination of oral and topical anti-inflammatory drugs for a month, but we found no improvement in clinical picture. So then we went ahead with incision biopsy and we found a periglandular lymphoplasmacytic infiltration. And on advice of a pathologist, the patient underwent IgG4, which was within normal limit. So then, based on the histopath, we started the patient on tapering dose of oral steroids for a month. Despite that, no clinical improvement was seen. And patient underwent left eye excision biopsy via lateral lid crease approach. The mass was excised, and on gross examination, we found it to be a dermoid. But surprisingly, on histopathology, pleomorphic adenoma came out with typical picture. On postoperative visit 7, patient had mild upper lid erythema. And on further follow-up visits, patient was doing well. We kept the patient on closer follow-up visit as we have done incisional biopsy. On literature review, we found another study done by Vadani et al. On palpable pleomorphic adenoma, who quoted that in 14% of cases, significant ptosis and upper lid swelling was noted in 6 cases similar to our study. So key points were pleomorphic adenoma can present as dacroadenitis and a confusing imaging picture. So we should be cautious in our management and avoid incisional biopsy. Another case of a 47-year-old male who came with complaint of protrusion of left eye since 3 years, which was gradual, progressive, and unremarkable systemic history. On examination, we found in left eye inferior show of 8 mm with normal anterior and posterior segment finding. A superior gaze restriction was noted, and a proptosis of 11 mm and a dystopia of 10 mm was seen. On palpation, a firm, mildly tendered, diffuse mass was seen in supralateral quadrant, which was the posterior borders were merging within the orbit. So on CT, we saw a hyperdense mass in intraconal space with well-defined borders. So we narrowed down our differentials to cavernous hemangioma and the patient underwent lateral orbitotomy with excision biopsy through a transconjunctival approach. The mass was excised and the mass was completely unrelated to lacrimal gland peroperatively. The gross examination of mass had a bosselated appearance, and on histopathology, it was consistent with pleomorphic adenoma. So on further follow-up visit, patient was doing well. So a diagnosis of pleomorphic adenoma arising from ectopic lacrimal gland aligns with existing literature, which also documents similar occurrences and proposes two theories, including one migration of sequestered portion of lacrimal gland into orbital soft tissue, or a part of separation from main lacrimal gland during development. These are the various places where ectopic lacrimal gland tissue is found. There are 5 reported cases, 3 of which were within the orbit. Previous study consistent with our diagnosis, one done by Mishra et al., who managed a similar case using external approach via lateral orbitotomy. So key findings include complete excision of mass with strategic incision planning and accurate localization of mass guided by imaging. Thank you.
Thank you, Dr. Tanvi. Any questions from the panel? The next speaker is Dr. Manu Seni, who will be presenting her case online. Dr. Manu, are you there? Dr. Manu?
Am I audible?
Yes, Dr. Manu, you are audible.
Visible?
Yes, you are audible. Please go ahead with your case.
Yeah. My slides are visible.
Yes.
Yeah, a very good morning to all.
And I would like to be there, but because of the crisis, I missed it. And sincere thanks to MID-TERM OPAI and event organizers for this opportunity. I'm going to talk about the wayward lacrimal gland tumor, a rare and intriguing topic in the field. The most of the part has been discussed in the previous speaker. Slides are not moving. Just hold on. I'll find out. Yeah. 32-year-old male present with a painless progressive proptosis. An examination revealed an inferior dystopia of the globe. There was a fullness of subbrow lesion with non-pulsatile firm, non-compressible swelling. CT scan examination revealed a well-defined heterogeneous enhancing subperiosteal mass region around 1.5 times diameter of the globe. The mass was causing significant thinning to the roof with indentation to the globe. Considering lacrimal gland tumor as a primary differential diagnosis, patient underwent excisional biopsy. The mass was approached via subbrow incision. Skin orbicularis oculi was dissected up to the orbital rim. A sharp incision was made at the orbital rim. Periosteum and periorbita were dissected out, and an encapsulated mass separated from the main lacrimal gland was identified. The mass was freed from the surrounding tissues using blunt spatula. No connection was observed with the main lacrimal gland, and a plane is created between the mass and the gland easily. The mass was prolapsed out. Slight nodularity with multiple hemorrhages and yellowish content was identified. And stalk seems to be attached at the superior medial aspect. Gentle dissection is continued. And mass is sent for the histopath examination, followed by the closure of a incision in layered. So histopath examination revealed a well-circumscribed solid tumor arranged in the nest trabecular and cribriform pattern composed of the epithelial and myoepithelial cells in chondromyxoid matrix, suggesting pleomorphic adenoma. As in our patient, mass is situated outside the lacrimal fossa. So our patient is a case of ectopic pleomorphic adenoma of the lacrimal gland. And surprisingly, ectopic foci can be located far away from the lacrimal gland. Like in this case, she has inferomedial mass, shows homogeneous enhancement and fossa formation, suggesting chronicity, long-standing duration. And her histopath examination also turned out to be the pleomorphic adenoma with abundant cystic spaces. So on exploring the literature about the ectopic foci mechanism, we found that during development, part of the lacrimal gland may get sequestered or develop separately from the main mass. And if it is located deep in the orbit, it may present as a proptosis. However, ectopic foci can be located anywhere at any location in and around the eye. And their presentation seems similar to the growth pattern of the pleomorphic adenoma arising from the main lacrimal gland. Therefore, it requires total excision. However, if the capsule is ruptured and the myxoid components flow out, the tumor may reoccur. In our case, lesion has caused significant displacement and compression of the globe. However, outcomes remain good with best corrected visual acuity of 6/6. Tumor were excised in toto in both the cases, and cystic degeneration in long-standing pleomorphic adenoma is exceedingly rare phenomenon, especially at ectopic foci and associated with a heightened risk of recurrence, being prone for rupture and spillage during surgical excision. Thank you for patience listening. Any questions?
Nothing much to add, but definitely for lacrimal gland, before going for any incisional biopsies, we should be sure that it's not an adenoma. because
Actually, I did excisional biopsy. I
no,
incised
I'm just adding a comment to your case. I mean,
unless and until we are suspicious about the malignancy, perineural invasion, infiltrative etiology, then and then only we proceed for incision biopsy.
yeah. So I think thank you.
Thank you, sir. Thank you, sir.
I have the next speaker now.
I'm not sure if we are connected to the main hall. So I think there is a little lag there. I think so. We'll have to just tell them that we are not able to connect with them.
Okay, message them.
Next speaker is online.
Sir, I think we have lost contact with the main hall team. That video I am not being able to see of the main hall.
Yeah, looks like.
Do you need any assistance?
Hi, Sunil. We have lost from the main hall connection. I think so. We are not seeing anybody in the hall.
I am just speaking to them. I'm trying to connect. They are disconnected. Let me just wait for a minute.
Thank you.
Okay. Thank you,
Uh,
everyone. Thank you, everyone.
Next speaker is Dr. Abhijay Luthra.
Luthra, and today I'll be talking about tackling the unforeseen consequences of seemingly regular procedures. So, cataract surgery is the most common elective world nowadays, and Descemet's membrane detachment is a frequently noted complication, which has management air or gas descemetopexy, which has threatening complications such as persistent DMDs, high IOP, or pupillary blocks. Not always the case. So moving on to my case, a 71-year-old female presented to us with complaint, pain, diminution of vision, and significant past history included her undergoing cataract surgery 3 weeks back elsewhere, diagnosed with a DMD for which she underwent descemetopexy with C3F8 2 days back. Plastic clinic as a case of query orbital cellulitis of hand movements in the right eye with an IOP of 25 mmHg. So on exam, no changes in color and temperature, thereby ruling out what we thought what she was referred as was orbital cellulitis. Other than that, she had complete ptosis, gross edema, increased orbital pressure, and extraocular movements were restricted in all gazes. On opening the eye, she also had multiple subconjunctival gas pockets. Crepitus was noted on palpation, and 360-degree conjunctival ballooning was noted. She also had diffuse stromal edema with multiple Descemet membrane folds, a gas bubble covering 50% of the anterior chamber. The pupil was sluggishly reactive to light, and there was no view of the fundus. The fellow eye was completely within normal limits. So keeping in mind all these positive findings, we were wondering what it could be, and we came to a subconjunctival and orbital emphysema, a diagnosis that has not been reported in literature previously. So we went ahead with the urgent scan orbit to localize all the areas where the gas would be located, and this is what we found. We found multiple pockets of gas, extracorneal space, the subcutaneous space, and a small amount of air was also noted in the intracorneal space, which was probably leading to the slight proptosis too. So this right-sided orbital and subconjunctival emphysema post-gas descemetopexy was to go ahead with the emergency right-sided conjunctival gas drainage along with the lateral. So here we did a subconjunctival drainage of the gas, following which we used a side, give a stab incision to again release the gas. Here we are draining the subcutaneous gas by going in with a 26-gauge needle with the plunger removed. Following which we saw that more gas migrated anteriorly from the orbital cavity. After this, we sutured up the main port that was probably used for the cataract, and we noted that one of the stab incisions was a bit posterior. So this was most probably the conjunctiva. The conjunctiva while making the entry, and they had no. So orbital it's commonly seen in patients with a medial fall fracture after orbital fracture repair, post-VIA procedures, or post-FES. Most literature are usually of orbital emphysema secondary to vitreoretinal improper closure of the ports. So our patient in the post-operative period at 1 week, her IOPs had come down to normal. The edema membrane detachment was persisting, for which she underwent a subsequent. And at 2 months, she had improved to a 6, and we have counseled the patient that in the future. So the take-home message is that while preparing the gas for desmatopexies, it must be used in iso. What happened here was most probably the gas was not prepared in an isoexpansile concentration, 6 or 14% for C3F8. That the conjunctiva must not be touched. So this is a preparing the gas ourselves and not. We should know that orbital emphysema can be a rare complication, and a CT scan orbit is the best way to rule this out. I would like to end with saying that seemingly harmless procedures, if done carelessly, can lead to devastating consequences. Thank you.
Thank you, Dr. Abhijit. Any questions from the panel?
Nice case.
Next speaker is Dr. Tarjani Dave, who will be presenting her case online. She's not there. Okay. So moving on. Next presenter is Dr. Vidya Shankar. So next presenter is Dr. Varsha, who will be presenting a case online. Dr. Varsha, are you connected? Dr. Varsha. So I think we'll move on to next. So next presenter is Dr. Pankaj Gupta. Dr. Varsha has connected. Dr. Varsha, can you hear me? Dr. Varsha, can you hear me? Next speaker is Dr. Raguraj.
Dr. Varsha has some technical glitches. Her volume, her voice is not audible. So I think she'll join in maybe after the next presentation. Sorry.
एक मिनट अलाउ करते हैं बट ये कीनोट ट्राई करें Dr. Varsha is online. Dr. Varsha.
Am I audible?
She is connected, but she is not replying.
Can you hear me?
Dr. Varsha, we can hear you.
I don't think they can hear me. Hello?
Yeah, you are audible.
Yes, you are audible. Dr. Varsha? I think there's some connection problem with Dr. Varsha.
Or Dr. Lag is also there.
Dr. Pankaj? Dr. Pankaj Gupta?
Yes, sir. Good morning. I'm here.
Yeah, Dr. Pankaj, please go ahead with your case.
Should I present now?
Yeah, you should.
Okay.
Yes, please.
Is my screen visible?
Yes,
Yep.
Dr. Manu.
Okay. So good morning to everyone. I'll be talking about the role of closed suction drain in anterior orbitotomy. This was a study that we did at our department, and as we all know, that surgical excision of masses leave behind a potential space for a collection of fluid or blood, and the source of hemorrhage can be from an inadequately cauterized bleeders. Placement of a drain in the cavity has been shown to reduce morbidity and complications in various surgeries, including abdominal, plastic, and orthopedic surgeries. And this closed suction drain after any surgery facilitates in removing the fluid from the operated cavity, and it mitigates the dead space. And however, sometimes there are complications associated with placement of drains that include inflammation, retrograde bacterial migration and infection, or loss or entrapment of the drain, and possible protein electrolyte loss. This use of post-operative drain is largely based on surgeon's preference, and a few authors use them routinely, while others do not. The exact role has not been substantiated by any randomized trial, and keeping this lacuna in mind, we intended and we studied the role of post-operative closed section drain in anterior orbitotomies. This was a prospective randomized comparative study of consecutive patients, adult patients, who underwent anterior orbitotomy over a 15-month period. And the adult patient with well-localized
Dr. Pankaj,
anterior
you're not able to hear
orbital
you.
mass requiring excision by anterior orbitotomy were randomized into two groups. Group A, where a drain was put, and Group B, where drain was not put. And randomization was performed using a computer-generated random number tables, and patients with known bleeding disorders, uncontrolled systemic morbidities, they were excluded from the study. All the patients underwent an anterior-orbitotomy with mass excision using the standard of care. And mini-vac closed suction drain by Romson's was placed in Group A patients. The drain was kept in the depth of the wound, brought out through a separate incision in the skin, and sutured to prevent slippage with airtight wound closure. This was left in place until the collection was less than 5 ml in 24 hours, and the wound was inspected daily. And the time from operation to removal of the drain and total volume collected were recorded. The patients in Group B underwent orbitotomy, but no drain was used, and they were followed up regularly. The demographic details of the patients in the two groups, they were more or less similar, and there was no gross deviation. The number of patients in Group A was 12, and in Group B was 13. All were adult patients. The closed suction drain was removed once the collection was less than 5 ml in 24 hours using the standard procedure of removal. In 4 cases, it was at 24 hours. In 7, it was at 48 hours. And in 1, it was at 72 hours. And the subsidence of proptosis, eyelid swelling, and restoration of ocular motility were evaluated in both the groups. And it was actually faster in the drain group as compared to the non-drain, which was Group B. And on comparing the scores for pain in the two groups, a significant difference was observed, and post-operative pain was more in the non-drain group as compared to the drain group. The study documented no significant difference in the visual acuity following the post-operative closed suction drain at the end of 1 month and 3 months. And none of the patients reported any transient or persistent vision loss in the immediate post-operative period. Histopathology and pathological examination of the excised masses disclosed pleomorphic adenoma of lacrimal gland, cavernous hemangioma, lymphoma, inflammation, a dermoid cyst, and low flow arteriovenous malformation in Group A, while in Group B, the pathological diagnosis were orbital lymphoma, benign orbital mass, schwannoma, cavernous hemangioma, and lipoma on histopathology. This photograph just demonstrates a patient in Group A who underwent anterior orbitotomy for a supratemporal mass, along with the use of post-operative closed suction drain. So these results that we had, though it was a small sized study, but we inferred that the use of a post-operative closed suction drain, it helps in faster post-operative recovery and faster subsidence of proptosis, eyelid and edema, and rapid recovery of ocular motility. However, the final outcome when we talk of in terms of visual acuity was comparable in both the groups, and the and again there were the type of orbitotomy that we talked about was the anterior orbitotomy, so that was another limitation of the study, and maybe a larger study with that includes patients with as posterior orbit or and lateral orbitotomy would be more beneficial in drawing such conclusions. Thank you all for your patient listening.
Thank you, Dr. Pankaj. Our next speaker is Dr. Raguraj Hegde.
Hello. Yeah. Good morning, everyone. Thank goodness I could make it to Missouri. It was thanks for Vishal for organizing this wonderful conference. And even on the second last session of the event, there's almost half the room is filled. And so I'm going to talk about a very interesting case which I had never come across or not even read in the literature. Of 5 days. She had severe chemosis, total external ophthalmoplegia, diminution of vision, and a recent history of recovering from dengue. And she had thrombocytopenia at that time, for which she was given platelet transfusions. So we were thinking whether post the recovery there was a hypercoagulation status, which explained like probably a cavernous sinus thrombosis as well. And along with that, she is a newly diagnosed diabetic during the treatment of the dengue, and she was on oral hypoglycemia when she came to she presented to us. So our first diagnosis was cavernous sinus thrombosis, which was again somewhat corroborated with the MRI. So we could see that there is a intraconal orbital fat stranding in the MRI, and this complete obliteration of the superior ophthalmic vein. But the cavernous sinus was normal, but only the superior ophthalmic vein was thrombosed. So we thought it was because of the hypercoagulation status of the thing, and then there was associated inflammation as well, because dengue also causes hyperimmune status post the recovery. So we started her on multidisciplinary management of broad spectrum antibiotics, and anticoagulant agents was started by our hematologist. And pulsed high dose IV methylprednisolone was given 1 gram for 3 days. And because she was also diabetic, and glycemic control was not sufficient with just insulin dosages, so we had to give her insulin infusion, because it was always, when she presented to us, her sugars were above 400. So then we shifted to oral steroids because her glycemic management was getting more challenging. So we shifted her to a 30 mg of Vizolone. So, but 3 days after presentation, she was all the edema, extraocular movement, everything was resolved, and we thought we were past the report. But the 1 day after the stopping of the IV steroids, she again came back with a recurrence. I mean, she was still in the hospital, so she had a recurrence, and that was very confusing to us. And so we got another MRI done at that time, since she was already in the hospital. So we at that time the radiologist, we had a discussion with the radiologist, and the radiologist noticed this opacification at the middle of the interconal component of the orbit, and he said this is not looking normal. It looks like there is some collection, that probably a bleeding, or there is some vascular malformation that is there. I think it would be a good idea to biopsy it. I was at that time not very keen on it, but then because he said, I think if you want to biopsy it, this would be the best possible time. So we went in and did a surgery. We convinced the patient for that surgery was important. And we went in with the exploratory orbitotomy with the transcaruncular incision. And we did an excision of the solid mass and surrounding intercorneal fat. And what we next saw was really very, very amazing. So what we saw was that there was a venolymphatic malformation that was there at the nidus of the mass that we took out. And the other photograph shows that there is a broad septate, aseptate branching filaments morphologically resembling mucor, and which was confirmed by the GMS stain as a brownish black branching filaments consistent with mucormycosis. But that is not the end of the story. So we then, the pathologist also noticed there is dense lymphoplasmacytic cells dissecting the adipose tissue, which is the surrounding fat that I had taken out. And that had perivascular sclerosis and plasma cells with sclerosed vessels, all of which are very pathognomic of IgG4 related disease. And again, there were all signs of there's transmural phlebitis as well as IgG4 plasma cells on IHC staining. There was a IgG4 positive plasma cells, which is more than 100 per high power field, which satisfy the criteria for orbital IgG4 related disease. So we had at the end of this, the eye of the storm is basically we had a three diagnoses. One was angioinvasive mucormycosis, which was the most proximate cause. And the second one was a venolymphatic malformation, which is probably pre-existing before the whole episode. And then there was the IgG4 related disease, which was which was probably triggered by the dengue that she had. So our hypothesis, which is of course, don't know exactly what exactly was the sequence of events, but dengue was obviously the trigger, and pre-existing asymptomatic VLM, and she was probably a pre-diabetic before dengue, and dengue triggers diabetes and then causes hypercoagulability, SOV thrombosis. Then the VLM also clots in the background of diabetic ketoacidosis. Dengue also triggers hyperimmune status, causing the IgG4 also to be triggered. And then the angioinvasive mucormycosis was at the nidus of the VLM. And because there was no PNS involvement, there was no other location where there was mucormycosis or any sort of disease. So multidisciplinary management was done. We started on oral isoconazole for 3 months at a low dose oral corticosteroids and insulin for glycemic management. And after 2 months, because we couldn't give her a lot of immunomodulation, we started her on IV rituximab 2 doses, 4 weeks apart. And after 2 months, oral MMF maintenance therapy was initiated. After 3 months, we were not giving her any corticosteroids, no antifungals, and maintenance therapy with MMF was going on. And we were managing her diabetes with oral hypoglycemics with good glycemic control. So after 6 months, she was very well controlled. She was in complete remission, and there's been no recurrences since the initial part of the disease. So there is a deception of corticosteroid trial. Basically, orbital inflammation can be present in wide array of diseases, and corticosteroids switch off the inflammatory genes in the chronic inflammatory process and upregulate the anti-inflammatory proteins. So it induces apoptosis and misleading as a misleading phenomenon of a clinical improvement in both benign and malignant lesions. So many diseases are missed, fungal, neoplasms, and other diseases can be missed. So corticosteroid is not a really therapeutic agent for treating orbital inflammation. So it's often clubbed together as a pseudo tumor, but actually a misnomer. It can be misleading if we just use a corticosteroid as a marker for orbital inflammation. So studies world over have shown that there's long-term benefits of early biopsy and early induction of immunomodulation. And in our hospital, we do a biopsy first approach, and we have a multidisciplinary team to manage all the immunomodulation as well post surgery and post inflammation. And we have a good pathologist as well who are able to pick up the diagnosis so that we can treat them in a targeted approach. So in summary, orbital inflammation can present in a wide variety of lesions from benign to malignant with other associated infections, neoplasms, and comorbidities. And multidisciplinary management is the cornerstone of management in this particular case. So we couldn't have done it without all the inputs from the various specialties. And biopsy first approach is a better long-term prognosis. And this is the first of a kind case, and we have not found anything in literature about this kind of a case. So we are shortly going to be publishing this. Thank you.
Thank you, Dr.
Yeah, well managed case, Raghu. I think we are not having anyone talking on NSOIDs. I think, remember, I mean, your talk reminded of that. We should have had someone speaking on that. It's really challenging and a dilemma.
Yes.
Okay, Dr. Varsha is there. Okay.
Yes. Am I audible?
Yes, yes.
I'm really sorry about the glitch. I'll go ahead presenting now. At the outset, I'd like to thank Dr. and the entire team for giving me.
Varsha, can you just hold on for a minute? We have
Yes.
some questions for the previous presenter.
Yes, please. Sorry.
So I have one.
Mic is not.
So one query that could it be that because that histopath it is probably because of this fungal thing. So fungal could be because of this the patient is the immunocompromised.
She was not immunocompromised. She was
She is
immunocompromised.
diabetic and yeah.
So diabetes. So probably she had a lot of things, but dengue was a trigger.
So that hypothesis I understood that dengue was a trigger and that inflammation thing. But how come it's like the fungal elements there in the pre-existing variant?
So probably that SOV thrombosis was actually a clue also that the VLM that was pre-existing that had got thrombosed. So that VLM, the venulolymphatic malformation, which is probably a slow flow malformation, since it got, see, it was a nidus of infection. So there was, the blood supply was not there. And then that area, because of the diabetic ketoacidosis, that converted to mucormycosis because of the pre-existing, because there was no other areas from where the mucor could have come. Like the sinuses were clear and there was no other involvement in any part of the body. So that particular, so the VLM was probably the reason why she had mucormycosis there. And
that part of the VLM was even present in the first, I think, imaging.
no, there was, but it was covered up with all the orbital inflammation, the intercorneal inflammation. But after we started the steroids, probably the mucormycosis worsened.
Yeah. Yes.
But she was not having externally, she improved. So that was the confusion when we did the steroids. Externally, the inflammatory markers, all of them improved. But the disease, mucormycosis probably increased. She probably had a mucormycosis earlier, but it was masked with because of the other problems that are going on. So once we stopped when she reduced the dosage of the steroid, then when we did the imaging, we saw that it was enlarged. So when we went back to the image and saw that the size had increased, and here we could clearly see there is no blood supply in the post contrast images.
Long back, we had a similar case where the presentation was MSOID with the fungal mixed element, and ultimately the patient landed to the examination.
Yeah, so I think radiologists need the best credit because he picked it up. Even I was not really wanted to go in. He said, no, if you want to do the biopsy, this is the best time. So go in early. So then I had to convince the patient and patient agreed.
Raghu, can I add a point?
Yeah.
Hi, Sonam here. Hi.
Hi.
I think a fantastic case. We had a similar case where we had IgG4 but with aspergillosis. And the dilemma was that the patient had a lot of pain, a lot of orbital inflammation. And as you know, we cannot start voriconazole with oral steroids because that will have a problem with the uptake.
Counterproductive, yes.
Yes. So we were stuck there. And so then we had to start voriconazole, but the patient worsened because his inflammatory signs worsened. At that stage, then we had to take a call what to do. So then we started him on oral, stopped the antifungal, started oral steroids. Once he was little better, after 4 weeks, repeated imaging, and then again restarted the antifungals. So these are very tricky situations, fantastic outcome there. So thank you so much for this case.
Also, I think one thing also helped that we could remove the main areas where the fungus was there. So the disease load had come down. So then we had a little bit of leeway in like keeping the steroids as well as giving antifungals at the same time. So I think that was the surgery actually was a little bit curative in this case because it gave us a little bit of space.
Correct. Just a question for everybody there. And if we have such a scenario, would you consider giving intraorbital antifungal injections in that case along with oral steroids, or what would you do? Like any orbital injections like?
Dr. Sonam, I think if there is already inflammation, the intraorbital amphotericin will increase the inflammation.
So it'll be difficult to tell what is causing the inflammation, whether it's the underlying inflammation or whether the caused by, because it causes the amphotericin, even if the liposomal one also causes induces inflammation.
Yes.
This was a seeing eye, I believe. It was a seeing
Yeah,
eye.
it's a seeing eye. Seeing eye. She's 6'6".
So only oral and IV. Got it. All right. Thank you.
Thank you so much. Next presenter is Dr. Varsha. Dr. Varsha, can you please connect now?
Yes. Am I audible?
Yes, you are audible. Please go ahead.
Thank you. Very good morning to all. At the outset, I'd like to thank Dr. Vishal and the entire organizing committee for this opportunity. I'll be talking about a wolf in sheep's clothing.
Dr. Varsha, can you please share your screen?
Doctor, can you please share your?
Sorry, I've already shared it. You can't
It's
see.
not. Can you just do it again? And also just look at the camera, please. Also, a little. Your face is not visible.
Okay. Sorry about that. I'll share it again then. Okay.
Yes, and also kindly lower the camera. Also, your face is not visible.
All right. Is it seen now?
Yes. Can you just make it into PowerPoint show mode, please? Thank you.
No, it's okay. Yeah. So I'll be talking about wolf in sheep's clothing. Could it be more than a cavernous hemangioma? So cavernous venous malformation are considered the most common benign tumor of the orbit and relatively easily diagnosed radiologically. Surgical management is straightforward with excellent outcomes. However, masquerades of cavernous hemangiomas can be troublesome to the surgeon. So this is a 39-year-old gentleman who presented with the left eye prominence for 7 years, double vision and diminution vision for 4 years. The visual acuity in the left eye was 6/12 with the relative afferent pupillary defect. There was a gross proptosis with exotropia. The extraocular movement was limited in elevation as well as in adduction. And on imaging, a large, well-circumscribed intracorneal lesion medial to the optic nerve was noted, pushing the optic nerve laterally. It was iso-intense in T1 and homogeneous hyper-intense in T2, extending up to the apex, suggestive of a cavernous hemangioma. So, and the visual field was a grossly restricted field with tunnel vision. He underwent an excisional biopsy via a transcarencular approach with a lateral wall out fracture to create extra space. And during the dissection, the mass was tethered to the apex and there was on-pupil dilatation. Hence, a near complete removal with a small residue at the apex was performed in order to salvage his vision. Operatively, the gross specimen looked very much similar to a cavernous hemangioma. However, interestingly, on histopathological examination, vascular channels lined with endothelial cells showing hobnail pattern was noted, suggestive of a hemangioendothelioma. So the outcome at around 2 months post-op period was good, and fortunately, he did not have a post-operative visual loss and it maintained the vision of 6/9. And these are the scan images at 2 months follow-up. So hemangioendotheliomas are low to intermediate grade vascular tumors, which can mimic the benign cavernous hemangioma. The pathology clinches the diagnosis as these tumors do not have a capsule. Tethering to the adjacent structures can happen, namely the optic nerve and the extraocular muscles, and surgery can be a challenge. It can tend to bleed, making the things complicate more, and it can locally recur, hence a close follow-up is required. Here is another patient, a 47-year-old lady who presented with blurring of vision for 2 years. Her vision was 6/9 in the left eye with mild proptosis. On imaging, there was a well-circumscribed intracorneal lesion inferior to the optic nerve with delayed contrast filling, suggestive of cavernous hemangioma again. There were field defects noted in the temporal quadrants. And she again underwent an excisional biopsy, and on table, to our surprise, there was tethering to the adjacent extraocular muscle and apex, unlike the usual cavernous hemangiomas. The tumor was removed with the help of a cryoprobe. And again, interestingly, the histopathology revealed large dilated vascular spaces lined with endothelial cells, and it was surrounded by spindle cells with myxoid component, and there's no atypia. This was suggestive of an angioleiomyoma of the orbit. So the post-operative period, the patient had a vision drop to 618 with an RAPD and movement limitation in elevation and adduction to -3. She was treated with IVMP and oral steroids, and fortunately, she improved very well. And at the end of 6 months, her vision was 6.6 with the extraocular movements being full. This is the imaging picture at the 6 months post-op period with a small residual at the apex. This is a 37-year-old lady who presented with an incidental diagnosis of an orbital mass for 2 years. Her vision was 6.6 and no proptosis was noted. And on imaging, a well-circumscribed extracorneal lesion between the superior oblique and superior rectus muscle was noted. It was iso in T1, hyper in T2 with delayed contrast filling, again suggestive of a typical cavernous hemangioma. She underwent an excisional biopsy with ease. However, the histopathology was a surprise. It was again a feature suggestive of the angioleiomyoma. So angioleiomyoma are benign smooth muscle tumors which most commonly originate from blood vessels. They again mimic cavernous hemangiomas, and angioleiomyoma belong to the vascular variant of the leiomyoma. So since they also do not have a capsule, just like the hemangioendothelioma, tethering to the adjacent structures should be anticipated as there are higher risk of perioperative complications unlike cavernous hemangiomas. It has excellent prognosis and recurrence is rare even after following an incomplete removal. Hence, it would be wise to leave a little bit of residue in case the surgery is very difficult and not go in for a complete surgical removal, which can damage and cause severe postoperative visual loss. So the take-home message is angioleiomyomas and hemangioendotheliomas mimic benign, easily removable cavernous hemangiomas. However, at times they could be something else these which cause tethering to the adjacent structures because of the absence of the capsule and the pathological features. So appropriate surgical management and detailed preoperative counseling is essential in every case. Thank you so much for your patient listening.
Thank you, Dr. Varsha. Any questions? I will request the speakers of the session and the panelists to please come gather for a photograph.
We'll have the working tea, and after this, we'll felicitate the LOC members who have worked hard to organize this event, and then we'll have a keynote by Dr. Mangesh Dopika. So I take this opportunity to thank my colleagues, my seniors, the LOC members who have really worked hard to organize this successful event. Successful in my eyes, otherwise it's successful because of the delegates and faculties who have made so long way to come here despite the odd situations in the country. So I first call my guiding light, Dr. Gaurav Luthra sir, and I request Dr. Abhijit Kaur ma'am to felicitate him. Dr. Vipul Arora sir. Dr. Gaurav sir, please be seated nearby so that we have a group picture. Dr. Sushil Oja. Dr. Neeraj Saraswat. Dr. Sukhdeep Kaur. She is the scientific committee chairperson and she has worked hard to craft these sessions. And Dr. Shubha, मैं भूल नहीं सकता तुम्हें. She is the program coordinator. And Dr. Gaurav Shah, he coordinated the PRYOGSHALA very efficiently. Thank you so much to the family.
And last but not the least, Dr. Vishal. Let's give him a big hand.
Yeah.
So coming to the बोल दो लीजिए. So we'll quickly announce the winners of the e-poster and video and photography sessions. Oh, can we have it?
Dr. Prerna Hello. Start kar. Dr. Prerna Chaudhary gets the first prize in the video presentation. I request Dr. Rajesh Tiwari sir to please do the honors of presenting. Yeah. Could you, hi Dr. Prerna, could you please mention the topic of your video?
My topic was eyelid malignancies complicated by orbital meiosis.
Ma'am was Dr. Kamna Verma, the second prize for video. Dr. B.K. Oli sir, kindly do the honors. Now, Dr. Banka Mega Ajay. Dr. Banka Mega Ajay gets the third prize for the same. Now announcing the prizes for the e-poster. Dr. Zahir Ansari gets the first prize. Is he here? Dr. Prerna Chaudhary gets the second prize. Dr. Rajesh Tiwari, sir, please. Dr. Prerna. Prerna. Dr. Varsha gets the third, please. Not.
Thank you so much. Thank you.
In the category of photography, the first place goes to Dr. Farnaz Ahmad Khan. The second goes to Dr. Priyanka Valvekar. And the third goes to Dr. Ashwita Alva.
So with this, we move ahead for the keynote address by my mentor, and I'm honored to introduce him, Dr. Mangesh Dobekar, who is a senior oculoplastic surgeon at Shri Ganpati Netralaya, Jalna, Maharashtra. A masterful surgeon, talented artist, and humble soul, my trusted mentor, and a person to go to. He is trained at Shankar Netralaya, Chennai in oculoplasty, and he has special interest in orbital surgeries and dacrology. Over to you, sir.
Thank you, Vishal. Am I audible?
Yes, sir, you're audible, sir. Please go ahead.
Slides are visible, Vishal?
Yes, sir.
Okay. So at the outset, I would like to thank Vishal, Dr. Sukhdeep, and the team LOC MID-TERM OPAI for organizing such a wonderful, flawless conference, and physically as well as virtual mode, and that is too on the 11th hour, and giving us an opportunity who could not present there. So I'll be talking on the mistakes, lessons, and the protocol. Actually, this is a series of near about 10 to 12 cases, and there will be a short commentary about the protocols. So just listen. All these are the interesting cases. Some of these are the cases which are very common, but mistake happened. Let us see what happened. So first case is the no means no. You must have seen a Pink movie in which if anyone says no, it means no. So this is a story of 78 years old female patient. She had history of diminution of visions in childhood. She had history of eye surgery in the past, history of recent injury to the left eye with a kid's hand, and she developed pain, redness, swelling since last 8 days. She was having no PL, left eye total corneal med with iris prolapse. Movement restriction was there along with the conjunctival chemosis. Right eye was a pre-thysical. B scan showed hemorrhagic CDs with a T sign, and the cornea and the vitreoretina intervention was not there. Right eye, it was a pre-thysical eye, and the left eye now diagnosed to have a left eye panophthalmitis. So preoperative counseling was done. Patient was hard of hearing, so explained to the relatives as well that there was no visual prognosis, and surgery is not to improve the vision, but to prevent the spread of the infection. Next day, patient was on the table, vital stable, OT trolley was ready. Re-explained about the surgery and the need of local anesthesia as well as the injection in the form of for the periverbal anesthesia in the form of local anesthesia. But what happened? She suddenly said no. No means no for the surgery. Despite explaining everything, she said no. We explained her everything that we have informed your relatives and what are the consequences and the pros and cons. She said, I means no. Who the relatives are, who the hell the relatives are, tell and give permission on behalf of me. I've been living with this eye since last 78 years and I will live it rest of my life. So I don't want any surgery, and it was not informed me before like this. So this was no means no. So was it a mistake? Was it inadequate counseling or uninformed eye removal. It was a near miss event. Mistake is avoided by following the protocol while the patient is awake before giving any incision or the anesthesia. Why did it happen? Over assumption, taking the things for granted, inefficient preoperative counseling. And what is the lesson? Any surgery is an important procedure, and make sure that patient understand it before any incision or anesthesia. Second case is actually a Judwa. This is the case of two beautiful ladies. A is the 75 years old female patient. She was diagnosed to have primary acquired nasolacrimal duct obstruction, and the she was diagnosed to have right lower lid entropion. Now you can see these are the look alike, sound alike like drugs. Okay. So patient A was actually advised the external DCR, patient B was advised the entropion correction. I asked my resident to keep the DCR patient ready, block the nasal packing, give local anesthesia, nasal packing, and the corneal sheath. What happened actually, the DCR patient was ready. Then just out of the, I asked each and every patient before the surgery and any incision, is there any watering in the other eye? He said, no, it's fine. But this side eyelashes do irritate me so much that I get watering. So this was a patient A or this was a patient B. So we get confused because after local anesthesia, there was no entropion. When we reconfirmed it, we checked everything, and then it was a right eye lower lid entropion patient. So nasal packing was removed and the entropion correction was done. So there was exchange of the patient. So it was a wrong patient. It was again a near miss event, wrong patient, over assumption, taking things for granted, and failure to follow the protocol. What is the lesson? Don't rely on others or even on your memory. Just follow the protocol. Coming to the case 3, that is left, right, left. This was the patient who was actually diagnosed to have a left eye primary acquired nasolacrimal duct obstruction, and she was planned for the external DCR. She had a history of right eye external DCR years ago, but even this time she was very anxious, and the IM sedation was given for her. Patient was on the sleep mode, local anesthesia was given, and I was just about to do the nasal packing, and then I realized, I startled that, oh, what is this? Is it a right or wrong eye? It is the right or left eye, but it's the right, and it's the left eye to be operated upon. So we did right eye nasal endoscopic examination only, and then I just shifted to the left eye, gave the local anesthesia, and the DCR surgery was uneventfully completed. So again, wrong anesthesia was given. Why? Failure to follow the protocol when the patient is awake. What is the lesson? Again, same, just follow the protocol. Have you ever performed surgery on the wrong eye? If yes, you are not alone. 1 in 4 ophthalmologists have done it already, but it is often underreported. Is an enucleation of the wrong eye possibility? Don't worry, I have not enucleated any wrong eye, but wrong kidney, wrong limb amputation, wrong finger, wrong eye squint surgery, wrong eye cataract surgery, and the wrong lens implant can happen. Still, enucleation of the wrong eye is a possibility, and it's rare. It's not published, it is underreported, but near miss events are very common, a possibility that cannot be declined. Actually, this was in 1946 when the Traquar had an article about the removal of the wrong eye. He said the most terrible disaster which can occur to the ophthalmic surgeon and to his patient is the removal of the wrong eye. But most stories were common, near misses were common. If there is no eye marking, this can happen. In general anesthesia, when the patient is not able to tell you, this can happen. Intraocular tumor, when the anti-segment examination is totally normal, this can happen. So it's very important to have a pre-incision fundus examination in all cases with intraocular tumor. Coming to the 4th case, that is invisible. Let us see what is invisible here. This is a case of 30 years old female patient. She had a history of injury with a grass cutting machine a day ago, vital stable, no history of unconsciousness, nausea, vomiting, or the nasal bleeding, inconsistent PL. It was actually open globe injury with extensive corneoscleral tear with a uveal tissue prolapse, upper and lower lid margin tear, no canalicular involvement, advised CT orbit, the patient was not willing. So just for the screening, we did the gentle B scan. There was no evidence of intraocular foreign body. So plan was complex wound repair with upper and lower lid reconstruction under GA and the GVP. Preoperative counseling was done. Financial restraint, all the charges were actually totally waived off. It was taken up by the retina surgeon. I got a call from the OT that there is an intraocular foreign body with extraocular extension. I said, where are the CT films? CT orbit was not done, and B scan was suggestive of no evidence of intraocular foreign body. But what happened intraoperatively? I was suspecting that there could be a very small foreign body which might be there in the just outside the sclera, but this was a big, and this was bigger again, and this was the biggest. So there was a foreign body which was lying in the inferior orbit. It was going to the medial orbit, and even it was even coming out of the medial orbit also. So with a very careful exploration, a long piece of the metallic soft bed which was removed, lying horizontally mid to medial orbit with a fracture of the medial orbital wall, entrapped in the inferior rectus, inferior oblique, and the medial rectus muscle as well. It was released, and no other intraoperative complications were there. This was a terminal part of the saw machine blade. So it was sort of the mistake. Mistake was miss intraocular in the intraorbital foreign body because there was no strong suspicion of the foreign body. So lesson is over investigate all the trauma cases because it is full of surprises. Coming to the next case, that is kahi pe nigahe, kahi pe nishana. This was a case of 35 years old male patient. He was passing by the police station. Suddenly, right eye got hit by something. He consulted locally. Right eye was diagnosed to have a pellet gut injury, and right eye was having the open globe injury, scleral tear, and query it was suspected based on the history that there could be an intraocular foreign body. B-scan screening was done, actually, the general screening was done, vitreous, multiple dot and clump echo hemorrhagic CDs, but there was no evidence of the foreign body. So additional imaging was done, and it showed there is a right eye intraorbital foreign body. It was away from the globe actually, and actually then patient was taken to the OT for the scleral tear repair. And then I got a call from the OT just before the OT. What is your plan for the intraorbital foreign body? So I said, just let me check the images. And when I saw that there is a foreign body which was lying in the posterior part of the orbit, and then I suddenly realized that this is not something routine. It was actually a left eye intraorbital foreign body, and this was really a surprise. The foreign body travels from the right eye to the left eye through the nose. So this was really a surprise to us. Right eye was scleral tear repair was done. OS vision was 66 and 6, no RAPD. Patient was actually very concerned about the left eye, but we assured him and asked him for the regular follow-ups. So what was the mistake? It was a wrong interpretation of the imaging. Over assumption, taking the things for granted, no strong suspicion of the foreign body in the other eye. Follow the protocol even while reading the films is the lesson. Coming to the next case, that is got it. So this was a 4-year-old male child with a history of injury to the right eye and the forehead by the clutch of the motorbike which fallen on him. Actually, he consulted locally and the patient was referred here. No brain parenchymal injury. Patient received primary care. A patient had the secondary infection also. Parents were very anxious and repeatedly asking for the immediate surgery, not willing at all for the CT orbit. We got the CT orbit. And there was associated RAPD, globe was down in out position, all the extraocular muscle movements were restricted. Medial rectus disinsertion, mild proptosis, no pulsation or bruise, secondary infection was also there. And then CT showed there is a medial rectus disinsertion, frontoethmoidal fractures, optic nerve head, avulsion, and there was associated lesions as well. But what we found here also that there is a partial optic nerve avulsion also, and there was a sheath of the that was residual over there. Associated cribriform plate fractures were there, fractures, and there was a retro and the inferior orbital hematoma as well. So based on this, the neurosurgeon and the skull-based surgeon opinion was taken. They were of the conservative thing. And in case of the partial traumatic optic nerve avulsion, though it was very guarded as well as a nil visual prognosis, but we gave a trial of methylprednisolone. But the main concern was what to do about the upper eyelid loss. Because if it is a total upper eyelid avulsion, the attempt to retrieve the avulsed tissue was done, it was not found. Then we had a median forehead flap option, temporal forehead transposition flap, that is the Freakies, Mustard's lead switch, or the Cutler beard fish flap. So let us go to the OR and see what happens. And further exploration, we did the medial wound exploration, and then we were about to do what to do about the upper lid, and then we explored the lid part. And to our surprise, what happened? There were the lashes, and the lashes was from the lid, and we could found that the entire lid is there in the inferior orbit, and part of it was going into the retrobulbar area. And we could found that it was a viable lid, and it was then repositioned back. It was a total lid, Medial rectus was also revived back then. Canalicular tear repair was done. LPS was reattached, and this lead was repositioned back. The patient was doing well. He is under follow-up right now. Movements also improved. Medial rectus movement improved. So actually, let us look back at the images. What we were thinking of the retrobulbar hematoma or the infraorbital hematoma was the lead actually. So we got it eventually in a very surprising manner. So it was a mistake, no mistake, but it was a surgical surprise. Not ordering an imaging would have missed important findings. So why inadequate evaluation and non-ordering imaging would have been disastrous, because we would not have suspected all these things. So over investigate all trauma cases, for it is full of surprises, especially in the kids. Coming to the next very interesting story, that is the sweet story. This is a 36 years old gentleman, history of a road traffic accident a day back. Riding on the bike, got hit onto the sugarcane trolley from backside while taking the sharp turn. Sugarcane gone inside and stuck into the left tire, nausea, vomiting episode. Once the attending clinician, what mistake he did, he tried to remove the foreign body, pulling it outside. The patient was vertical, became horizontal. Patient collapsed with a loss of consciousness. The patient was then again revived. Vital got stable, under observation for 12 hours, referred for the eye injury in the foreign body. There was a decreased vision, PLPR, but were accurate, severe pain on the attempted ocular movements, not able to open the eye. There was a large rodent foreign body. And then we did the imaging with the apical 1 mm cuts as well. And it showed there is a large foreign body in the inferior orbit, 27 millimeter into the orbits from the skin surface, just short of the apical structure and inferior to the optic nerves, with peri-transection of the inferior rectus and the blood fractures of the floor and the medial wall. A foreign body was intending the globe from the inferior side, but no obvious globe injury was there. So with all these provisional diagnoses, our plan was to go ahead exploration and to address each component accordingly. There were multiple components over there. So I will just keep this video short of time. So we removed this large wooden foreign body, and there was actually, it was entangled into the inferior oblique as well as the inferior rectus muscle. They were partially lacerated. We did repairing of those things also. And then the patient was doing very well. Even the pupil was normal size, reacting to light. Extraocular movements were okay. Vision was 6/6, and there was no diplopia. So this was a sweet story of the sugarcane. As you can see over here, and this was the outcome post-op day 7, sweet story of the sugarcane. What happened? It was a near miss event because improper technique of the removal of the foreign body in the OPD itself can lead to the catastrophic sequences, and you need to be very systematic in all these conditions. So, or investigate all trauma cases because it is full of surprises. Coming to the 8th case, that is a knot again. This was a story of 8 years old female patient, history of injury with the sugarcane 6 months ago as per the parents. Diagnosed via anterior staphylomas with a painful blind eye, consulted locally. She was advised and referred here for the evisceration and the ball implant. No GA facility was there, so patient was referred here. Patient had actually the proptosis, exposure keratopathy, tenderness, very suspecting the mass lesion, and other eye was WNL. But the history was not consistent with the clinical picture. What we did, we just probed into the history, and what we found that there was a history of prior consultation 1 year back. B-scan was also suggestive of query calcification with calcification of the posterior ocular port, query intraocular mass lesion. That time, additional imaging was also advised, but patient lost to follow-up, and the patient did this imaging 6 months ago. But you see, what is the report? Report says left eye normal in shape, disintegrated lens noted with few high HU foreign bodies in the vitreous chamber and the vitreous hemorrhage noted. Actually, at that point of time, patient was asymptomatic, and only the CT report was noted, and the patient was sent back, and whenever asked to review if there is any pain, redness or swelling, or if the patient becomes symptomatic. And the patient presented with this. Then we did the EUA, bone marrow CSF analysis, system screening, orbital imaging, as well as the brain screening. And then we diagnosed it to have orbital retinoblastoma. Multimodal treatment for the orbital retinoblastoma was started on. Patient is doing well and alive. He is doing well. So wrong interpretation even of the imaging can lead to the delayed treatment of the life-threatening condition. So it's very important that you should correlate clinico-radiologically, read images yourself and correlate the clinico-radiologically all these cases. Coming to the 9th case, that is first, do no harm by the Hippocrates. So this is 33 years old male patient, history of the febrile illness and hospitalization for 2 weeks a month ago. Pain, tenderness, decreased vision, diagnosed to have an endogenous endophthalmitis based on the history. Patient was posted for the past plantar vitrectomy. Patient was having mild conjunctival congestion, AC reaction, hypopia, red glow, no PL vision. B scan showed vitreous multiple dot and clamtico hyperreflective because no calcification. Diagnosed to have an endogenous endophthalmitis. Pre-op counseling was done and the posture for the past plantar vitrectomy. What happened intraoperatively? Intraoperatively, surgeon failed on altered consistency of the vitreous. Vitreous sent for the cytology. It was a malignant round cell tumor, query, retinoblastoma. Surgery was abandoned and the ports to the ports, cryo was done and was imaging. So it showed and it was suggestive of the diffuse infiltrating retinoblastoma without calcification with optic nerve extension. Again, the patient was then subjected to the multimodal management of for the orbital retinoblastoma and the patient was also doing well. So there are a number of articles. This is a very good article by the Swati Kaliki, inadvertent intraocular surgery in children with an unsuspected retinoblastoma. And even in those cases, the death was seen in about 57% of the cases. There was actually another article in 2015 which showed that past plantar vitrectomy and the evisceration resulting in death due to the misdiagnosis of the retinoblastoma, because here after the evisceration only adjuvant orbital radiotherapy was given and no patient was given the multimodal management. So inadequate clinical evaluation and inadvertent surgery can lead to the delayed treatment of the life-threatening conditions. So failure to correlate clinical radiologically leading to the misdiagnosis and the misdiagnosis as well. Follow the clinical protocol. Coming to the 10th case, that is a brown frown. This was a 66 years old male patient diagnosed elsewhere with a neovascular glaucoma, painful blind eyes, referred for the evisceration ball implant. Preoperative counseling was done and patient was posted for the surgery. Next day, I was at the conference, so I just gave the information and the patient actually next day was taken up for the surgery. And just I asked, where is the B scan? See, they said the B scan was done. Then I sent the patient back to the OPD, got the B scan done, and the B scan was suggestive there is a infratemporal quadrant mushroom-shaped lesion was there. And then we did, it was suggestive of the choroidal melanoma. So MRI was also suggestive of a T1 hyperintense lesion, which is again in favor of the melanoma. And then patient was diagnosed to have a secondary glaucoma with a sterile orbital inflammation secondary to the tumor necrosis and the choroidal melanoma. Then we patient subjected to the systemic screening, elective was raised, and you can see there was a secondaries in the liver. And actually patient succumbed to the conditions after 6 months. So inadequate clinical evaluation may lead to the inadvertent surgery in life-threatening conditions. So it is very important to correlate clinico-radiologically, follow the clinical protocol. And there have been multiple, this very good article by the Ralph Eagle, which shows that inadvertent evisceration of the eyes containing the EVL melanoma, which was published in 2009. And again, this was in a very old article in 1968. There was a malignant melanoma of the choroid presenting as a panophthalmitis, but it has been there since 1968, even up to the 2022, that UL melanoma presenting as a panophthalmitis in the absence of an intraocular mass lesion. So we should learn out of all these things. Coming to the next case, that is the 11th case, yellow story. So what happened in this case? This was a 1-year-old male child and he had a lesion over the forehead, and all that lesion infection actually spread over the right side of the face. Swelling was increasing gradually and involved right half of the face actually. Febrile and irritable child of folliculitis over the right side was there, which was actually healing, but the rest of the face was having the swelling and all those things. Patient was advised admission under the pediatrician care and advised imaging and the blood investigations. CT was also consistent that there was a multiple abscesses in the periocular region also, and it was a post-septal extension into the anterior, into the extraocular space, as well as in the superotemporal fascia of the tissues. And then the patient was actually started with the IV vancomycin, amikacin, and the metronidazole as per the weight under pediatrician care for the 2 days. But there was actually a, again, progress of the lesion. So surgeon and the maxillofacial surgeon opinion was taken, exploration, IND, and the debridement was actually planned. What happened, we found that there were multiple abscesses right from the forehead to the upper brow, then upper lid, lower lid, facial region, temporal region, and even the maxillary region. And the specimen was then sent for the microbiological examination. There were multiple pus pockets over there. And the first examination, the first microbiological examination report came, it was a Staphylococcus aureus. and the amikacin was omitted, and the vancomycin then continued for the next 5 days under pediatrician care, but continued to have the fever spikes. Then we were thinking, if it is a Staphylococcus aureus, why it is not responsive to vancomycin? There was only a marginal improvement. Then we sent again one microbiological specimen. Patient started to develop the cellulitis. Again, fever continued. And by the time, actually, after 2 days, again the second report came, which was suggestive of the Klebsiella pneumoniae. And actually, then we shifted the patient, and it was initiated on the piperacillin, tazobactam, and the IV meropenem as per the weight, and the patient started to improve the next day. Fever spike decreased and the CRP reduced over the next 2 days, and the patient then started to improve. By the time the third specimen also came, it was suggestive of the Klebsiella pneumonia. So if you say, what is the problem? If there is a delayed diagnosis and the delayed treatment of this condition, what was the cause of the delayed diagnosis? When we probed back, then we found it could be a mislabeling of the specimen, because 2 other surgeries of the IND were done on the same day, and it could be one of the cause for the delayed diagnosis. And the Klebsiella pneumonia induce multiple invasive abscesses, and sometimes it's very severe and the life-threatening as well. The choice of the antibiotic is very complex in such scenario and should be adjusted according to the assessment of the illness, and surgical intervention considered in all such cases. So mislabeling of the even microbiological specimen can lead to the delayed treatment of the life-threatening conditions. To failure to follow the surgical safety protocol, we'll come to it later. This is the last story, that is a blue story. Now let us see. This was a 27 days old baby. She was diagnosed to have a bilateral congenital dacrocystocele, recurrent acute episode, left side lacrimal abscess with orbital cellulitis, thrice over a period of 2 weeks. There was a febrile illness, respiratory difficulty. Imaging was showing bilateral congenital dacrocystocele with a bilateral intranasal cyst. Actually, we were about to manage it conservatively, but the patient improved and then again developed the acute episode after 3 days, and then patient was again developing the orbital cellulitis also repeatedly. So it was decided to go ahead with early probing under nasal endoscopic assistance under GA. Preoperative counseling of the parents was done. Neonatologist fitness was taken. We had a experienced anesthetist NBM with IV fluid maintenance who was actually done properly. All investigation check, nebulization, neonatologist standby, anesthesia machine recheck. Plan was endotracheal intubation and the throat packing. And what happened actually when the patient was about to induce, after the induction was given, they were ventilating, but I'm not actually anesthetic, but what inference I could see, I could draw. Actually, the patient's SpO2 was actually decreasing, and from the 100%, it went to even to the 30%. Everyone was panicking, but our experienced anesthetist and the neonatologist standby, actually at the 30%, they tried to intubate, but it was repeatedly failing, and the patient was also not ventilating properly. And at the last time, under video assisted laryngoscope, they could actually see the vocal cords, and they were having laryngospasm, and the patient actually could intubated later on, and then SpO2 within a period of even 90 seconds improved to 30 to 100%. So this was a blue story. And when actually the patient and the surgery was done uneventfully, later on the patient was doing well, and he was also very surprised that what happened actually to me. So what was the mistake? It was the inadequate preparation in the anesthesia. Was it like this? But we had all the preparation. But it can lead to the life-threatening consequences in all such cases. One unanticipated event and the high-risk anesthesia. Any pediatric anesthesia is a high-risk procedure, follow the clinical protocol. So all these were the mistakes in all these 12 cases. So what happens? So whenever there are the mistakes, one feels guilty. But how common is this? We should introspect. What are the risk factors? What can be done to prevent it? It is 40 times a week in the United States. Numbers might even be more because it is often underreported. Invariably, it attracts the media attention, so it is underreported. Undermines the public confidence in the healthcare system. What are the risk factors? Immense burden on the healthcare system, high number of cases and the documentation, increased reliance on the one's memory, no system or the protocol in place, not familiar with the new safety protocol. It is more common in procedures associated with the bilaterality in ophthalmology. Failure in communication between the team members, no discussion about the atypical or the complicated cases, not following the red signals or the alerts. What are the additional risk factors? It is a captain of the ship mentality. मैं कहता हूँ वही करना है बस. Surgeon team hierarchy कि सर को कैसे बोले, मैडम को कैसे बोले, दो तो सीनियर है. Culture of blame and the punishment, compelling incentives for the speed and number is the cause. Little attention to the mere misses, not learning from the other's mistake, and one wants to experience all of them in a lifetime. Failure to adopt the best practices, litigation and confidentiality is another issue. So what can be done to prevent it? We all make mistakes and none of us are perfect. If mistake happens, rest have to be supportive and understand. If no mistake so far, aware, your time may still come. As a profession, we need to strive for the better system and the protocol. So surgical safety checklist is an option. It should be employed in all OR teams, all patients and all team. It has a 3 components actually. It is the first one is the sign in. It is before induction of the anesthesia. And what are the components? You need to check, has the patient confirmed his or her identity, site, procedure and the consent? Is the site marked? Is the anesthesia machine and the medication check is complete? Is the pulse oximeter on the patient and if it is functioning, if required, it is used? Does the patient have a known allergy, difficult airway or the aspiration link in the particular case, risk of more than 500 ml blood loss, and what are the preparation for this? Timeout is the second portion. It is just before the skin incision. It should be done with the nurse, anesthetist, and the surgeon. What are the components? Confirm all team members have introduced themselves by the name and role. Confirm again patient's name, procedure, and whether the incision will be made. Has antibiotic prophylaxis been given within the last 60 minutes? Anticipated critical events for the surgeon. What are the critical or the non-routine steps? How long the case is going to take? What is the anticipated blood loss? For the anesthetist, are there any patient-specific concern as far as the anesthesia is concerned? To the nursing team, has sterility including the indicated results been confirmed? Are there any equipment issues or any concern? Is the essential imaging displayed properly? Sign out is the third component. Before the patient leaves the operating room, nurse verbally should confirm the name of the procedure, completion of the instrument, sponge and the needle counts, specimen labeling, read specimens labels allowed, including the patient name, whether there are equipment problems to be addressed, to surgeon, anesthetist and the nurse. What are the key concerns for the recovery and the management of this portion? Clinical protocol, actually.
Can you please brief us, sir?
Hello? Yes?
Hello. Sorry to say, sir. Can you please brief?
Yeah, 10 minutes, just 5 minutes, 5 minutes. So we should, I just urge all the oculoplastic surgeons that we should have a simple protocols, clinical protocol, like in the painful blind eyes. It should be applied to the adults and the pediatric as well. Intraocular tumor, unless proven otherwise, should be the things. B-scan, UBM and the photographic documentation should be done in all cases. MRI CT orbit with the brain scanning as appropriate. Enucleation if a mass lesion cannot be ruled out. Histopathological and microbiological examination is important for all cases. Lead and the orbital injuries. All lead injuries are associated with the canalicular tears unless proven otherwise. May be associated with the orbital and optic nerve injury also. Do not hesitate to order imaging in case of atypical clinical picture. Over-investigate all the cases. Review the images yourself and not just the reports. For the orbital surgery, do you need any additional investigation? What is your differential diagnosis? Exploration is not a plan. You should have a concrete plan. Thorough preoperative counseling, whether it is done, what is your separate approach, brain required or not. For the lacrimal surgery, whether it's Roplus positive or not. History of acute episode trauma, previous surgeries, do you need additional investigations, patient on the blood thinners? Have you explained about the post-op nasal bleeding, throat pack in case of the pediatric and the cases under GA? Anesthesia, even we can say that endotracheal intubation is safer than the IV sedation in the probing, and whether we should go ahead with the pediatric standby mandatory in less than 2 years of the age. And we should have, if there is a mishap happen, there should be a clear mishap plan. NICU, PICU, backup mandatory. We should have a MOU with all these techniques, with all these setups. So take-home points is that we have accumulated stupendous know-how, but know-how is often unmanageable. Avoidable failures are common and persistent, demoralizing and frustrating across many fields from medicine to finance, business to the government. And the reason is increasingly evident, the volume and the complexity. The knowledge has both saved us and the burdened us. Need of different strategy for the overcoming failure based on the experience and the knowledge, but also makes up for our inevitable human adequacy. And there is a strategy, it's called as a checklist. Active implementation is the key. Please don't make it a checklist. You just go through this book. This is the checklist manifesto by Atul Gawande. It's a very good book. And the last point is that be mindful always when you are a surgeon. Be sincere, not serious. Just slow down a little bit. Thank you very much for your kind listening for such an exhaustive talk. Thank you so much.
Thank you so much, sir, for the detailed lessons that you have learned from your life in the OR, in the OPD, in the clinics, and sharing them with all of us so that we all can prevent such incidences happening into our practices. Thank you so much, sir. And we are sorry to stop you in between.
No, it is very.
Because of the time limit
Yeah.
that we are having. Thank you. Thank you so much. So I hand over the mic to Dr. Shubha for the next session.
Hello. We quickly move on to the next session, dacryology. I would request Dr. Nidhi Pandey, Dr. Nidhi Rana, Dr. Mangesh Dobekar, sir, Dr. Aditi, if present, to kindly chair the session, please. And I request Dr. B.K. Oli, sir, to kindly start the session for this talk, Techniques of DCR Surgery. Sir, please.
So I've been doing DCR surgery since 1980 when I was resident. And our professors used to go away after doing cataract surgery, and it was little boring and difficult and less result. So there are 2-3 problems. It is not continuing. Okay. So there are some problems. Plain, you have to decide bleeding is a problem, thickness of the bone, which cannot be cut by Chidley's punch or bone trephine. Stitching and dissection of posterior flap is also very difficult. So we had been doing how to overcome these problems. First is bleeding. So I'll focus on bleeding, number 1. Second is cutting of the bones. These punches which were available in the past, these trephines which we used to use, now some new things are available, like these cauteries which have got very precise type of needles which can go inside. They are curved. They can stop the bleeding from inside the bone also. And second is very important instrument. This is micromotor. I don't know how many people are aware of it. It has got different type of heads. It moves. It rotates like dental drill. So instead of breaking or cutting the bone, we drill it. Pain is less. So I'll emphasize on these 2-3 things. I'll just show the steps and importance of these 2 instruments which we use. And third instrument which we use is cataract knife. Instead of using straight knife that is curved, 0.2 or 0.22 or 0.28, they are curved and easy to cut nasal mucosa. Just to give presentation, identify the sac. After the ligament. Now, initially you can open with bone trephine or Chidley's punch, which everybody is doing. But things are different after this. Soft bones can be managed. Hard bones, thick bones cannot be managed with Chidley's punch or bone trephine. You are in dilemma what to do. So just watch after Chidley's punch and identify the sac. This micromotor. You can make big, smooth hole with the help of this micromotor. You can control the speed. You can change the head like a dentist changes his head for different work. You see, small spicules of bones are being removed by micromotor, and I'm making bigger and bigger hole. Smooth again. Now, in lower area, again, I'm going down also. Upwards, downwards, thick bones, all can be, you can grind with the help of this micromotor. Little downwards again. Now, see, bleeding is there. It will be difficult to proceed. A curve. we'll be using a curved cauterization for this, curved needle for this purpose. So I don't like spicules. They may create problem while doing stitching. Or even after good surgery, if patient touches, rubs his eyes, these spicules may break your sac and nasal mucosa. Look at the cautery help of the cautery. It is curved, and different tips are available. At least 20 type of tips come with this machine. Using cataract knife 2.8, see how easy it is to cut the nasal mucosa because this is curved and sharp. Making flap or lacrimal sac is not so difficult because it is relatively superficial. At this point, I want to mention that stitching of posterior flap is guaranteed for the surgery. If you don't stitch it, you may have trouble. So this posterior flap, after that anterior flap, that is normally done. And after that, you have to anchor this anterior flap into the subcutaneous tissue so that it does not fall back, fluid does not collect. And this is being anchored with the periosteum. This is normal subcutaneous stitches. If you do this much, you are happy doctor and happy patient. Reports were 85% success in cataract surgery, this DCR surgery. Now I guarantee more than this to the patient. It rarely happens that you don't find good mucosa, nasal mucosa. It happens. Then we have to stitch this lacrimal sac to the periosteum. Results may or may not be good. Yeah, this is almost over. Thank you.
Sir, do you have any questions?
Yeah, please. Take the mic, please.
Thank you, sir, for the wonderful video. Sir, I would just like to ask, what is the advantage of stitching the posterior flaps over just excising it? We normally just excise both the posterior flaps.
By keeping the integrity of posterior flap, you are making a tunnel through which tear passes. And if you stitch only anterior flap, there is no tunnel. It goes to the nose, anywhere. You are not directing the tear to any particular place. You are creating something abnormal passage if you don't stitch.
Thank you.
And that is a success of your surgery. Yeah, please. Please use mic for.
First question regarding the drill you are using for the nasal bone.
I can't hear you. A little closer.
First question, you are using micro drill for the nasal bone. There's the bone fragments that get dislodged. In future, they may form the granulomas there.
Okay. So the question is, as I have heard, the small spicules or water substance is being released by grinding the bone that may form granuloma. This is the question. Yes. So my answer is, you wash it thoroughly. So far, you have not opened the nasal mucosa. You wash it thoroughly, and at the same time, you have to wash this cavity several times because it is bleeding. Hardly anything is left. You wash it, and at the last, because you have seen this much of discharge from mucosa, you have to, at the end, give a gentamicin injection at the site to prevent infection. So it is very less likely, not seen so far.
Second question, does the drill sometimes hit muscles or affect the other tissue there?
Can there be damage to the soft tissue while you drill?
Yeah, I try to do cataract surgery. I might perforate posterior capsule. Anything can happen in surgery. But it is visible. You are operating under 9x. How can it happen? You have seen it, me doing it. How can you touch other tissues? I don't agree with this.
Sir, excuse me, the last question.
Yeah.
This is Dr. Mangesh Dobekar. So, what is the specific advantage you feel of the micro drill over the manual bone punch?
If you use bone punch, if the bones are thick, you can't do anything to those bones. You can't make a good hole. And this
larger bone punch then?
There is a limitation. Larger bone punch will not go into the hole first. Most of us are doing DCR surgery because this is oculoplastic conference. So large drill or large punch does not go into a small hole. Unless it goes in, it will not cut.
But
that is a problem.
We'll need to go in a serial manner. First the smaller one, then the medium, and then the larger one.
Yeah, you are right, sir. But even the largest one doesn't go in at times, and at times it happens. Even if it goes, bone is so thick, it does not cut the bone. And more of a pain. Bone not only cuts, it moves also. It's painful. And grinding is not painful. Just wash it thoroughly after that.
But just my concern was to add additional instrument in the very limited space over there.
It is your
that
choice.
is another way of doing DCR. Thank you.
Right. Thank you so much.
Thank you for the questions. Do we have Dr. Gavita Joshi here? She would be here to present her talk from syringing to DCR, tale of a retained cannula.
A very good afternoon to everyone present. I would be presenting my case in the dacryology session from syringing to DCR, tale of a retained cannula. We all know that syringing is quite a routine common OPD procedure, which is performed every day in our OPD. And it is a very simple diagnostic test, which is used to assess the patency of our lacrimal drainage system. Now, whenever we do syringing, I'm sure most of us only try to interpret our syringing findings, whether it is a canalicular block or whether the system is patent or whether it is an NLDO. But does something more lie beyond the horizon? How many times is a DCR surgery being performed because of a simple syringing procedure? Sounds quite unlikely, isn't it? But wait, we have a plot twist. Today we present before you an unexpected sequelae of a routine diagnostic procedure. The patient who presented to us was a 51-year-old female, and she had a complaint of pain and swelling in her right-sided eyelids and sac region since a day. Now, there was a history of attempted syringing at one of our peripheral centers, and this resulted in the lacrimal cannula being broken and impacted. So what might have happened is that, while performing syringing via the upper puncta, with the pressure of the fluid, a part of the cannula might have got broken and impacted. So on examination, we could find erythema around the skin of the upper eyelid and the medial canthal region. There was also some edema. There was tenderness on palpation. Also, we could see a scar mark. So when we asked the patient again, she gave a history of some old lacrimal surgery, for which we did not have any documentation at that time. However, we could neither see or palpate the broken cannula externally. So what did we do next is we set our patients to get scans done, and on NCCT orbits, we could see a hyperdense radiopaque foreign body, that is our cannula, and now it was lying at the junction of the sac and the NLD. So what do we do next now? Because there was a risk of iatrogenic dacryocystitis if we let it be, surgical extraction of the cannula was considered necessary. So we went ahead and did a diagnostic endoscopy in our OPD. However, the cannula could not be visualized and its retrieval was not possible. So we thought of exploring and removing the foreign body through the old scar, that is the teardrop incision. And ultimately, we excised the sac and found this broken half of the cannula at the junction of the sac and the NLD. So we can see its rust-coated base over here. So ultimately, the patient underwent a revision DCR with intubation under local anesthesia. Coming to the review of literature, there have been quite a few case reports of NLD, of foreign body associated NLD obstruction. Just want to highlight two of these. Now, this was a 25-year-old female who had recurrent bouts of dacryocystitis, history of probing in childhood under GA, and this resulted in the cannula getting broken and impacted. Ultimately, many years later, it was seen on imaging and extracted. Similarly, a 10-year-old boy, he was hit by a BB from a pressurized gun, and he also had the same symptoms. And again, this was a foreign body which was seen surgically and then extracted. Sorry, it was seen on imaging and then extracted. Now, this is the first case report of a syringing cannula being impacted and an early intervention being done. Going on with the theme of midterm OPAI this year, the twist in our case was that a routine OPD procedure took an unexpected turn when the cannula got broken and impacted. And the turn was that we found it stuck at the sac and the NLD junction. So what are the learnings from our case? No procedure is small. Smallest of every procedure is important, should be done gently and carefully. Routine inspection and timely replacement of our instruments is very essential. So please take care of your instruments. Thank you.
That was an interesting presentation, Dr. Gargita.
Thank you.
Any questions?
Thank you.
One question, ma'am. It was done in two settings.
No, sir. First, we did a diagnostic endoscopy in our OPD, but we could not visualize the cannula, so we could not retrieve it.
Surgical interventions?
Surgical intervention, we opened up the old scar mark, and then we excised the sac, we removed the cannula, and we did a revision DCR for the patient. So only in one sitting.
Okay. In one sitting means all these two steps were done?
Diagnostic endoscopy was done in our OPD.
Diagnostic endoscopy I'm not asking about.
Yes,
the removal of the cannula and the DCR was done in the same setting?
Yes, yes. Foreign body removal and DCR was done in the same setting.
Okay, that's the point. Okay, good case.
Thank you.
Thank you, Dr. Gargita. Do we
Thank
have
you, ma'am.
Dr. Sarat Chabra here?
Good afternoon, everyone. Thank you for this opportunity to present this interesting case before you. Giant sac swellings in the early post-op period following external DCR are infrequent. The usual suspects are a seroma or a hematoma, a post-operative wound infection, granulation tissue, incomplete or poor surgical closure, a dacryocele formation. This case draws attention because of its possible multifactorial etiology. A middle-aged male presented with a left lower lid swelling, which developed on post-suture removal syringing 7 days after an uneventful external DCR. Progressive painful increase in the swelling size, and the size of this swelling was larger than the primary sac swelling, and it obstructed the patient's vision. It was a 2 centimeter by 2.5 centimeter, tense, cystic, non-mobile, mildly tender, brilliantly transilluminant swelling with the superior border extending beyond the medial canthus, occluding the visual axis. The Rhoplast was negative. Hemogram revealed a marginally increased TLC. A CT dacrocystogram was done, which showed a bony ostium and a large sacculated swelling of the lacrimal sac, extending beyond the boundaries of the lacrimal fossa. The dye did not leak into the nasal cavity, and nasal endoscopy revealed granulation tissue. The bony ostium is visible on the coronal and the sagittal sections, along with the large sacculated swelling. For management, the patient was conservatively treated initially with oral antibiotics and anti-inflammatory medication for 2 weeks. The objective was to reduce the size of the swelling, and then exploration was done under local anesthesia. A dacrocystorhinostomy with an extended bony ostium and bicanalicular intubation was done. Intraoperative findings included a common canalicular stenosis, a thickened sac wall, granulation tissue bridge over the anastomosis, which extended to the bony ostium. A histopathology was done of the excised tissue, and the findings were consistent with those of an inflammatory granuloma. The results, this image is of the patient post-stent removal. The normal lacus lacrimalis was observed, no epiphora, and the syringing was patent. What can be learned from this case is that there can be a multifactorial etiology for a post-op swelling. It can be traumatic syringing, a seroma, a granuloma. Safe syringing for all patients is crucial. Revision surgery should address the canalicular status. There should be meticulous and gentle dissection, and asepsis is essential to avoid any granulomas. Retained fibers can be a nidus, and sac swellings can attain giant sizes. Thank you.
Thank you, Dr. Sharad. It's just one question. So
Yes,
what do you feel was the basic reason for formation of this? And when was the stent removal done? 2 questions.
Ma'am, the reason for the swelling, it could have been that there could be some procedural error during the initial surgery, and the person who did the syringing may have been a resident who was not involved of the exact status of the patient, or had not taken proper care during syringing. That could have been one, and the granulation tissue could have been any cotton fibers that were left during the surgery.
Like during the revision surgery,
Yes.
What was the status of the ostium? Because you mentioned that
Yes,
the
ma'am.
dye was not going
Yes,
into
ma'am.
the
Yes, ma'am.
nasal cavity.
Yes, ma'am.
So was it essentially a failed DCR which gave rise to acute dacryocystitis again of the recurrent? So why is it different from a failed DCR giving rise to acute dacryocystitis?
Ma'am, it could have been a failed DCR. The granulation tissue was another factor that was adding to the list of problems there.
And when was the stent removal done? Because in the photograph, it
Yes,
looked
ma'am.
quite a bit fresh wound,
Yes, ma'am.
which
Yes,
was
ma'am.
seen. And so when do you generally remove the bicanalicular stents?
Ma'am, this was done, I think, 2 or 3 weeks, I think, after the surgery.
Okay. Thank you.
Thank you. Do we have Dr. Syed Wajahat Ali Rizvi here?
Good afternoon, everyone. I'm Dr. Wajahat from Jain Medical College, Aligarh. And here I have an interesting case to present. It was about a 32-year-old male who presented with acute right painful eye for 2 days with associated diplopia on upgaze and painful ocular movements. There was past history of epiphora for about 8 months. And a patient in his previous record had documented patent NLD with a positive fluorescein disappearance test. There was a history of recurrent swelling on inner aspect of the right eye for 3 months, and patient used to compress the swelling, and there was regurgitation of the mucoid nasal discharge on compression. 2 days prior, that is prior to the presentation, he compressed the swelling and the swelling disappeared, but there was no regurgitation of the fluid from the nasal cavity and it disappeared. There was no other significant history. This is how the patient presented to us. The visual acuity was 6.6. The diffuse upper and lower lid swelling, conjunctiva was congested, and there was restricted and painful upgazes. There were elevated leukocytes on hemogram, and imaging was done. Initially, a CT was done, which showed a dilated sac, inflamed and dilated sac on the right side. NLD was wide, and nasolacrimal canal was also quite wide. It was normal on the left side. Then an MRI was repeated, and if you can see here, this is T2 saturated image, shows a peaking at the posterolateral aspect of the sac. And in the other one also, you can see a similar peaking. And there was extracorneal inflammation in the inframedial orbit was also there. This was a CISS high spatial resolution, which shows a membranous septa at SAC NLD junction. So we made a diagnosis of a ruptured SAC on compression. And we started the patient on a broad spectrum IV antibiotics and anti-inflammatory drugs. Patient was discharged a week later, and a DCR was planned after 2 weeks. Just a day prior to the planned surgery, the patient again presented to us with the characteristic features of acute dacryocystitis, a painful swelling on the inner aspect of the right eye. The patient was again put on the antibiotics and anti-inflammatory drugs, which were given for 10 days, and DCR was done 2 weeks later. And this is around 2 months after the surgery. The patient, on syringing, the pathway was patent, and the patient was asymptomatic. And the last follow-up, that is at 6 months, the patient has been symptom-free. So we made a diagnosis of atonic sac, which because of development of a membranous septa, because of inflammation, has ruptured on compression and has given rise to orbital cellulitis. So atonic sac is an underreported, and it is clinically characterized by watery eye discharge, and rarely it can present as a sac swelling. Nasolacrimal duct is mostly patent, and the diagnosis is made when the NLD is patent and there is a delayed fluorescein dye disappearance test. And it can also be made on a dacryocystogram. Self-proplas is a common practice in patients with chronic dacryocystitis, where the patient compress the sac to alleviate the symptoms. So the technique provide transient release, but sometimes it can be counterproductive, as in our case. So the patient especially with atonic sac, should be advised to avoid aggressive and repeated sac compression. And we offered early DCR to prevent such mishaps. So that was my conclusion. Thank you.
Thank you, Dr. Sai. Any questions from the chairperson?
Why did you perform an MRI in this case?
Because the patient is having a feature of orbital cellulitis, just to look how deep the things were. Yeah.
At any point in time before the surgery, was syringing attempted in this case, and what was the status of that, if just in case it was?
We didn't do the syringing because we had an apprehension, because the sac has already ruptured. On syringing, it might rupture again. Thank you.
May I take this moment to invite PK Oli sir. We would like to honor sir. May I request Dr. Rajesh Tiwari sir to felicitate PK Oli sir.
We move on to Dr. Nitish Arora for his presentation on bloody tears.
Yeah. Good afternoon, everyone. Thank you, Dr. Vishal, for having me here, and thank you, LOC, for organizing such a great event. I'll be talking about bloody tears. Bloody tears or hemolacria is a problem where the patient has blood in his tears, which is very commonly seen in movies or horror films whatsoever. Represents regurgitation of nasal or sinus bleeding to the ocular surface, or it can be coming from the ocular surface itself. So we'll make some ground for it. So history is very important in this. Laterality, where is it bilateral or unilateral? Duration and frequency, the pain is associated or not? There is burning or itching. There is exacerbating factors are there or not? History of facial trauma or eye trauma, any history of intraocular surgery or extraocular surgery, the personal and family history of a patient of hematological disorders, history of vascular lesions around the eye, any medications patient is on, and other bleeding, particularly epistaxis or hemotaxis or spitting of blood is there or not, headache is associated or not, and the most important, factitious disorders suspected. If has anyone observed the patient having this, or any patient has seen a patient has immediately prior to the episode, someone has seen the patient. So physical examination, we'll do a slit lamp examination for the conjunctiva. We'll see the anterior segment. Bleeding diastasis, patients usually have subconjunctival hemorrhages. Digital palpation of the lacrimal sac over the lacrimal sac fossa area upward may reveal if it is from the lacrimal sac. Mass lesions in the lacrimal sac or in the medial canthal tendon are particularly concerned for malignancy and other processes. And reflux of bloody discharge or other material on compression of lacrimal sac may locate the source of bloody tears to be the lacrimal sac. So associated symptoms like psychological distress and clear drainage or mucoid drainage may indicate lacrimal outflow source of the bleeding. Pain may indicate that it is traumatic, inflammatory, or infectious, and there are some accompanying skin or conjunctival lesions. So diagnostic procedures in cases of hemolacria are probing and irrigation of in the office and culture of the discharge. Cytology can be done, nasal endoscopy, computed tomography, dacrocystography, and intraoperative biopsies of lacrimal gland. Differentials for this range from many like canaliculitis, to anticoagulant use, topical silver nitrate, epistaxis, melanomas, benign masses, squamous cell papillomas, nasolacrimal endometriosis, factitious disorders, and idiopathic. So with all this ground, we come to our case. Our case is a case of a 34-year-old gentleman who came to my OPD with chief complaint of blood and tears since 2 weeks. And it only occurs when he washes the face. There's no history of trauma. There's no history of any intraocular or periocular surgery, no infectious disease, systemic disease, no other medications he was on. Patient had, this was the picture he showed me, that this is what happens after he washes the face. So this looks like patient took previous prescriptions from many doctors where antibiotics, anti-inflammatory, and many other drugs were started, but there was no careful examination which was done. So when I examined, there was a small upper tarsal conjunctival pyogenic granuloma which was located and which was bleeding whenever patient used to wash the face. So it was a very small case, and pyogenic granulomas, as we all know it, they are benign vascular lesions of the skin and mucosa. Recurrent bleeding, even with minimal trauma, can occur. And current treatment for pyogenic granuloma is ablative, but I started with patient on timolol, which is a vasoconstrictive drug, and it causes vasoconstriction, vascular growth factor inhibition, and apoptosis. I started the patient on topical medication of timolol 0.5 and observed after 2 weeks there was nothing which was there and patient was symptom free, and patient had seen around 10 to 15 doctors before that and no one noticed that. So take home message for me is careful examination is must, medical and surgical treatment follows later. So the simple act of paying attention can take you a long way. Thank you.
Thank you, Dr. Nitish. Nice case. Actually, that is most of the times we are so much driven by the psychological thing that patient is doing something and patthar aate hain and all those things we have already seen getting presented. So these kind of few genuine cases, we tend to misinterpret them as psychological. I had a similar patient, young patient. He actually had a video with him where he showed, because he was not bleeding when he came to me, but he had that video. And again, when I everted, the upper lid had kind of a small AV malformation with a small like
granuloma.
Kind of granuloma. It was not granuloma, actually the vascular loop which had kind of, so just a simple local anesthesia and cautery made the
Would
thing
have,
and he was
yes,
happy. So maybe similar case.
Yeah,
so
ma'am.
sometimes we think of all the rare
All that,
things first
yeah.
and miss something in examination.
Yeah.
So yes.
Yeah, just everting the lid would have.
We should make it standard practice to evert the lid in all cases. In all cases in oculoplasty. Sometimes you get referrals for watering, continuous watering, and you see giant papillae, which nobody noticed just because they didn't.
Didn't evert.
I think the COVID practice is still, the COVID scare is still there. Inclinations.
Not only the lid eversion, double lid eversion, and
Yes, sir.
the whole of the upper form.
Yes, sir.
There are sometimes foreign bodies, contact lenses, large contact lenses, they are also. So you have to see all the formations, upper two and lower one.
Definitely.
Quickly add that how important double lid eversion can be. So during my training years, we had a child presented with features of chalazion, has been diagnosed and sent to us for management, and on eversion. So the child, while playing, had inserted something and that foreign body was lodged in the superior fornix, which was causing the indentation of the lid, which presented as a... Yes. We definitely, it will help a lot. Just to underline the importance of that.
Thank you, Dr. Nitish, for inciting a wonderful discussion. May we have Dr. Amrita Shawnee for her presentation on pediatric granulomatous dacryocystitis, a rare fungal twist.
Good afternoon, everyone. So I will be talking about a rare case of pediatric granulomatous dacryocystitis with a rare fungal twist, no financial disclosures. So a 3-year-old healthy male child presented to us with right-sided epiphora of duration of 1 month with rapidly progressive swelling near the right medial canthus. Birth history was uneventful. There was no history of blood-stained tears, trauma, or systemic diseases. The informant in his case was his mother. On examination, there was ill-defined, firm, non-tender, non-reducible swelling over the lacrimal sac area, along with fullness, medial canthal dystopia, raised tear meniscus height, no regurgitation on pressure, and rest of the examination was within normal limits. CT scan showed heterogeneously enhancing lesions suggestive of acute dacryocystitis, and the MRI reported right-sided granulomatous dacryocystitis with preseptal cellulitis and mild ethmoid and maxillary sinusitis. The systemic workup revealed that the child was immunocompetent. The blood culture and tuberculosis workup was negative, stool examination was normal, and nasal swab, although has low sensitivity, was still done, and no pathogenic organisms were noted. Now, since the systemic workup did not give us anything concrete, and the child was symptomatic, progressively symptomatic, we went ahead and did an excision biopsy, and we noted this irregular reddish white lacrimal sac mass, and on cutting it open, it was grayish white in color. The histopathology here showed multiple areas, islands of granulomas with necrosis. And on higher magnification, we can see we have this multinucleated giant cell and an area of necrosis. And within that area of necrosis, the pathologist noted the aseptate fungal hyphae, which were better delineated on the PAS stain and the GMS stain. So these are ribbon-like, broken, parallel, non-parallel walled aseptate hyphae, which was also seen on KOH mount. Now, on further culture, we recovered mucor. AFB was negative. So both the microbiologists and pathologists, they reported it as necrotizing granulomatous inflammation secondary to mucor. And the child was diagnosed with fungal granuloma of right lacrimal sac with pre-septal cellulitis secondary to mucormycosis and was immediately started on intravenous liposomal amphotericin B for 4 weeks and oral posaconazole for 6 months. The child had an excellent outcome with a combination of surgical and medical management and with no recurrence at 1 year follow-up. Epiphora, although reduced, but is persisting. So we have explained to the mother about lacrimal rehabilitation that may be required later. And this is something that I also would like my colleagues and my seniors to comment upon because the age of the child now is just 4 years. Coming to the discussion, fungal dacrocystitis, although uncommon, and it's only seen in immunocompromised patients, but is also rarely reported in immunocompetent, mainly in adults, less commonly in pediatric age group, and the most common organisms implicated are Candida aspergillus cerevisiae. Kapoor et al., however, reported mucormycosis of lacrimal sac in a 72-year-old immunocompetent lady who had history of epiphora. She underwent rhinostomy with a lacrimal sac biopsy, and that time it was an incidental finding that she had mucor. Similar, another case, Halawa et al. Reported mucor in an immunocompromised person. So to best of our knowledge, pediatric fungal dacrocystitis caused by mucor, especially in immunocompetent child, and has not been documented till date. And it being a rare entity, ophthalmologists should be aware of this diagnosis in a child presenting with antibiotic-resistant dacrocystitis, as it will lead to targeted therapy with better clinical outcomes. Thank you.
Thank you, ma'am.
So just one, I can ask you something. How will you? He has intermittent watering. The epiphora has now reduced, but the mother is still worried because the epiphora was one of the main symptoms that he had come for. Yes, but now the child still has slight epiphora and she's worried that in future, if this increases, then what are the options for a 4-year-old? So that way, would you? So syringing is, so when we do EUA, the canaliculus is absolutely normal. Huh. We'll wait.
Exactly.
Thank you, ma'am. We now have Dr. Praveen Mongre for his talk on salivary gland duct carcinoma of lacrimal drainage system, an exceedingly rare entity.
Please accept one more congratulations for conducting this conference so successfully. Salivary gland-like duct carcinoma of the lacrimal drainage system. This is probably the 3rd or 4th case which is reported in literature. I presented this case in ISO Goa last year. Drainage system neoplasms are actually extremely rare. Less than 1,000 cases so far has been reported in literature. Occurrence of salivary gland-like tumor in the lacrimal gland is well known, but primary ductal adenocarcinoma of the ductal system is also, in the lacrimal gland is well established, but very few cases of salivary gland-like duct carcinoma of the ductal system has been reported. Probably this is 4th case. And of the WHO classification of 2023, they are categorized under the known epithelial tumors. We had the 77-year-old male who presented to us with the medial canthal gradually increasing mass with redness and epiphora. On MRI, there was 1.9 to 1.4 millimeter mass, which was abutting the medial rectus muscle. And on PET CT, it was FDG enhancing lesion, which was adherent with the lower lid also. So we subjected this patient to the biopsy. And histopathology report were consistent with sebaceous gland carcinoma. But when we subjected this patient to IHC staining, it was CK7 positive, EMA positive, which were in favor of adenocarcinoma. But it was HER2 positive. So HER2 positivity is a significant because it is a marker for the endothelium. Fine. And not only this, HER2 new was positive. New is a new oncogene which carries a bad prognosis, because the cells which are positive with HER new, they have a militant capacity to continue to have the DNA mutations. There was androgen receptor positivity also. Androgen receptor has a significance. I will come later on. P63 was negative. It also has a very good prognostic factor, because P63 is a gene which helps in the DNA repair. And the cells which are having P63 negative, they do not respond to the treatment well, because their DNA repair capacity is low. So with this, we had a diagnosis of high-grade carcinoma, salivary gland-like duct carcinoma of the lacrimal drainage system. One report came in 2016, which claimed that they are reporting the first case of this. And three cases more have been reported subsequently. So we are looking into more literature about this to report our case. Adenocarcinoma, but this was negative. Adenocarcinoma was negative for HER2. So since this was a high-grade carcinoma, which is adherent to the globe and medial rectus muscle, all the vision was 6/6. And with the scanty literature available for the ideal management, we thought of doing exentration, but patient refused because of his good vision. So we planned a medical management. So going through all the literature, we could find these 5 combinations of chemotherapies which are good for these things. But since patient was having hypertension and ischemic heart disease, so 5-FU based treatment was not considered. And we had given him docetaxel and carboplastin in 3 cycles. At the end of the first cycle, there was absolutely no response. The MRI was the same, clinical features were same. At the end of the second cycle, also there was absolutely no change in the MRI status. So since he was androgen receptor positive, so we added on androgen deprivation therapy, which is very commonly used for the recurrent prostate carcinomas. In spite of this, he still had the same clinical picture after the third cycle also. So patient was reviewed at the tertiary center tumor board meeting. There he was advised exentration, but patient still refused. So this is where we are. So lacrimal drainage system tumors are extremely rare. They just present like a mass or epiphora. So we need to pick them early, and specific treatment need to be given. In addition to morphological resemblances, the phenotyping of these tumors are absolutely essential, like we did at HER2 new, HR, and P63. So since AR evaluation may have a significant diagnostic and therapeutic ramifications, so we recommend that it be included in the immunohistochemical analysis of high-grade carcinoma of the drainage system. Overall prognosis of all lacrimal drainage system carcinomas are poor. Even the benign one has a high recurrence rate. So because they are relatively rare and there is insufficient data, the best treatment modalities are not available to us. So surgery with adjuvant radiotherapy has been used widely. However, the exact course of treatment depends on patient preference, overall health, and severity of disease. So take home is a multidisciplinary team approach should be considered to manage these kind of rare and aggressive cancers. AR positivity is not only for a diagnostic, but for a therapeutic implication also. P3 negativity is an ominous sign. Endocrine therapy can be used, and androgen deprivation therapy, which has been used, can be used in these cases. Thank you very much.
Thank you, sir, for a wonderful presentation. Any questions, judges? May I call upon the next speaker? Yes, sir.
Yeah. This is a really very good case, Dr. Mongre. And basically, even the earlier case, it was actually a fungal pediatric dacrocystitis, and your case was related to the neoplasm of the nasolacrimal system and the ductal system, basically. But what happens regarding these cases, we don't have a much awareness, and the delayed diagnosis has been the norm for all such cases. So whenever we look into the lacrimal system, we need to know that infective cause is the well known, but we need to look into the inflammatory as well as the neoplastic etiology in all such cases. And whenever the patient is not responding to the standard line of management for the infective etiology, then we should really think about out of the box, and there could be an underlying inflammatory or the neoplastic etiology. And as you have said, actually the rarity of the case, actually they don't have any protocol based management because of the rarity of the things. So really good case. Thank you for sharing with us.
In fact, it is very essential that the diagnosis should be the IHC markers. The pathologist should actually know that what they are dealing with. In this case, P63 was not present with the I sent all my sample to institute, that is Molanjad. Yeah, private practitioner, they do accept my cases. So P63 antigen was not present, was available with Dr. Saran. He requested it from All India Institute. So pathologists do help us in case we want their help. Thank you.
Thank you.
Next, we have Dr. Mukesh Sharma, our OPAI Scientific Committee Chairman. Sir, can you please start?
So my slides are visible?
Yes, sir.
All right, thank you.
So this is the last slide that we can see.
Yeah, actually. So at the outset, my compliments to Dr. Vishal and whole team of MID-TERM OPAI. Like in these difficult times, you are able to manage such a nice conference. I'm connected online with the conference. And unfortunately, I could not attend it because of uncertainty and also because of indirect connections. But anyway, you could pull up and organize it in such a nice manner. So my compliments. It's my loss actually. So today I shall be presenting to you little rarer kind of surgeries, lacrimal canalicular surgeries. And I'll be showing you 3 surgeries in that. One is congenital lacrimal fistula. This is a case of congenital lacrimal fistula. It's, I think, 8-year-old child. And here is the fistula opening. So we did syringing, and syringing was patent also, but fluid was coming out through the fistula tract also. So basically NLD was patent, but there was watery discharge from this tract. So we need to deal with it. Literature says that you do DCR with intubation in these cases. Long back, we were part of a large series which was published in ophthalmology, and we did simple fistulectomy. Like a pursing suture was passed all around the fistula tract. Surprisingly, you find pretty long fistula tract here. In this case also, it was 5 to 7 millimeter, though it looks very superficial kind of thing, but internally there is a long tract. So you just dissect all around the tract, pass a purse string vehicle suture all over the fistula opening into the sac. Lower down at the opening part in sac, it becomes pear shape, dilated kind of opening. So you pass bursting suture all over the tract, not into the tract, but into the tissue all around the tract. So once you have passed this bursting suture, you just pull up the tract and tighten this suture. And then you can see it's a little long kind of fistulous tract, which is not apparent on cursory examination. So once it is done, you just resect out the tract, then pass a suture through the cut end of fistulous opening, so that this opening does not opens up again. And then one more suture into the subcutaneous tissue and skin suturing. So it's a very simple surgery, but gives very gratifying results. And to our surprise, in literature, like not too many people are advocating this surgeries. Most studies, they are advocating DCR with intubation. Now I'll be showing you another surgery, which is proximal canalicular obstruction, less than 8 millimeter. And what we all are doing nowadays is trephination with stenting.
Dr. Mukesh,
In this
sir.
particular case, the
Dr.
block
Mukesh,
was
sir.
there almost at 8 millimeter only, 7 to 8 millimeter. Beyond that, we do canalicular DCR, but if the blockage is earlier than 8 millimeter, then trephination is done rather than doing conjunctival DCR, because the results of trephination are almost same with it's a very simple surgery, does not require any maintenance. So we are just measuring the blockage distance. It's around 7.5 millimeter. We have passed a probe and just measuring the distance of blockage. This is canalicular trephination, Sisler's trephine. So this is the trephine. So puncta is dilated and it is passed into the canalicular system. As we do the syringing, you reach up to the blockage part and then just rotate the internal metallic trephine kind of thing basically, and try to negotiate the block. Once you have negotiated it, you pass a mini monoca stent. I prefer passing around 12 millimeter of a stent. I do not pass too long a stent because I believe that dangling stent itself can create granuloma formation. So once you are through with it, just pass it into the canalicular system and leave it there for 4 to 6 weeks. Results are around 70 to 80%. In this particular case, it was successful. Then another surgery which all of us are doing routinely, canalicular repair. So nothing great in this particular surgery. Only thing is that you need to identify the distal cut end. Proximal cut end is very easy to identify because you can pass your probe through that. Then there are several ways of identifying the distal cut end. One is by seeing it directly under microscope. Second is if there is some difficulty, you can do syringing with dye. I prefer doing it with Tryphon blue. So we are doing Tryphon blue syringing through the upper puncta. Advantage of this over methylene blue is that this does not stain the adjoining area and it creates very fine staining of the canalicular system, cut end of canaliculus. So you can see dye coming out through it. If there is some difficulty, you can place your finger there down at the sac area. So you can create a blockage over sac and the dye would come out. So once you have identified the distal cut end, you pass your stent. Again, as I told you, I do not prefer leaving a very long stent. So this is the distal cut end of canaliculus. Very beautifully seen. It looks like any artificial tube. So this is where it is visible. You can pass your tube directly into it and then pass two pericanalicular sutures, 2 or 3. So we are passing pericanalicular sutures. They are pre-placed. We are not tightening them. We'll tighten all of them together once you pass them so that you can identify the tissue properly. Once you have passed them, you place your tube again. Your assistant will hold the lid. Your assistant is holding the lid and you just tighten those pre-placed sutures. So this is the end of surgery. Sometimes you can do canalicular repair in delayed cases also. This was RTA case and surgery was done 4 years after this. There are fistulas tracked also. So it's a difficult case, but we took up for surgery. So you try to negotiate all the blockages internally. So we are resecting out the block there. This fistulous opening also would be dealt with. So once you have dissected the block, you pass a pigtail catheter from other end. Was from this puncta only. And then thread this pigtail catheter with non-absorbable suture or silicone rod. Take it out. Pass it from opposite puncta. The blockage was there also. So we resected the blockage, came out in the canalicular system, threaded the catheter with the suture which was passed earlier on. Whole thing was repaired. So we have done, I think, around 8 cases till now of delayed canalicular repair after 1 year of injuries. And out of those 8 cases, 3 are successful. So success rate, long-term success rate is poor in these cases, but 30%, 30 to 40% success rate is there. Around 40% success rate is there in our scenario. So we are still dealing with these cases, and probably we will publish this series in this year only. So thank you for your patience hearing.
Thank you, sir, for a wonderful presentation. Yes, sir.
Dr. Mukesh, sir.
Yeah.
Yeah, regarding your first, when you are doing that fistula repair, although you are master, but do you recommend that canalicular system should be kept probed so that there is no damage to the canaliculus?
See, in this particular case, your fistulous tract may open up in canaliculus also, canaliculi also, and also in sac. So in this particular case, it was opening up in the sac. We ascertained that by doing preoperative syringing. But if it is getting opened up in canaliculus, then obviously you need to pass a probe there to prevent damage of canaliculus. It's a very important point actually. But in our case, it was opening up in sac. So it was not done.
Second, regarding your second case where you are doing trephinization, in case you create a false passage, then how you proceed? False passage means after you have done and the syringing is still not patent, then what will you do? Do you convert them into DCR or what you do?
See, the advantage of Sisler's refine is that there is a sleeve and then there is a catheter kind of thing inside. So sleeve prevents you in creation of false passage. I do not do syringing on table in these cases because syringing causes extravasation of fluid there, swelling of fluid there. So I go by the dictum that I have not created false passage and I try to pass a stent directly without doing syringing because I believe that once you have done something on the canaliculus, tissue is already damaged. If you try to do syringing, you will create more edema in that tissue and you may create later on problem in your intubation also. So with Sisler refine, you take it that you are not going, you are not creating a false passage. If you do try to negotiate blockage directly with the help of needle, we were doing it long back when there was no Sisler refine. In those times, there was incidence of false passage creation, but I believe it not with Sisler refine.
Because I had understanding that sisler cannula as such, when you have completed the procedure with that cannula itself, you can do the syringing and confirm the patency.
Yes, you can do with this. Yeah, there is this system. Basically, you remove the catheter and you can do syringing through the cannula itself. You are very right. That is the advantage of Sisler's refine.
Thank you, sir. Thank you.
Thank you, sir. Faculty and the students for the feedback.
Mohini here from Hyderabad, Sarojini Devi. I'm regularly doing stenting for trauma cases, maybe 2 or 3 per week. And I have found that in my hands, even longer stents, say up to 20, I just bevel the tip of the stent, even if I bevel it, it goes into the sac, and after 2 months, that is 8 weeks, we remove it out in the OPD and do a dye disappearance test in children as a proof of recanalization, and found that nearly 90%, 95 I should say, are successful. Delayed stents also we do some of them, but not as bad as the one you showed where the skin flap and all had formed. And even the longer one I find works quite well in my hands.
Yes, actually, most people are doing the way you are saying, and there is no harm in leaving them long also. But leaving stent for more than 4 to 6 weeks, I think, is generally avoided nowadays, because there is definitely an incidence of granuloma formation if you leave stent longer than 6 weeks. So I think any stent, now the dictum is that whether you have done it for intubation DCR or for canalicular repair or for any other thing, should not be left for more than 6 weeks or so. But
Yeah,
again,
we
it's
take
a
it
matter
out
of
to
personal
8 weeks, depending from where the patient is coming and when. Even 8 weeks, we have not faced any granulation tissue or anything. And I feel more secure if the stent is longer while I'm placing my sutures so that it doesn't get disturbed. Especially the posterior suture and the anterior suture, I feel more secure and brings the cut end of the tissues perfectly aligned. I have a little play there. If it's a shorter stent, I would have to keep on putting it back every time I manipulate the sutures, because it's difficult to suture in that area, which is in a depth and a very narrow area.
Yes, as I said, basically it's a matter of personal preference. No harm even if you're leaving it long. But I generally like off late, I have started leaving it short because of the reason I have told you. Earlier, I also used to leave it little longer.
Okay.
So Mukesh, one last question. Regarding the delayed repair of the canalicular blocks, did you put any intubation over there, or just sutures absorbable or non-absorbable?
No, this was Ethibond basic. Yeah. This was Ethibond suture, non-coated Ethibond suture. So it was appearing white and we left it there. And now we have got silicone tube which can be threaded. Earlier on, we did not have those kind of tubes available with us. Now what we do is we thread silicone tube over the suture and then we remove the suture. So that's a better way of doing it, but you need to have a hollow silicone tube which can be threaded over the sutures. So earlier on, we were not having those kind of tubes with us. So
even if the patient is affording and the affordability is not the issue, 2 mini monocas also can be put inside.
Not really, because in these cases, the system was blocked everywhere. Like canalicular system was also not patent. It was not upper and lower canaliculi only. The whole thing was damaged. So you wanted a loop which was going through both the canaliculus and the common canaliculus.
I have a series of 5 or 6 cases where I have done, but that was a fresh injury. I have done bicanalicular mini monoca stenting, and I was apprehensive whether 2 stents of that length will sit in the sac, but they sat with ease. I mean, I think as they go, they expand, and silicone is very malleable and it can roll up. It's been proved that it rolls up in the sac, but I'm not concerned because I want approximation at the cut ends, and later I can with ease just pull out the mini monoca. So fresh cases I have done bicanalicular, maybe a series of 6 to 7 cases with success.
Yes, true. Actually, in fresh cases, it can be done. There is no issue in fresh cases. Yeah.
Thank you, sir. Thank you, everyone. With this, we move on to the next session, socket and potpourri. We have Dr. Bhavita Wadhwa online. Do we have Dr. Bhavita?
Yes, he is there.
Please upload your presentation.
Do we have moderators, Dr. Gaurav Saha and Dr. Namita Kumari here, please?
Till then,
Dr. Maya Hada. Hello. Can we have Mr. Ravikant Sharma for his presentation on management of an ophthalmic socket? Dr. Bhavita?
I'm not able to connect. It's written that you cannot start your video because the host has stopped it.
Okay, Dr. Bhavita, we'll have Mr. Ravikant Sharma for his presentation now. And we have Dr. Aditi and Dr. Nidhi for
should I stop sharing the screen?
dear IT staff, can you please help Dr. Bhavita with the screen presentation sharing?
Thank you so much, OPI team and scientific committee for accepting my work. And I'm presenting on management of anophthalmic sockets. Anophthalmic socket can be like it's an absence of an eye or maybe both eyes. It can be congenital or acquired. And for acquiring, it may be n number of reasons. In such cases, for management, multidisciplinary approach is must between the treating surgeon, ocularist, and the patient. As we have to treat the congenital patient, for managing those cases, we have like the parents' follow-up is very, very must. If the follow-up is not being done, then whole thing goes waste. So pediatric consideration, early socket expansion and bony growth is basically very, very necessary and needed with the help of progressive and expanders to avoid any facial asymmetry. Comprehensive care and rehabilitation, the goal should be to create a comfortable, technically and cosmetically acceptable ocular prosthesis which restores the facial symmetry. I'm discussing all these 5 cases, particularly these 2 are the congenital cases. One is an ophthalmic case, which the surgery was done with Dr. Shobha. And there are 2 cases which were post-radiated socket, post-retinoblastoma. How do we do it? Like for the serial conformer therapy, custom conformers are basically much needed for these kind of cases. As we can see, both the cases I started because there was no space. I started just with the iris button and the conformer was increasing in the manner. And we can see there is a down the line, there are 3 conformers which take care of this canthal expansion also. I'll show you how does it help. Like if we see in such cases, like if we consider this case, what happens with the regular or conventional conformers, they turn actually vertical. when we put it on horizontal versus, and they turn by itself only the vertical side. But putting extra wedge over the conformer, either it is stock conformer or the customized conformer, if we put a wedge over it on the horizontal side, then it doesn't rotate. So it gives us the canthal expansion as well as the vertical expansion. And it works out perfectly for me, as we can see in the second patient. Like for this girl, the follow-up was not done properly because her father lives, they were in Mumbai, and so they don't come actually as they were asked for. But this girl, she is very well taken care of. And I'm thankful to Dr. Rajan, and whenever I need his help, he is always there. Like whenever I'm stuck somewhere, and he's always there because we are across. So he helped me a lot for such cases. And this is another case. It not only works for a pediatric case, it works even in a slightly older cases also. Like for the girl particularly, I asked this girl to follow up with sir also, but unfortunately she didn't went there for the lower lid consideration, so that we can take care of the lower lid laxity or any kind of deformity. There is another case. This is done by Dr. Subha, an ophthalmic socket, and very well taken care of because the 70% volume was compensated with the help of implant, and then 30% was compensated with the prosthesis. And this is the movement. If it works, it came out perfectly. And these are the like care and maintenance of artificial eye. For patient care, hand wash is necessary. Cleaning the eyelid and lash is very, very necessary, particularly for those cases, those patients who are actually having outdoor works, like some people who are using artificial eye, they're working on marketing and all. So they have to take care of their these sockets. Post removal, rinsing and sterile water or warm water, followed with the gentle cleaning with the baby shampoo, rinsing thoroughly with the water and re-insert. Lubrication can be achieved by using the drops, suggesting by the visiting ophthalmologist to reduce dryness and the socket irritations. Professional care, routine checkup are necessary. If the closure is not complete, maybe if it is not closing, then 6-month polishing is necessary. If it is closing properly, then there is no problem. In a year, the patient can come and get the polishing done. Replacement usually depend on condition to condition. If there are no tissue changes, a patient is getting polishing done annually or 6 months as advised. Patient can use the processes maybe more than 10 years, 12 years also. Nothing happens to the material itself. If the tissue change is not happening, if the tissue change is happening, then accordingly we have to change the processes or the alteration is necessary. This is the case. She was the girl who has the retinoblastoma, but unfortunately she had post-radiated socket and gone in the contraction. So I just made the prosthesis, spectacle prosthesis for. I have done for 2 cases like this. This is another girl with the same history, and I managed with both of them with the spectacle prosthesis. This is how it looks. Spectacle prosthesis is very easy. Actually, you can put and remove. It comes out fantastic for the patient. Particularly, it works fantastic in the elderly patients, the patient who cannot take care of the orbital prosthesis, which is being held by the adhesive. So this was my work. Thank you so much.
Very nice presentation, Ravikant.
Thank you, sir.
Actually, for an ophthalmic socket, we do need an ocularist, and I'm blessed to have Ravikant very close proximity. So I can actually manage difficult cases with his expertise.
Thank you so much, sir.
Thank you, Dr.
Having a good ocularist is actually a blessing, because unless, even if you do a very good socket surgery, unless if the patient just puts stock eye, your whole of the effort is not noticed. So unless the patient is fitted with a good cosmetically nice COP, then your socket surgery makes sense.
And especially in cases of contracted sockets, congenital ones.
Thank you, sir. Thank you so much.
Is Dr. Bhavita connected? Hello? We have Dr. Shalini Kumari. Hello? Dr. Bhavita?
Yes, I'm not allowing me to share the video, please. We cannot start the video because the host has stopped it. Can you please help me in doing this?
Just a moment.
Mr. Sunil? Okay, meanwhile, we can have Dr. Shalin Kumari's present.
Hi, Dr. Bhavita. Hello. Hello, Dr. Bhavita.
Hello.
I think you can
Yes,
start with the
I'm not
presentation.
able to share the screen.
No, your screen is shared, Dr. Bhavita.
Is it? It is visible?
Yes, you need to.
Okay, can I start?
Yes, please. Full screen kar
So,
denge aap?
sorry.
Full screen, please.
Okay. So, my topic for my presentation is the custom ocular prosthesis in the children with retinoblastoma, leveraging EOA in the digital workflow. So, is it visible, ma'am?
Yes, sir. Yes, ma'am.
Okay. Right. Thank you. So, you all are very familiar with the cases with the retinoblastoma with the conventional workflow. So the retinoblastoma, as you all are very aware, it's a very aggressive tumor, but the rehabilitation of such cases is practically very important. Without the rehabilitation of all these cases, the entire process of enucleation, the quality of life which we give to the patient is been defeated. So we all are familiar with the conventional workflow of our prosthesis, which we have already seen with Mr. Ravikant, that we have ocular stock trays and we make impressions, we place an aluminum buttons, and we paint the iris and we deliver the prosthesis to the patient. So, but why impression making in EOA? See, there are certain challenges, particularly for the pediatric patients, 3 months, 6 months, 8 months, so many small patients. So they don't allow us to make impression. They give so weird faces. They cry a lot on the dental operatory, and this is how they give us the expression when we start making their impressions. Otherwise, they will cry a lot, the socket gets contracted, you get an inadequate and insufficient impression of the socket. So there are certain challenges, how we can overcome. Either we give a behavior management to the small kids with the positive reinforcement, modeling, followed by the subsequent visits. So the process is so prolonged that incomplete or inaccurate impressions caused by their uncooperative behavior or the reflexive movement, they necessitate or repeated adjustments and refittings, which extend their fabrication time. So I'm very thankful to ma'am, Dr. Usha Singh. She cooperates a lot. The patients which are taken up for the evaluation under anesthesia, when they follow up after 3 months or 6 months, we go to the dental operator, we go to the ophthalmic operatory, we make the impressions there for all these kids. This entire thing that harnesses the protocol in such a manner that we are able to give the prosthesis in a day for these all patients. So there is some protocol that we follow in our institute in PGNAR for the digital workflow or this 3D printed ocular prosthesis. First, the impression has been made in the enucleated socket in the ophthalmic operatory, and the orientation is also done in the EOA procedure. And the rest, the ophthalmic surgeons or ocular oncologists, they did take over their remaining procedure. So the patient is then sent to the dental operatory. The wax scleral shell and the iris positioning has been done there. And we scan. I'll show you in the subsequent slides how we scan the wax scleral shells and iris button has been positioned. And we do with all the softwares, we do the digital designing, and the prosthesis is 3D printed, followed by the characterization, and we deliver the prosthesis to the patient. Though it is very nutshell that I am given in a workflow, I'll show in a video. It's very short time for 4 minutes to explain the entire digital workflow. Like this, we make an impression of the implants in the operatory. At the same time, when the ophthalmic procedure is done, it hardly takes us 15 to 20 seconds to make the impression. But our procedure becomes so easy for us, particularly for the patient. They become so cooperative. Otherwise, practically it is difficult for us to make impression in the dental operatory. They will keep on hanging here and there, and they will they will contract the socket and impression will be insufficient. So once the impression has been made, we start scanning the procedure. Wax pattern is then scanned. These are various digital software. The aluminum button is also scanned. So we adapt the aluminum button with the iris button. Then we start with the positioning. This is the image picture software. So now after this, there are various printers on which there is SLA printers which are commonly used with the PMMA resins, and the 3D printed ocular prosthesis is printed. These are the printers. This is how the raw printed 3D printed ocular prosthesis comes out. And finally, we get a process in such a manner, there is a recessed cavity for which we have, because everything we have done in a software, we have done with a digital workflow. So with the painting, definitely that we have to do with a conventional workflow, and the disc has been placed, and with the composite resin, we cure it and we deliver the prosthesis to these patients. So actually, it is very boon for these patients that no acrylic contamination, no monomer contamination in their sockets. We are giving the prosthesis in such a manner that there is no inflammation in the sockets with all these 3D printed prostheses. For one patient, a bilateral case, my article is published along with Dr. Usha and Dr. Sudhir Bhandari in our department. A patient with bilateral electroplated socket, and he was facing a difficulty in orienting the prosthesis, the right and the left. So the brain was incorporated in the prosthesis. He used to the letter L was incorporated, the brain letter L was incorporated in the left prosthesis so that he could be able to orient the prosthesis mesodistally as well as superior and inferior. Otherwise, for a child who is starting in a blind school, not able to orient the prosthesis, somebody has to take the assistance, somebody has to be independent. He could make out which is my right prosthesis, left prosthesis, what is the mesial, superior, inferior, and he's able to make out everything. Quality of life is so much more for these patients. Hardly have encountered 2 to 3 patients with bilaterally affected sockets, but definitely it was a tool for our patients to incorporate the brain in their prosthesis. So this was the article being recently published in Journal of Prosthetic Dentistry. And as of now, for the in our department, along with the Advanced Eye Center of PGIMR, we have done more than 50 cases, more than above 50 cases under evaluation and anesthesia for the COP, and more than above 150 patients for the routine follow-up patients with the custom ocular prosthesis. A small video of my all cases as of now we have completed in our department. I'll run through in a few seconds.
लहरों से डर कर नौका पार नहीं होती, लहरों से डर कर नौका पार नहीं होती, कोशिश करने वालों की हार नहीं होती, कोशिश करने वालों की हार नहीं होती, लहरों से डर कर नौका पार नहीं होती, लहरों से डर कर नौका पार नहीं होती, कोशिश करने वालों की हार नहीं होती, कोशिश करने वालों की हार नहीं होती। नन्ही चींटी जब दाना लेकर चलती है, नन्ही चींटी जब दाना लेकर चलती है, चढ़ती दीवारों पर 100 बार फिसलती है, चढ़ती दीवारों पर 100 बार फिसलती है, मन का विश्वास रगों में साहस भरता है,
डॉक्टर
मन
बबीता,
का विश्वास रगों में साहस
डॉक्टर बबीता,
भरता है,
बबीता,
चढ़कर गिरना
प्लीज
गिर कर
conclude it.
चढ़ना खरता है, करना का पार नहीं होती, कोशिश
डॉक्टर बबीता,
करने
बबीता,
हाँ जी सर,
yeah, can you please summarize it?
okay, okay. Should I escape this video and wait?
Thank you so much.
Thank you,
Brilliant.
Dr. Bhavita.
Brilliant.
For rehabilitating.
Yes, yes.
Next.
Yes, ma'am. Just got to connect. One second, ma'am. I've stopped sharing my screen.
Thank you. Thank
How
you.
do I come back?
It was an excellent presentation, Dr. Bhavita. I'm Dr. Raj Anand, and quite impressed with your work. A lot of technological incorporation, because conventionally we have seen a lot of manual work being done. So I believe with the incorporation of technology, it can be done
Yes,
much
sir.
precise, faster, and better way for all of us. Great presentation.
Yes,
Thank
sir.
you very much.
Thank you, sir. Thank you so much, sir. Thank you.
So we call upon our next speaker, Dr. Shalini Kumari.
Good afternoon. Thank you for accepting my presentation. My topic is before fitting custom ocular prosthesis, challenges encountered in case series. Cosmetic rehabilitation is recommended in individuals with loss of an eye or with disfigured eye. Fitting of a COP demands an ideal socket. How do we define an ideal socket? It is the presence of adequately deep furnaces, effective volume replacement with orbital implants, or with DFG in an ophthalmic socket as per indications. There should be absence of blepharotosis, no eyelid malpositioning, absence of socket contracture, and no sulcus deformity. So today I'll be presenting a case series, 3 cases of DFG and 5 cases of interstitial, my lessons, mistakes, lessons learned, and some insight very quickly. Due to paucity of the time, instead of going into the details, let us jump to the cases itself. My first case is a young male who came to us with inability to retain COP. Evisceration with implant was done few months ago somewhere else. When we removed the COP, what we saw was a big PMMA implant hanging from the socket, and it was firmly attached with the underlying socket. So similar case reports have been reported in the literature. So we removed the socket with dissection and then went ahead with DFG. This is the result after 3 months with COP. My next case was a young female who came to us with inability to retain COP. She had a history of trauma in childhood. It was an ophthalmic socket, basically post-enucleation socket syndrome. Again, we went ahead with the DFG, and this was the end result after 3 months. A very interesting finding which we saw was a hair shaft in the socket. Similar case reports have been reported in the literature. Our third case is the most challenging case in my career so far. A young lady, 27-year-old, she came to me with anterior staphyloма of the left eye. I did evisceration with implant. On the 12th day post-op, what I saw was a big exposure of the implant. So I just visited my surgical video, and what I noticed that scleral flaps were actually sutured under tension. We know that such tension can lead to implant exposure. So what next? I just went ahead. What is this? So I just revisited the surgery, and by visiting the anterior sclerotomy incisions, the posterior sclerotomy, double breasting of the flaps, and the same implant was repositioned. It was doing well, but unfortunate turn of events, patient got pregnant, and in post-operative period, she developed hyperemesis gravidarum. And again, implant was exposed and it extruded on its own. All interventions were aborted due to in view of pregnancy, and we put a non-customized COP just to buy time. So next, after several months when she came up, we had an ophthalmic socket. We went ahead with DFG. Patient was doing very well. On the 4th day, suddenly patient turned up with infection of FFS and DFG as well. So we did culture and sensitivity, started on antibiotic. Unfortunately, in few weeks, we just, the DFG failed. So in view of so many procedures, actually, I stopped doing anything. After 8 weeks, when I was quiet, what we did was COP implanting. So I revisited my surgical recording. What I noticed that since patient was under general anesthesia, I just forgot to put injection lignocaine with adrenaline. We do know that putting this injection actually creates a plane between epidermis and dermis, and epidermis can be scraped off in toto. So I am still wondering, did I incompletely remove the epidermis? Was it a cause for the infection? And similar case report of graft infection has been reported in the literature. Now, let us jump to my evisceration with implant cases. A young male patient whom I had operated around 7 years back for anterior staphyloma with evisceration with implant. He came back after 7 years. His COP was actually protruding and all movements were restricted also. When I removed the COP, what we noticed was a large conjunctival epithelial inclusion cyst. So what next? We excised the conjunctival inclusion cyst in toto, and then after 8 weeks, a new COP was put. So what I suggest with this case is that while suturing the conjunctiva, we have to carefully avoid the edges because any incarceration can lead to this complication. Okay, so my next case was a young male patient who came to us with anterior staphyloма of the right eye. The surgery was done nicely, but all of a sudden on day 1, he developed preseptal cellulitis. On day 3, it was increasing. Again, on day 4, it was increasing. But we visited the surgical video, and what we concluded that it was a case of absolute alcohol-induced preseptal cellulitis. So we left it as such. On post-op day 7, we saw that it had resolved it on its own. After 8 weeks, COP was implanted. So see, what I noticed that we took full precaution to prevent any spillage, but still wondering, did something wrong happen? In literature, there are 2 schools of thought. One school of thought says that to use alcohol because it denatures the uveal ruminants and decreases the possibility of sympathetic ophthalmia. But other school of thought says that we don't need to use alcohol. Then our next case is a case of anterior staphyloma. Surgery 2, for me, it was done nicely. But what happened on day 2, he sent me a selfie image, says it's excessively, the swelling is there. So when I called, by the time day 5 when he came, the swelling had dissolved on its own. Post-op day 7 picture is this. After 6 weeks, we could put the COP. So I revisited my surgical recording. What I noticed that adequate hemostasis was not achieved even by the end of the surgery. So what I suggest, the adidline soaked gauze paste or even the cautery or the combination of both, sometimes alcohol also does prevent the hemostasis. One of my cases during fellowship time, just because of the ongoing bleeding, the implant extrusion I have seen. So this should not be done. So my 7th case is again an anterior staphyloma. The evisceration with implant was done. Post-op 6 weeks, we could put COP. With this case, I want to just highlight that sometimes when in anterior staphyloma, the scleral cavity is quite baggy, it's large. One school of thought says just excise the excess scleral rim. But what we suggest is just put 4 radial anterior sclerotomy, do the double breasting of the flap and suture it properly. It gives reinforcement and preserves the natural scleral tissue as well. Okay. And so my last case is again a case of anterior staphyloma. We did evisceration with implant and the COP was made after 8 weeks. While recording the COP video, what we noticed that adduction movement was more than the abduction. One paper says in a large study that generally abduction is more than adduction. So again, I visited my surgical video. What I noticed that there was pigmentation over the scleral flap, on lateral scleral flap. I just wanted to excise it, but conjunctiva was overlying. So I started doing undermining of the conjunctiva. And I believe during the process, I did damage some lateral lactus fibers, which led to restriction of the abduction, which should have been done carefully. So the take-home message is twist and turns in contour in such cases make this procedure so challenging, and key learning is preparing an ideal socket bed before fitting a COP is a must for adequate cosmetic rehabilitation in all cases. Thank you.
Thank you, Dr. Shalini. A wonderful collection of cases, very well managed. Any questions, judges?
One question, Dr. Shalini. Do you practice, this is Dr. Mangesh Dovekar here.
Yes,
do you
sir.
practice posterior sclerotomy and the posterior radial relaxing incision in all of your cases?
Sir, I do practice posterior sclerotomy in all, mostly in all cases.
Okay. It's with the optic nerve release you do?
Yes, sir.
That is actually recently it has significantly decreased the implant exposure rates in most of the cases.
Yes, sir. In the first case where the there was an exposure, I believe that my posterior sclerotomy cuts was not adequate. So when I did the revision surgery, I made it a point to adequately release it, and I felt that implant which I was putting was going back properly, so that I could do the double breasting without changing the size of the implant.
Yeah, that's good. And regarding the alcohol use, I think better to err on the side of preseptal cellulitis following alcohol use than getting the cases of sympathetic ophthalmia. What is your opinion?
Sir, actually, I did search the literature a lot before reporting this case. So I believe it should be used, but still if there is so much of pain, and not pain, patient was painless except swelling. So I'm still in dilemma because there are two different schools of thought. So I have stopped using it.
No, but sympathetic ophthalmia cases, though these are very underreported cases, and even in at
Yes.
your institute, we continue to get such cases. So it's, I think, always better to use alcohol, because we are, whatever the preseptal cellulitis or the periocular inflammation, we get in only in the first week, and it can be subsided with the use of mild steroids also.
Okay, sir.
Thank you. Good case.
Good afternoon. I have another question. In cases of staphyloma, what is your first choice? E-visceration with ball implant because and versus the enucleation and ball implant, because the sclera is very thin. So the removing total and placing an implant with the tenons and conjunctiva overlying, that is better, or the evisceration with ball implant?
I do evisceration with implant in all cases.
Excellent series, Dr. Shalini. Enjoyed watching them. Dr. Modini from Hyderabad here. And my question, not just to you, but to everybody, what are the suture materials you use to close the sclera?
For the sclera, 60 Vicryl.
There are schools of thought where ethibond has been used, where proline 50 has been used. But like you, yes, I prefer 60 Vicryl itself because it does not really poke through the conjunctiva and give a lot of irritation and granuloma formation later. But there are some who swear by proline. So just wanted to take everybody's take on that.
Proline can protrude through that, even through conjunctiva. Na?
Exactly, that's what I said. That's
and
what
again, ethibond, I think somebody showed it today itself, that ethibond through the tosi, somebody did some tosi surgery, ethibond was causing some problem. So I think 60 Vicryl is safer.
Yes, ethibond causes a lot of inflammation, sometimes infection also. So I never use ethibond. 60 Vicryl is my go-to.
Okay. Thank you.
Dr. Mangesh, anything on that?
Basically, whenever you use the proline, then it has to have a conjunctival thinning, scleral thinning on the, all these cases will present late, even after 5 to 7, 8 years. And then these patients will have an exposed proline suture, and then it will lead to again recurrent inflammation, conjunctival thinning, and the implant exposure. So better always to use 60 Vicryl.
Thank you.
No other option, no other options.
Thank you, thank you.
Thank you.
Thank you, Dr. Shalini. Next, I invite our next speaker, Dr. Nidhi. Dr. Nidhi is a practitioner in Delhi. She would be talking about a case of two globes.
Good afternoon, everyone. It has been a fantastic 2 days here, and the weather being kind today, a very sunny and bright day. So this brings us to the presentation, a tale of two globes. So presenting a case of a 25-year-old male patient who presented with an ill-fitted prosthetic right eye for replacement of the prosthesis. He had a history of no eye or vision on the right side since birth, and was using an earlier prosthetic eye since his childhood. On examination, there was no visible eyeball. Suspecting a microphthalmic or an anophthalmic socket, no history of any surgical intervention done before. A small unstable prosthesis was there, and there was a contracture of the inferior fornix. There was an ill-defined fullness in the inferior fornix of the patient, suspecting a soft tissue hypertrophy. Not very sure in the clinics, and the lower lid surface was quite unremarkable. The upper lid and the superior fornix was quite adequate. The other eye, the vision was 6/9, uncorrected, and anterior segment was within normal limit, and there was an inferior coloboma in the retina in the left eye. So we went ahead with the radiological investigation, and as we can see, there was a large cyst almost as big as the eyeball on the other contralateral side, and there was a small rudimentary eyeball with a lenticular structure. Along with it, the cyst was pushing this globe behind in the posterior orbit. So the positioning of the cyst was in the inferior medial orbit, and this was the fullness that was first evident in the clinical examination, and the prosthesis could not be stabilized because of this. So to manage this case, the cyst excision and inferior fornix formation was done. So intraoperatively, the cyst had a thick wall with serous fluid in the cavity, and the posterior communication with the globe was suspected. The removal of the cyst was done, and suturing of the residual tissue was done with Vicryl 60. The rudimentary eyeball was retained in the socket. So in the post-operative recovery, the patient was fitted with a customized prosthesis at 8 weeks after removal of the inferior fornix formatting sutures. So a few salient features that I would like to discuss regarding management of cases with microphthalmic eye and orbital cyst. So we need to manage not only the eye, but also the patient as a whole. So in about, the literature says that over 50% of cases of microphthalmia as well as anophthalmia will have some form of systemic association in the form of mental retardation, craniofacial deformations, polydactyly, cardiac, renal, genitourinary system abnormalities. And a few of these patients will also be a part of a bigger syndromic association such as Char syndrome, Aicardi, Lenz syndrome, Fraser, Golin-Galls, and so many others. So we need to keep that in mind while managing such patients. Coming to the management of the eye, so very important that the other eye should be examined in detail, because these patients will might be having some developmental anomalies of the other eye as well, same as in our case. So, how the factors that guide the management of the microphthalmic socket. So to highlight the visual potential in the microphthalmic eye, the age of the patient at presentation, the volume of the orbit, and the pattern of the cyst growth. To cover these points, so the main stay of the management will be socket expansion to be started as soon as possible after the birth of the child. So this is to prevent the facial structural deformity as the child grows. And the way to do it using acrylic, sequentially enlarging acrylic conformers. However, the literature says then in severe contraction of the orbit, about less than 85% compared with the other side, the orbital expanders such as dermis fat graft, spherical orbital implants, and hydrophilic expanders have to be used as well. So now the question whether to remove the cyst and when to remove the cyst. So this cyst will act like a natural socket expander in young children. And the literature says that about 2 to 5 years of the age is the age when the socket will grow about 50 to 90% of the adult size. So this is a good time after which we can plan the removal of the cyst in the orbit. However, there are indications for early removal of orbital cyst. If the cyst is rapidly enlarging due to hemorrhage into the cyst, or displacing the prosthesis or the wall of the orbit, or prolapse of the cyst through the palpebral fissure, this would warrant an early removal of the orbital cyst. So the modalities that are available, so aspiration of the cyst can be used as a single standalone procedure, or as a standalone procedure, or in conjunction with the surgical removal of the cyst to buy some time. However, this modality is has a high reoccurrence rate because reaccumulation of the fluid occurs. So literature also tells us that there is an option of using sclerosing agents after the cyst has been aspirated, and the recurrence rates are less. But surgical removal of the cyst with or without enucleation is the treatment of choice in such cases. And the question that I would like to ask the audience here is whether or not to use an implant in cases where we decide to enucleate these orbits. And so to conclude, I would like to say that microphthalmia with orbital cyst presents with a cosmetic and functional disability for our patients, and timely and appropriate management is necessary to minimize the disability and its impact in our patients. Thank you very much.
Very nice presentation, Dr. Nidhi, and very well managed case. There are two things I would like to point out. First, doing surgery in both microphthalmia and anophthalmia congenital cases are very different from adult sockets.
Definitely.
My preference is to avoid surgical intervention as long as possible.
Right, sir.
For example, like in cases with microphthalmia and cyst, I would rather wait for socket expansion. Once my desirable socket expansion has been achieved, I would rather aspirate and do a sclerosing agent than doing a surgical intervention.
Right,
In
sir.
my experience, it works much better. Enucleation should be again, if we can manage with prosthesis, if prosthesis become heavy, we can go for hollow prosthesis, but try to delay it as much as possible. And of course, if prosthesis cannot be retained or if it becomes heavy, we do it, but try to delay it till the bony expansion is complete.
Right, sir. So, sir, can I ask a question regarding the sclerosing therapy?
Yeah.
So, I personally don't have a lot of experience with the sclerosing such cases. So, whether in future, if you need to do an enucleation or a surgery in the orbit, whether that will be a challenge in cases where sclerosing agent has been used?
I never had to do it so far.
Oh, that's very nice.
So,
right.
May I comment on this? This is Dr. Mangesh Dovekar.
Right.
Yes, Mangesh.
Actually, whenever I come across a patients with a microophthalmos with a cyst, I give them option that there will be a 3 settings minimally invasive, like the cyst aspiration and the sclerotherapy. And even at the end of the 3rd setting, if the cyst doesn't resolve completely, then and then only we can go ahead with the enucleation. But as ma'am, as you have said rightly, that surgical intervention post sclerotherapy is really challenging, because it induces a lot of inflammation, and inflammation is followed by the fibrosis. So getting plane is very difficult in all such cases. In a virgin case, actually, you can go ahead and you can get the cyst wall nicely and you can get away with the surgery. But if you use the sclerosing agent, then it's very difficult. Because I had a case and there was a huge microophthalmic cyst was there. It was actually 4 times the size of the globe, and we tried first the minimally invasive cyst aspiration with the sclerotherapy, but the patient actually the cyst was not getting completely resolved, and then we planned to go ahead with the surgical intervention in the form of the enucleation and the cyst removal. Then it was really very challenging. So though all these cases are very rare, in most of the cases, even in our setup, more than 70 to 80% cases get resolved with the cyst aspiration and the sclerotherapy alone.
Thank
I
you,
think
sir.
recurrent kind of cases where sometimes the main thing how sclerotherapy is going to work is destroying the cyst wall. So in cases where there is a very huge cyst, most of the times in single syringe, sometimes it doesn't come.
You can't aspirate all of
Yeah.
it.
And when you are actually sclerosing, you need to keep the needle like that, and then you need to put the sclerosant so that you do not leave the plane. The thing actually goes in. So sometimes if the cyst is very huge, you cannot aspirate whole of the cyst fluid sometimes in first thing. So when you are injecting sclerosant, it sometimes gets diluted. So in those cases,
Hi, this is Dr. Modini, and I would just like to share my experience. Am I audible? Everything has frozen over for me. I don't know if I'm audible. Someone can raise their thumb to tell me if I'm audible at all.
You're audible, ma'am, but I think we have lost the connection from the hall.
Okay. But I think you all are there. So my experience with this is I would definitely do excision for the cyst because I don't find sclerosant working well in my hands.
Okay.
And the next step, enucleation, whether to do it at the same time or at a later stage, I would leave the decision to the age of the child. Because in younger children, I do not want to do a enucleation because the eyeball remaining there allows the facial bones to develop properly. These people often present at infancy or below 5 years age. So I would leave it like that. Just put a prosthetic eye because here the cornea is not exposed in the eye, which is almost hidden under the conjunctiva. So there is no chance of rubbing and causing a corneal ulcer and such things. Just keep changing the prosthesis regularly. And if an adult approaches for the first time, I would go for enucleation, cyst excision, and dummy fat graft at the same sitting. That gives good results.
Okay. There are a number of ways to manage the socket.
Yes.
It is one of
It's customized to each case.
Yes. Thank you, ma'am.
Thank you so much, judges.
So as we are coming towards the end of the session and as well as the conference, before doing that, I would like to uh, uh, request Dr. Rajesh Tiwari sir to say something, few words, and then we'll felicitate the sponsors, the pharmaceutical companies who have been generous to us.
वेल इस समय जो नज़ारा है वो कुछ ऐसा है जैसे कि एक पंडित जी कथा बाँच रहे थे और कथा के बाद जब उन्होंने आंख खोली तो देखा 2-3 लोग थे। उन्होंने पूछा, भाई आप लोगों को मेरी कथा इतनी पसंद आई कि आप लोग 2-3 लोग रह गए? उन्होंने कहा नहीं, हम तो ये ऑर्गेनाइजर हैं इसलिए जो है हम यहाँ बैठे हुए तो majority has left. So मैं आपको बताऊंगा the power of the black magic. Power of the black magic. See, we have 5 fingers. Every finger has got its own place. In the same way, in society, there is definite place for, non-medicos as well. I came across, true story. I came across a lady nearly 20-25 years ago. She complained of some black granules which appear suddenly in the lower fornix. I said, okay. I took history. She said, "आ गया." I also saw a black granule. जैसे पपीते का दाना होता है ना, बिल्कुल उसी साइज का. So what I did, just like any other doctor, topical जो है वो डाली उसको, एनेस्थीसिया की ड्रॉप सेट लैंप पर बैठा के निकाल दिया. हर हस्बैंड सेड, डॉक्टर साहब ये तो हम भी 1 हफ्ते से कर रहे हैं, आपने कुछ खास नहीं कर दिया. I had no answer. उसके बाद मैंने हिस्ट्री में कहानियां बनानी शुरू की कि चलो इससे पता लगेगा, हो सकता है दिस लेडी मस्ट बी डूइंग समथिंग रॉन्ग, बिकॉज माय प्रोफेसर ऑफ मेडिसिन हैड taught us about the neurotic ladies who are there in the villages and they are practically confined to their rooms within the 4 walls. They want to come out in the city and such things are done. थोड़ी देर बाद he said कि और आ गया. I said बैठे रहो. And after say 15-20 minutes, it happened that some granules started coming out of the eye. मैंने लोअर लिड थोड़ी सी इवर्ट की और लोअर लिड इवर्ट करके मैंने देखा फॉर्निक्स वाज फुल ऑफ दोज ग्रेन्यूल्स. मैंने वो निकालकर तुरंत मेरे पास में एक पैथोलॉजिस्ट है उनके पास भेजा. उन्होंने उसकी स्टडी की एंड शी रिपोर्टेड कि इट इज नॉन बायोलॉजिकल सब्सटेंस. Then I thought of referring that patient to one of my friend. He is tantric. He's a known tantric in Dehradun. Yes, he's a Raj Jyotishi and known tantric in Dehradun. And I believe in tantra. It is a science. Tantra means system. It is a different system of medicine or whatever you can say to harass people, right? तो पंडित जी said मेरे पास भेज दो, मैं ठीक कर दूंगा, कोई बात नहीं है. Later on, when I came to know truth of this patient, पंडित जी told me कि ये किसी रिश्तेदार ने करवाया हुआ था. जो आदमी ये मैजिक कर रहा था वो शमशान घाट में बैठकर एंड धूप बत्ती की गोलियां बनाता था. धूप बत्ती की गोलियां वहां शमशान से बैठे बैठे उस लेडी की आंख में पहुंच जाती थी. पंडित जी डिड द ट्रीटमेंट एंड दैट लेडी बिकेम ऑल राइट. और लास्ट जो पीस आंख से निकला वो धूप बत्ती का बुझा हुआ टुकड़ा और कुछ थ्रेड्स आंख से निकले. एंड फाइनली दैट लेडी बिकेम ऑल राइट. तो देयर इज प्लेस फॉर दीज पीपल ऑल्सो इन द सोसाइटी. समटाइम्स वी शुड थिंक कि भाई मेडिकल साइंस से ही सब कुछ क्योर नहीं होने वाला है. तो जस्ट ए स्टोरी. थैंक यू वेरी मच.
Thank you all for being here throughout the session today. And 2 days, which was a really twist and turn in terms of weather as well, and the scientific sessions also. Circumstances, all twists and turns. Yeah. Thank you, Dr. Mangesh Dobega sir, for being there throughout the session online, and all the participants on Zoom meeting. So before concluding or proceeding for the valedictory function, I would request Dr. Sukhdeep to call upon all our pharmaceutical partners who have been generous enough to sponsor us, and without them, their support, this event couldn't have been possible at all. Thank you all for that. We will call one by one. And I request Dr. Rajesh Tiwari sir to give them a token of thanks.
May call upon the pharmaceutical trade partners, please. Thank you so much. Zicon Pharma. Klitsch Healthcare India Limited. Please come, sir. Mankind Pharma. Centis Pharma. Centis Pharma. Centis Pharma. Remed. Abbey. Ajanta.
I request all the pharma companies to come forward a bit.
Sun Pharma. Neomedics. Protec, Intas, Essential.
Protec Pharma, Essential Pharma, Lupin, NRI, and Mr. Sandeep Sharma. Microlabs. Microlabs. कोई मिस आउट तो नहीं हो रहा है?
और कोई फार्मा कंपनी से अगर हो जो रह गए हो अभी?
And a special thanks to His Highness and Akriti, who physically couldn't be present here, but still they supported us. Can we call all the pharma companies to like representatives for a group photo?
आइए सब लोग आइए।
स्क्रीन हटा दो। वीडियो फार्मा शर्मा
That's a wrap. Thank you all.
Thank you very much.